Okay. I declare open this public hearing of the Standing Committee on Health, Aged Care and Disabilities inquiry into the health aspects and impacts of alcohol and other drugs in Australia. I'd like to acknowledge the traditional custodian of the lands from which we meet and pay my respects to their ancestors and elders past, present and emerging. I extend this respect to all Aboriginal and Torres Strait Islander peoples and their cultural and spiritual connections to Australia's lands and waters. Today's evidence may include material that some people may find distressing. We encourage everyone present and those listening online to prioritise their own well-being and seek support if needed. In accordance with the Committee's resolution of the 21st of August 2025, this hearing will be broadcast on the Parliament's website and the proof and official transcripts of the proceedings will be published on the inquiry website. I remind members of the media of the need to fairly and accurately report the proceedings of the Committee. I remind all stakeholders who are present before us in ensuring the safety and privacy of individuals during these proceedings. This includes avoiding the use of names or identifying details when referring to other parties, particularly children, and ensuring that any discussion is respectful, appropriate and consistent with our shared responsibility to maintain a safe environment. I now invite members of the Committee to introduce themselves. Starting from you, Sam.
Sam Birrell, Federal Member for Nichols in Northern Victoria and Shadow Assistant Minister for Agriculture and Regional Education.
Monique Ryan, Federal Member for Kooyong in Eastern Melbourne.
Mike Freelander, Chair of the Committee, Member for Macarthur in Outer South-Western Sydney.
Alice Jordan-Baird, Federal Member for Gorton, Member for Western Suburbs.
Ailey France, Member for Dixon in Outer Brisbane, Queensland.
I now call representatives of the Alcohol and Other Drug Consumer and Community Coalition to give evidence. For the Hansard record, could you please state your full names and the capacity in which you appear before the Committee?
Alex Arpino, Executive Manager for the Alcohol and Other Drug Consumer and Community Coalition.
Ben Kane, Lived Experience Representative.
I'm Alice Guest and a Lived Experience Rep for AODCCC.
Thank you. Although the Committee doesn't require you to give evidence under oath, I should advise you that this hearing is the legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I would now like to invite one of you to make a brief opening statement before we proceed to discussion. To assist with the transcription of the public hearing, it would be appreciated if you could please state your name before responding to any question. And I now invite representatives from your organisation to make a brief opening statement before we proceed to discussion. That's all the official stuff we've gone through. Please don't feel intimidated. This is not meant to be an inquisition. We just want to hear what's happening on the ground, and we're very grateful for you appearing in front of us today. So without further ado, I'd like to invite one of you to make an opening statement.
Thank you. And thank you for the opportunity to appear this morning. I'd like to begin by recognising the individual and collective expertise of people with a lived and living experience of alcohol and other drugs. We honour the emotional labour, the vulnerability and the strength when coming forward to share their stories and experience, often at their own cost, in the interest of building meaningful connection and understanding to help inform change. Our submission and opening statements are amplifying these voices. The Alcohol and Other Drug Consumer and Community Coalition is the peak lived experience body for consumer systemic advocacy in Western Australia. We represent more than 990 members with lived and living experience of alcohol and other drug use, including family, carer and significant other, treatment, harm reduction and the systems that surround them. At its core, our message is clear. Alcohol and other drug use must be treated first and foremost as a health and social issue, not a moral or criminal failing. Stigma, discrimination, fragmented systems, a lack of and under-resourced services continue to impact preventable harm to individuals, families and communities. Our call to action begins with the need for a system-wide approach to addressing alcohol and other drug-related stigma and discrimination. Stigma associated with alcohol and other drug use remains one of the most significant barriers to help seeking. It exists not only in the community but within healthcare, social services, child protection, housing, employment and justice systems. It undermines public trust, discourages accessing support and exacerbates poor health outcomes. Our last 2 annual membership surveys found 85% of participants have experienced stigma, discrimination or shame in relation to alcohol and other drug use. Members reported experienced judgmental treatment at oral health care centres, dental clinics, dismissive or contemptuous attitudes from emergency departments and hospital staff, being labelled drug seeking despite having legitimate medical needs. This has led to some members opting not to disclose drug use in health settings to avoid stigma, prolonging and compounding health issues. The World Health Organization has acknowledged illicit drug dependence as the most stigmatised health condition globally, and alcohol dependence is listed at number 4. Public education, AOD literacy, policy reform and lived experience informed workforce training must work together to address this preventable barrier and shift attitudes. Second, we call for the implementation and regulation of a national quality framework of alcohol and other drug treatment services, applying to all AOD service providers, regardless of funding source. Consumers need to be assured there are consistent standards of safety, quality, transparency and accountability. Unregulated services are a present risk to an already highly vulnerable cohort of our community. Safeguards are needed with robust, accountable consumer complaints processes and real penalties for breaching standards. Regarding current services across the AOD sector, our members report uneven access, poor system navigation and inconsistent value for money. Residential rehabilitation services are often unaffordable or inaccessible, especially for people not receiving Centrelink benefits or those at risk of losing housing while in treatment. Private services are prohibitively expensive and do not consistently deliver outcomes that justify their cost. We call for enhanced family and supporter services. AODCCC members identifying as family, carers and significant others report they are often left unsupported in crisis. These supporters are the safety net of our community long after services close their doors. Whether services bring them to the table or not, they continue to be present for their loved ones and in need of understanding and support. We see this as an essential holistic approach to addressing AOD harms. Importantly, our members emphasise that no single service model works for everyone. A diverse mix of harm reduction, pharmacotherapy, psychosocial support, peer-led services and abstinence-based options must be available within a national consistent framework. Third, we strongly support the expansion of harm reduction strategies, including needle and syringe programs, take-home naloxone, drug checking services and supervised consumption environments. These programs save lives, reduce harm, while also increasing engagement with health services in a non-judgmental and stigma-free setting. Fourth, we emphasise urgent action on alcohol-related harms, which continue to cause the greatest health burden of all substances. This includes addressing online alcohol delivery, buy now, pay later schemes, targeted digital advertising, and the normalisation of binge drinking. We urge consideration of proven measures such as minimum unit pricing and as advertising restrictions. Fifth, lived and living experience must be meaningfully included at every level of policy design, service delivery, governance and evaluation. This includes authentic community representation with current grassroots AOD knowledge, cultural expertise, removing barriers to engagement in our highly diverse population. A well-supported and funded peer workforce is essential in providing service users with common ground and genuine hope with navigating treatment in times of crisis. It can be instrumental in addressing stigma and discrimination. Finally, we draw attention to international best practice, including harm reduction-led approaches in Portugal, Switzerland, Canada, Norway, and Scotland, which have demonstrably reduced deaths and improved outcomes. In closing, AODCCC urges the committee to centre lived and living experience, reduce stigma, strengthen national standards and adopt a compassionate, evidence-based approach to alcohol and other drug policy in Australia. We thank the committee for this inquiry and welcome the opportunity to respond to any questions. Thank you.
Thanks very much for that. Deputy Chair, would you like to ask any questions?
Thank you, and thank you all for appearing this morning. It's really hugely helpful to have your input. We're very grateful to you for that. I'm interested in the references you made potentially to sort of preventative measures to protect people from alcohol-related harm. You mentioned taxation. You referred to taxation. Would you be able to expand on that a little bit more?
In terms of minimum unit pricing, the evidence shows that is a safeguard for cheap alcohol being sold in very vulnerable communities. It's a very harmful risk to the community, and if that's tackled at a taxation level, there is evidence to show that that's been very successful, and we've got some examples of minimum unit pricing in Scotland, which they estimate actually reduced deaths caused by alcohol consumption by 13.4% and hospital admissions by 4.1%. Reductions were greatest for men and those living in the most deprived areas of Scotland. There is also estimated that it reduced alcohol sales by 3%. So there is a body of evidence here to show that these initiatives actually work, and AODCCC certainly would support and encourage exploring these options for the community.
Thank you. I think it's an important thing for us to talk about as a committee. I'm also interested in your written submission. You had you talked about the difficulties for people in accessing residential care and the cost barriers for some individuals, particularly those people who aren't receiving benefit payments. Could you just expand on that a little bit?
So what our members have shared with us is the challenge of maintaining a rental property or housing and then requiring to step out of that for a period of time and put their income into the residential rehabilitation phase. So there can be some difficult decisions that have to be made as to whether to give up housing to access these types of services. Things like, for a lot of members of our community, pets are a very important part of their home life and their family. And if they're living alone and they don't have options for pets to go into alternate supportive accommodation or wherever it is, that can be part of the decision, the difficult decision as to what to do to access these types of treatments. So it can be very difficult to navigate that when, particularly when you're in a housing situation with limited income. So that's a challenge.
Sure.
That,
what would you suggest? I mean, people have got to rent. They don't want to lose their rental. What would you suggest that people do to assist with that?
Well, I think that the community needs to work together to provide some leeway to cover some rental costs or to hold accommodation for people, and acknowledging that that's a significant part of their treatment is that housing to have that housing available for them is crucial in their treatment, to be able to come back, have a home to live in, access employment, etc., etc. So to lose that is a massive risk.
Great. Thank you. Thanks, Chair.
Sam, any question?
You answered one of the questions that I had, which was I just wanted to go into a little bit more detail of some of the international experience. So you mentioned Scotland and minimum unit pricing. Is there anything else specific that has struck you about the other countries that you cited of specific things that may be working that we haven't yet looked at enough in Australia?
Look, I think it's really about approaching alcohol and drug harms from a human perspective and engaging in a person-first approach. I think what tends to happen in regards to alcohol and other drugs is that a lot of the campaigns and the media kind of lean into more fear-based messaging. That can actually create a stigmatised outcome for the people that are dealing with alcohol and other drug challenges. So we really need to bring the human forward, the human being forward, the human experience, and understand the function alcohol and other drug use has. And I think if we start at that position, any activities that we engage in are going to be a lot more supportive in understanding the individual's needs. As far as harm reduction options around the world, sorry, just bear with me. I've got some notes.
That's fine.
Obviously, decriminalisation is one of the significant approaches in Portugal, and what they've found is what's important in regards to that, it's not just decriminalising drugs and letting people just get on with their lives. It's actually having health services backing that up, so it's supporting people to enter into health services and support in addition to the decriminalisation. They've seen significant reductions in drug-related deaths, HIV and hepatitis C transmissions, and problematic drug use. So that's been shown to work well. They're able to lead individuals into health services rather than pushing them into the justice system, which is a very important thing. Scotland have been instrumental in rolling out national naloxone programs, which has seen a significant reduction in opiate deaths and overdose. They've also been driving a lot of drug consumption facilities, which has also had an impact in reduced overdose and deaths. They've also rolled out a strategic framing of drug use as a public health emergency under a national mission with a long-term investment plan. So that has seen some positive outcomes for the community. Switzerland integrated 4-pillar drug policy: prevention, treatment, harm reduction and law enforcement. Early adoption of needle exchange, supervised consumption rooms, which has seen a lot of positive impact in reduced deaths. So look, I think there is a lot of evidence that we can look at and best practice models that we can look at, but I think for Australia it's important that we find something that fits our community and our specific needs, and I think in order to do that it's drawing on lived experience and actually engaging the community to co-design all of these options. I think that's probably the main point that we would want to put across.
Thank you.
Alice?
Thank you so much for appearing before our committee today. It's wonderful to have you here. I just have 2 questions. Your submission calls for sort of more accessible translated materials, and I think the stigmas you sort of mentioned of AOD use can be further compounded in diverse communities. Can you expand on where you think the service gaps are for AOD sort of use in those sort of communities, but also in terms of workforce, culturally appropriate care, as well as translated resources as well?
We see that in a diverse community, it's important to actually engage those community members directly and speak, draw out and understand what their specific needs are in terms of access. So again, it comes back to that lived experience informed approach. If we're engaging at the community directly and speaking to those individuals and understanding what the barriers are, it's going to be a lot more accessible and fit for purpose. So I think if regardless of the approach that we're taking, if there's lived experience voices around the table, we're going to be far more effective in supporting those communities. So when we're talking about culturally and linguistically diverse communities, obviously there's language barriers, there's cultural barriers that we may not understand, and it's important to bring those individuals to the table to really understand those concerns. So that would be our message to that.
For sure, and thank you. My second question sort of picks up on what you're saying. My next question is for Mr. Kane and Ms. Guest. Would you be comfortable sharing your stories with this issue and what changes you'd like to see in the system to better support people with lived experience?
So I've got a background of experience with drug and alcohol use for approximately the last 10 years or so, and accessing services in the community and residential detoxes and rehabs. A major thing that I've noticed is, like you said, accessing services. There's limited services. They often have very strict exclusion criteria, which turns people away, or they can't access a service. Also, it's just not enough suitable services themselves to fit what people need. So even the services that are available aren't effective. What else did I write down? One moment.
Is that in terms of flexibility, what you're talking about there?
In terms of just the way the services run, what that person needs, meeting them like where they're at, not having to require them to be this or that to come to the service to receive support. And there seems to be a big gap and like a disconnect between the services themselves, so they don't work collaboratively in my experience anyway. There's a disconnect of some sort, and then you get passed around and it just doesn't work. And what else? Also, there's often like a lack of support, like post, say, rehab or detox that I've noticed, where like a follow-up. So people are kind of just left, and that is often where people then go back, obviously sometimes worse, and there seems to be a lack of support from transitioning from a detox or a rehab centre back into the community or back into their usual lives, and they don't look at anything else apart from the drug use. But you can't really treat that without looking at where the person's returning to, the environment that they're going back into. Like, how can you treat that without looking at what that person's going back to, whether that's housing, their mental health, abuse, whatever it is. That is why it fails, because you're looking at one issue when you should be looking collectively to treat that issue, if that makes sense. And yeah, I've just noticed that like a lot of, within the healthcare service, I've personally experienced a lot of, well, blatant discrimination, stigma. I've had my health dismissed due to drug use. I've had legitimate issues and things that have been disregarded just for that sole reason alone, which then makes me not want to go back to receive help the next time. And that seems to be a very big issue. And I don't understand why that is still an issue, if that makes sense, because everyone seems to agree on, have a shared like opinion of what needs to change and why it doesn't work, but that doesn't seem to be a major shift that I've witnessed anyway. Yeah, the main things are stigma, the exclusion criteria, and the model itself, the way services support that person, and the disconnect between the services themselves. But I'd say the stigma is probably number one, and access close second, in my experience.
Thank you for sharing your first-hand experiences. They're really powerful. Mr. Kane, would you like to add anything?
I grew up in the remote outback in the Pilbara. A lot of people, people up there don't get a mention. There are absolutely no services. So a lot of people that I grew up with because they couldn't access service, or they had to come to the city to access services when they eventually went back to using and committed suicide. It's a real thing, and I'd like to bring that up because the remote outback and all around Australia, I don't think it's just unique to WA. It's a problem, that people have to come all the way to the city, and then they've got to have, like Alex just said, they've got to keep their house up north, which is obviously very expensive. So one of the things that I witness a lot, I am an AOD peer worker on the ground with homeless healthcare. We provide services to the homeless and people that want to enter detox. So one of the things we see a lot is stigmatisation, where people will present to an emergency department and they'll be refused treatment, maybe because of their previous drug or alcohol use. So what will happen is they just will not engage because they fear being judged. And I'd just like to see, a meaningful change where we get a voice at the table. Like, we, for too long, have been spoken to, spoken for, spoken about research when we can do all those things ourselves. We're human beings, and I really appreciate you hearing us today. And we just like to, the stigma is the biggest thing of people accessing services. There also is a clear lack of funds for people and who gets prioritised into those services. I also see a lot of Indigenous people. They have a lot of issues accessing services as well. And unfortunately, prison becomes probably the only place where a lot of people can access treatment, where they can get the continuity of service, which is, it's a sad thing. It's good that they get treatment, but it's sad that it has to take place there and not in the community, which is a lot less expensive to deliver. And I'd just like to say thanks, and I just thank you so much for listening to us and hearing us today. It means a lot.
Thank you so much for sharing. It's really powerful and will be really important for our community's report. So thank you again.
Can I just add one thing to it? Also, another thing that's probably one of the main issues is the how people have a coexisting mental health issue along with drug and alcohol use, and everyone seems to acknowledge that, and the research backs that up. Yet, very limited services will deal with both, so they'll require you to be X amount sober or whatever before they will treat that issue, and vice versa. And that has been a big issue with myself, with accessing any sort of support. Go to mental health and they say stop the drug use, and then other way it's the same, which I'm not sure the exact percentage, but it's a very high number of people that use drugs and alcohol also have a coexisting mental health issue, and there doesn't seem to be any effective services that treat both, and I struggle to understand why, but that's probably another big issue I just wanted to highlight.
Yeah, I don't want to be rude, but do you have a family?
Do I have a family?
Yeah.
Yep.
Did you find that difficult negotiating the system when you've got children to think of? And
Sorry, what was that?
when you have children, sometimes people avoid getting support because they worry about what will happen to their children.
Oh, sorry, I misinterpreted your question. I don't have children of my own.
Right.
Yep.
Sorry. Yeah.
That's okay.
Sorry. Okay.
Thank you all for coming along today. I was actually going to ask you directly that connection between mental health and getting access to support, and how the two systems work together. So it was really great that you raised that. Could you, the exclusion criteria, could you give us some examples of the exclusion criteria, but also like the main barriers? I know you've described them, but just in a bit more detail in terms of the mental health side of things, and navigating those two systems separately.
So in terms of the exclusion criteria, do you mean, or both, and also accessing?
Yeah, well, just some examples of the exclusion criteria. I have no idea about the exclusion criteria. So
homeless, not homeless, not been suicidal or attempted suicide in X amount of time, too complex. I've had that one a lot, or too complex. What's another one? I think I've got some written down. 1 second. sorry, I'm just trying to find where I've written this down.
I can give
Yeah,
an
you
example.
can.
So where I work currently, they've just opened a new facility that we're working in partnership with our two other agencies. We found that we were having extreme difficulties, like Alex said, placing people with mental health and homelessness and drugs, like all those comorbidities. People were not accessing services because they were deemed too difficult to deal with, because the service would either provide detox, but it wouldn't provide assistance for mental health. It would provide detox, but it wouldn't provide assistance for homelessness. So homeless healthcare is the first service of its kind in Australia to provide that. And we just opened a new facility where people with mental health, homelessness and AOD issues are prioritised to get care. So there's a wraparound services, there's GPs, there's nurses, there's peer workers, which I am, there's case workers. So, but unfortunately and it's the first of its kind in Australia, but unfortunately it's a 12-bed facility. So where I work at one of the other facilities, we are constantly having people coming there, and then we're having to put them back on the street because there is nowhere that will take them because of the complex needs. And it's just a revolving door that ended up costing the taxpayer probably 5 to 10 times more than it would if there was a service they could access. So it's having those complex needs. So I think that's probably a real big gap that we could work. And also people with disabilities. I myself have a physical disability, so I know when I access treatment services, I suffer from chronic pain. When I accessed it, I was placed on the registered drug act, so I was taken off all my medication, which led me back to relapse after like 3 years of being clean. Thankfully, I got back. I had a good doctor and a good pain management specialist. I got back. So it's things like that. You're just deemed too complex, and we find that probably the people that need the most help are the ones that we're putting back on the street the most, which is a real shame.
Seems like a missed opportunity because, you know,
Definitely.
the opportunity for somebody to come and ask for help and then to be rejected.
And then to be
is just
stigmatised, because that's what it is. It's
awful.
stigma. They're not being accepted because they're too complex needs, which is crazy.
Yeah.
Another thing that I was going to mention is there seems to be like a stain on your name, essentially from any notes or previous interactions you've had with services. Like I've gone to services that I've been referred to, and before even speaking to me, they've denied my referral due to what notes or whatever is documented about me from a previous time or whatever, and it seems to follow you, and it doesn't seem to be possible to get rid of that, or completely anyway. People I've never met, there's no reason that they would have to deny me, but because what they read on whatever system or notes about me, they seem to run with that, and that's a big issue with going to a new service or trying to get a different support from elsewhere.
Thank you.
Mr. Birrell.
That was going to be the same question I was going to ask Ali. So it was. It does relate to the what's I think struck us possibly all is the exclusion criteria, and that the person's not being dealt with in a holistic manner. In that there's alcohol, drugs, mental issues, probably other things too that are all, you know, could have happened at different stages or different causal links between the two of them. But I suppose just to sort of to drill into it a bit more, that exclusion criteria. Are you saying that there are people who are going to have a mental illness dealt with, and the medical services are saying, well, I'm not going to deal with that until you can prove that you're sober or clean or whatever it is?
Yeah.
Whereas that...
Yeah, that's what I see every day.
Yeah.
at work.
Yeah.
People, particularly people with disabilities, are being turned away because they don't have this. They'll say we don't have the service, that we can't provide a service, and so they're on the street. They want to get clean, they want to get help, they want to get like a wraparound service, but they can't access it because they're deemed, you know, too challenging, their needs too extreme.
So I've heard this talked about in some community projects that I've in my own electorate that I've been talking about that hopefully are going to be built. And they talk about, in a crude sort of sense, a one-stop shop or a no wrong door, a facility that when you walk in, there'll be It won't be a referral where you have to wait 3 weeks or go
Yeah.
somewhere else. There'll be someone in there, perhaps in a collaborative way, to deal
Yeah.
with the person. Is
That's
that part of the solution?
That's awesome. That's exactly what you need. Like we're like basically handcuffed by our funding as well. Like we have to deal with certain people, and so people are triaged, and sometimes we're taking the most easiest people we can because you want service outcomes as well. But if you don't have a facility to send someone with complex needs, the only option we have really, unfortunately, is to put them back on the street once they're medically cleared. They're back on the street. So it's just costing it's just a revolving door costing the taxpayer like probably millions that could fix with the solution that you've just suggested.
Yeah.
If I could add to that, I think one of the other core challenges is retaining that area of expertise under a shared banner, because alcohol and other drugs is a specific area of expertise, as is mental health, as is peer work, and ensuring that those streams are supported and strengthened under one banner. I think that can also be an additional challenge. It's not a one-size-fits-all approach under one banner. It still requires that level of complexity and expertise within it.
Well, I want to explore that a little bit if I can. We've had some models of care over many, many years that revolve around residential management, which I think one of you have already said. I think, Ben, you said that it's very expensive, and it is indeed
Extremely expensive.
very expensive. Is there a more up-to-date approach that would look at outpatient, outpatient management rather than residential management, and using community resources like drug and alcohol nurses, GPs, digital platforms?
As I mentioned in the opening statement, our members are really calling for a diversity of options, because a one-size approach won't work for everyone. So outpatient, very important, residential, very important. It's providing those options for the community. I think some of the challenges, it's those intersecting issues that are the challenge as well, around housing, access to housing, security, employment, etc. So
all the social
the challenge with
determinants of
alcohol
health.
and other drugs is so many intersecting points that come in that add to the issue. So it's really around finding that person-centred approach and understanding the individual that you're working with, and then tailoring the supports for that individual. So it does take time.
Is there a role for a drug and alcohol nurse navigator?
Definitely. So where I work, it's basically nurse. It's a facility. We have wraparound services. So the facility that I just told you about, that is the 12-bed facility that targets people with AOD mental health. One of the things that we've had is they get excellent care when they're in there, and the services wrap around. But then when we find a permanent housing and they move into the house, we're finding high relapse, and they're going back into homelessness. So there's nothing back in the community, because once they leave our service, that's it. Our funding stops.
Yeah.
So like the other day, we had a guy who'd been with us for 18 months. He'd been clean the entire time. We found him a really nice house, and within, I think it was like 4 days, he'd rang us up and said, "Can you come back and get me?" But we couldn't even go get him, so he's back on the street. So it's just it's finding a service that connects with them in the community again. We do. It's led by nurses. So for instance, tomorrow I go around the street with a nursing team and a social worker and engage with people on the street, provide medical health care, do a triage, and then refer them to services, not just ours but others as well. And we find that really effective. But there's people, it's once they leave the treatment as well, that's where we're having the biggest problems, because there's no services once they leave the treatment. They're put back on a GP who may not have seen them for 18 months, because once they're with us, they can only see the GP that we see. So it's a bit of a challenge.
So there's a disconnect between
a big
community
disconnect, yeah. It's an awesome service, but it's when they're put back into the community, they're just basically left to their own devices, and there's no support there, unfortunately.
I mean, it has been brought up a bit with us about things like digital platforms.
Yeah.
Is that a reasonable thing to look at, or do you,
It depends on the cohort. It depends like a lot on age, and it's individual. Some people will engage a lot with that, but other people, if they have, they don't have the intellectual capacity or analytical capability to, you're not, so computer illiterate, particularly if they've been homeless for a long time, because they don't have access to the internet. That they may have a phone, but it's usually one that's quite dated. So a lot of the social media platforms and things like that, many of them are unaware of or can't use. So it's finding a service that they can actually engage with once they leave our care. Yeah.
If I could just add to that, one of the points that AODCCC is consistently advocating for is improved engagement with family carers and significant others to build those community connections and bring those individuals to the table to provide a safety net for the individuals when they get back into the community, and bringing those people in to support and wrap around those individuals. And look, we acknowledge that that's not always available for some people. They don't have family, but if we start to look at AOD as more of a community issue and create those community connections, I think that will go a long way in supporting individuals.
yeah. And maybe if I can just ask Alice also, when you've engaged with the rehabilitation services,
Yep.
what happens afterwards? Do you
After
get
leaving the
do
service.
you get follow up, or do you get
In some services, yeah, I've had one service in particular was pretty good with that. I was still engaged in community care after that, and I would still see them regularly following leaving the service. So I'm not. That's kind of where I'm speaking from, is mainly from one particular service. We were fairly good in that respect, and would follow up regularly and provide support to leaving the rehab and detox service, but other places not so much.
right? So, do they help you re-engage with community, look at getting you into the workforce or education or anything like that?
No.
And did you have any engagement with a GP? Did you ever?
With a GP?
Yeah.
There was a GP, that would be linked in. Mm-hmm.
And did they provide support for you, or?
Apart from medical needs, not really. That was kind of as far as that support went with the GP.
Because we have heard from the College of GPs who are keen to engage with in the AOD space.
Uh-huh.
Where I work, we have GPs, but the problem is once you lose the funding, that's it, they're gone. So I'm personally lucky, because I said I have a disability, I've got a fantastic GP, but not all GPs are trained for that, and then they don't get paid for it. So they're doing it on, they might get a bulk billing thing, but they're not going to spend hours and hours on it because it's a business.
One of the things they've asked for is a more prolonged
definitely, that's 100,000%
AOD
needed.
consultation. Yeah, okay, good. Any further questions?
Yeah, can we, I'll put more, please. Can we circle back to the issue of Centrelink payments and how people's qualification for them or non-qualification for them affects their ability to access services? Could we talk about that a little bit more?
I can give you a specific example. So right now, where I work, we have a former, she's a nurse and she's Kenyan, so she doesn't get Centrelink, so she's at our service and she's in Australia for 10 years. So the only way she can get money is to quite literally walk around 12 hours a day and collect bottles to make money, things like that. But we also get people who are on Centrelink. It's, the money they have in there will go usually to a lot of the services. But the service where I work is actually free. It's the first kind of it in Australia where we don't take any of their Centrelink, where a lot of other services will take up to 95%, some people 100% of their services. So we encourage them to save the money while they're in the facility. So if we can't find them accommodation, they've got enough money to find accommodation themselves. So we're all about agency and building the people up. So if they do leave or, we can't find them a house, they've at least got enough money to secure short-term, to medium-term accommodation.
Would it be fair to say that financial constraints would limit many people from
100%,
accessing services?
Yeah, 100%. Because if you don't have, like, if you have access to private healthcare, like, you can pretty much go wherever you want. You know, you can get whatever service you want. You know, but where if you're stuck on the Centrelink, it does really limit it. There are longer wait lists for things like that. Like, if it's a private facility, the wait lists are pretty small because you have the money. It's a pay-for-use service. But I think that's something that really needs to be addressed, definitely.
Okay. Thank you.
Good. How do people get access to your services?
So we're a systemic advocacy organisation, so individuals can access all of our, become a member, which is a free membership. They just go to AODCCC.org and able to become a member and be part of the conversation, and we capture their voices and experiences. We have a number of reference groups, opportunity to contribute to submissions. We provide training, etc. So that's our organisation as a systemic peak, and so we try and remove as many barriers as possible to have people come to the table and be part of this very important conversation.
And you taught us how to utilise our lived experience and monetise it. So there's been a massive expansion in peer worker roles, which is really good because co-design is really important. Like I said before, for too long we've been spoken for when we can speak for ourselves, and having a seat at the table, like, we really appreciate that. But I think it'll drive meaningful change if we're a part of it, because while people might learn things at university, like I've been to university myself, but when you're on the ground and you see the reality of it, you might have a model, but it's not usually what we're using on the ground. We're just using whatever works.
And you work in the community?
Yeah.
Is there anything you'd like us to take home from your appearances
just to
today?
be open to new approaches, like that's a thing. Like what we're doing is like I said, an Australian first. Like the AODCCC for me was an absolute lifeline. Like it gave me the confidence to understand that I could go there and not be judged. No one's ever judged me. I got paid to attend, which was, I'd been on the disability pension for 15 years. I had a surgery and I was able to return to work. So the AODCCC, I met my boss literally at one of the reference group meetings. So it's, networking pays off.
Yeah. Good. Alice, is there anything you'd like us to?
Just trying to think if there's anything else. Kind of just similar to Ben, just highlighting the impact of lived experience and kind of having not as like a token kind of voice, but really included in decision making at every level, I think will help a lot, and including lived experience just at any decision making and framework, policies, everything, and trying to think if there's anything else I've not already said.
Okay.
I think that's everything.
Good. Well, thank you all for coming today. It's been very interesting, very informative, and we really appreciate you giving us your time today. If you've been asked to provide any additional information, could you please forward it to the Secretariat within the next 2 weeks. You'll be sent a copy of the transcript of your evidence, and we'll have an opportunity to request corrections to any transcription errors. And once again, thank you so much for appearing today.
Thank you so much for having us. Thank you, really appreciate it. Enjoy your time in WA.
We will. You put on some nice weather for us. Good. Thanks. Good. I'd now like to call representatives of the Drug and Alcohol Nurses of Australasia to give evidence today.
They'll be appearing online.
Oh, they're online, are they?
Are they on? Great. So if you'd like us to, we can move on. They are ready to go.
Good. Good morning.
Good morning.
Yes, we can hear you. I'm Mike Freelander, Chair of the Standing Committee on Health, Aged Care and Disability. I'll get the rest of my committee to introduce themselves.
Sam Birrell, Member for Nichols in Northern Victoria, Shadow Minister, Assistant Minister for Agriculture and Regional Education.
Monique Ryan, Member for Kooyong in Inner Eastern Melbourne and Deputy Chair of the committee.
Alice.
Alice Jordan-Baird, Member for Gorton, Melbourne's Western Suburbs.
Ailey France, the member for Dixon in Queensland, Northern Brisbane.
For the Hansard record, could you please state your full names and the capacity in which you appear before the committee?
Yes, my name is Brendan Clifford and I am the Vice President of the Drug and Alcohol Nurses Australasia.
Thank you. Although the committee doesn't require you to give evidence under oath, I should advise you this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter, may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I'd now like to invite you to make a brief opening statement before we proceed to discussion.
Thank you. As I said, I'm the Vice President of Drug and Alcohol Nurses Australasia, Dana, and I'm a registered nurse with a background in clinical care and academia. Dana is the peak group for nurses working in AOD in Australia and New Zealand. Drug and alcohol nurses are a highly committed, skilled group of professionals working at the intersection of physical health, mental health and social need. We provide AOD harm reduction, treatment and rehabilitation services in acute and community settings and work across systems to support professionals in other specialities such as emergency medicine, perinatal health and infectious diseases. AOD nurses provide care in settings as varied as injection centres, pill checking services, small country hospitals, inner city emergency departments, maternity services, and clinical research units. Through our national conferences and our regional forums, Dana hears directly from nurses across Australia about the realities of care on the front lines. Barriers to integrated care, workforce shortages, service gaps, particularly for First Nations.
We'll start with you, Ali.
We also see a lot of innovation to meet these challenges. We undertook a study of the AOD nursing workforce in 2000 and repeated our survey component of that study in 2004. Our survey data show a workforce that is highly qualified and working autonomously, but also one that is ageing and under sustained pressure, particularly in regional and remote areas. Stigma is a major factor affecting not just our patients, but also our workforce. AOD nursing is frequently undervalued as a specialty, and that impacts recruitment, retention, and investment in training and career pathways. While AOD work is increasing in complexity, our nursing workforce needs more investment to keep pace. I know nursing had the highest vacancy rates of all the professions surveyed in the New South Wales AOD workforce census in 2022. Dana currently undertakes credentialing, clinical supervision, and leadership development programs. And in addition to supporting these efforts, we would also recommend building co-designed AOD content into undergraduate nursing education to build knowledge and enhance non-judgmental attitudes across the nursing workforce. The implementation of post-registration programs which provide structured, supported opportunities for graduate nurses and career pathways into specialist practice. Supporting advanced practice nursing roles and nurse-led models of care, including nurse practitioners and registered nurse prescribers, both in AOD specialist care and in other settings, such as primary care and mental health. The evaluations of models of integrated care so that AOD-related needs continue to be recognised and afforded expert care in pressurised health systems. And a national approach to workforce planning that includes the unique challenges of AOD nursing as a specialty. Nurses are well placed to provide non-judgmental and expert care to prevent and address AOD-related harms. We support health-led, evidence-based and non-punitive approaches to alcohol and other drug policy, and strongly believe this can only be meaningfully achieved in partnership with people that affects the most, people with lived and living experience. Thank you for this opportunity to participate in this inquiry, and I welcome any questions that you might have.
Thank you. Ms. France.
Thank you so much, Brendan, for giving evidence to us here today. We really appreciate it. I'm interested in the voluntary credentialing and just your views on whether there should be compulsory sort of education within a tertiary setting, and how that would help in terms of stigma. So not just providing more specialised services across the board, but in terms of how that would support. And do you actually support compulsory, courses within tertiary settings for health professionals?
Yes, I mean, I recognise how pressurised health professional curricula are at the moment. I would say that we need to have mandatory drug and alcohol education in those curricula, but it also needs to be supported out in the workplace, because once you go from university or your education provider into the workplace, that's where you will meet more stigmatising approaches. So we actually need to, you need a systematic approach to it, not just a module in an undergraduate course. I think you make a good point around stigma, because knowledge itself won't address stigma. There has been some good research done recently at Western Sydney University, where Dr. Mark Goodhue has developed education that's co-delivered with people with lived experience. And I think that's a very good way of not just imparting knowledge, but also the attitude changes that are required for people who are encountering or beginning to encounter harms from their substance use. When they start entering into health systems, it's generally not to a drug and alcohol service in the first instance. It will be to their primary care provider, or it will be to an emergency department. So we need to have a minimal skill set of AOD care that all professionals feel equipped to ask the questions and know what to do with the answer. Because I think health professions are very good at helping people when they feel supported to provide that help. Yes, I think I've answered most of your question there.
Yeah, thank you. That was helpful. Thank you. That's all from me.
Alice?
Thanks so much for appearing before our committee today. My question picks up on Ms. France's question. There's no doubt nurses play a really important part and an important role in the AOD space, and you sort of noted the issues with the ageing population and sort of sustained pressure on the workforce. How do we encourage more nurses to specialise in AOD? Is it through sort of Ms. France's suggestion, or is it through further incentives? How do you see that playing out?
So I think those exposure to AOD content in undergraduate and as a new graduate are really useful in just addressing some of the myths around AOD care that can be pervasive in the community, and then that feeds into our health workforce as well. So things that, that it's a meaningful area of healthcare with outcomes can be something that people don't believe when they first encounter it. So that initial entry into the health workforce needs that bit of support. We also need to have a career pathway that has development opportunities along the way. So currently, I think there's only 2 graduate certificate courses to specialise in drug and alcohol care for nurses, and one is only nursing specific. So we need more education opportunities that are specifically for nurses. And we also need to have funded positions that are attractive to nurses to stay in the position, to stay in drug and alcohol sectors to achieve those. So things like nurse practitioners are a really good way of not just delivering care, but enhancing the attractiveness of the speciality to people. We also have the opportunity for, we undertake credentialing as a way of raising the profile of the speciality, and that also supports nurses to feel expert in their practice. When you're comparing AOD nursing to specialities like theatres or emergency or critical cares, it can undermine people's confidence that they're providing really expert care, because it's not as technology dependent. But the work of engaging with somebody who feels huge amounts of shame or stigma, having a good knowledge of the physiology of what's happening but also the social context in which that person is trying to meet their needs is actually quite skilled. And we need to remind not just nurses, but the community that this is incredibly skilled work that we're doing. So things like support for credentialing, educational opportunities, and those positions that are really well recognised for the work that they're doing. So in addition to nurse practitioners, there's also kind of nurse navigation roles that are often clinical nurse coordinator positions, and they do really essential work in terms of bridging system gaps. They'll work across systems, and that is very interpersonal work because you need to build relationships with people, and there's no, and that it's very human work in that way. And recognizing that as expert work, not just something that you can do with an undergraduate course, I think that is also something that will attract people into speciality.
Do those nurse navigator roles that you just mentioned support sort of people in outpatient settings or within care?
So there isn't a like standard typology of kind of those nurse-led models. Nurse navigators I'm using as a term to kind of look at the ways in which nurses work into other systems. So you might have a nurse that works in a withdrawal management unit, for instance, whose work is AOD care and their patients are there. But there's lots of other models of people that are, of nurses that work across systems. So in a hospital, you'll have consultation liaison services where somebody might come in with an injecting related infection, for instance, and they'll be seen by a drug and alcohol nurse during that admission. You will have nurses that go down to the emergency department and talk to patients there. There's nurses that, in New South Wales, there's GP liaison nurses that will go from the hospital to work in GP practices. We also have nurses embedded within homeless health teams, for instance, that provide drug and alcohol care there. So there's lots of models that are being innovated in this space because nurses are very good at seeing local problems and devising local solutions. They can be very fragile though because they're dependent on short-term funding from PHN, and they're also really dependent on the goodwill of those nurses to go above and beyond what their position description says, because to advocate for those patients in systems that are often highly stigmatizing is a huge amount of emotional work. So the other thing that I think is really important is we talk about clinical supervision, and we have a small program that we're trying to run through our organisation, but supporting nurses to work in with the high degrees of trauma that can be experienced by this population, vicarious trauma, but also how do you continue to advocate for patients in systems which don't recognise their problems as health problems. I think that's another thing around clinical supervision and why that's important for that kind of nurse navigation role. It can be highly challenging work when you're dealing with services that would much rather not have to deal with your patient. And I recall a nurse practitioner I spoke to once, for instance, who was working in a homeless health service, met a client whose anxiety was increasing, and people were, and it was being attributed to his mental health and substance use. But when she listened to his chest, she found that actually he wasn't breathing well, and he actually had developed lung cancer. And she was the person that identified that. She thought broader than mental health or substance use. She used the biopsychosocial model that nurses use and thought, what else can be going on here? So she referred him into treatment, which was good. So unfortunately, it was too advanced for long-term outcomes, but that person got to experience good Australian healthcare towards the end of their life because of that. And I think that shows what nurse navigation roles for AOD can achieve for this population.
Most definitely. Thank you. No further questions, Chair.
Monique.
Thank you. I really appreciate your input this morning. Can I ask you about voluntary credentialing for alcohol and other drug nursing services? Is that a useful endeavour? Does it contribute to improved health outcomes and professional recognition for those nurses who engage with it, or what are your feelings about voluntary credentialing?
So, I think so. The evidence is kind of, nursing research doesn't get a lot of funding to do this type of work, to appreciate whether, what would be the best approach to do this. Nurse credentialing in Australia, there's only a few groups that do it, and it's got it really depends on if it's rewarded or not. Nurses as a group are very busy at their jobs. Their professional development opportunities might not be supported by organisations, and they often don't have the kind of disposable income to invest in their own professional development. So unless there's a reward for something like credentialing, which if there was greater take-up and expectation of it, might produce those shifts in nursing workforce prestige and the quality of the workforce that is provided to people with AOD issues, then that might help. So I think that's so it probably would help. I don't have any strong evidence for that, and we would need to see larger upscale and reward for it.
Mm. Thank you. So essentially then, barriers to nurses undertaking that sort of credentialing would be cost, and I guess also from what you're saying, availability of the credentialing sort of the higher education sort of training systems as well, or?
Yes. Yeah, we provide credentialing across a number of criteria because we try to make it pretty, because of the nature of the workforce, there's lots of ways into AOD nursing, so we're quite flexible, but it does require postgraduate education to become credentialed. So I think, yeah, the cost of undertaking that can be a barrier.
Okay. But how is it physically done? Can it be done online, or do you have to physically attend training sessions?
So how we credential is basically a portfolio of work. So you compile a portfolio of how you meet the criteria that we've set out to credential you as an AOD nurse. So a number of quality improvement projects, and it can be across depending how much postgraduate education you've had, so it can be a graduate certificate or a master's or a PhD, and so it's quite flexible in how you get it, and the credentialing cost itself is quite, for people is pretty low entry. It's $100 or $150 or so, but the opportunities to develop your career, to become credentialed, are things that will be in the domain of health services or service providers to give to nurses. And often nurses are working in places, if you're running at a staff shortage, for instance, getting the opportunity to go do professional development is something that will stress managers out, and so they might not be provided. And I think that the most important thing is how we incentivize and recognize the value of credentialing. So if you're a credentialed nurse, is it a financial reward in your pay salary? Is it, we would say that you would be better placed to apply for and get more senior positions if you're a credentialed nurse. There would be a lot of scaling up that would be required in terms of the system of credentialing if you were to bring in compulsory credentialing for nurses providing AOD care. And you would also need to take consideration of the fact that nurses, there may be general nurses providing AOD care, there might be general nurses who are providing only AOD care, and then there might be specialist nurses and who provide specialist AOD care. So a nurse on a withdrawal management ward in a hospital, for instance, might not need credentialing for that position, even though they're in an AOD specialty area, but the clinical nurse specialist in that unit might.
Okay, thank you. Yeah, I appreciate that. Thank you.
Sam?
Thank you. The last part of that answer clears a lot of things up to me. It's important that all nurses have some knowledge of alcohol and drug issues, because they're going to be probably exposed to it sometime, but then there'll be people who'll need to have specialisations to deal with that. And so you've explained that very well. Where are the biggest gaps, in your opinion, in the nursing workforce? Is it, or if you were to say, here's the extent of the alcohol and drug issue, but the biggest problem is that we don't have enough alcohol and drug specialist nurses, or we don't have general nurses with knowledge of alcohol and drug issues to be able to deal with them at the first level?
I think probably the most immediate gap would be that specialist AOD nursing capacity. So we're highly skilled, but it's, as I said, it's relatively small, ageing, not growing in line with demand. And so while generous nurses are increasingly encountering AOD issues, they often don't feel adequately supported or trained to respond. So having more specialist AOD nurses also helps that part of it. So growing and retaining the specialist workforce helps build capacity across the broader nursing workforce. And I think that's how you kind of start to begin to see reduced pressure in emergency departments, and really getting those opportunities for early intervention that present themselves in those non-specialist AOD health settings.
So is that another issue? Is it the fact that, so what you're saying is that we need more alcohol and drug specialist nurses, but let's assume that we've got those nurses and services. Is it the ability of people who aren't specialists but should have some sort of training, and if they had that training, they might be able to get intervention earlier than it otherwise would have been?
Yes, I mean, I think that is a gap, but also, so that is a gap, and the both, it's a twofold priority. So you need to have, let's say, that emergency department nurse recognise that this person has a substance use issue, and then they need to be able to refer that person on to the appropriate specialist care if they need it. So, to recognise that somebody has started using methamphetamine but hasn't quite reached the phase yet of recognising that their use is beginning to escalate, that might be recognised, and then they can be referred into a nurse practitioner or a senior nurse-led model of care within that health service. So I would say to sequence it, that ED nurse is much more likely to undertake that kind of work if that work has been modelled to them by a specialist nurse. So to kind of get that momentum going of building a culture of non-judgmental AOD care throughout the healthcare system, I think AOD nurse specialists as champions, working with people with lived experience, with peer workers, is a really strong model to support what, in an ideal world, to support what would have been some introductory AOD care in their undergraduate and some post-registration structured program as well.
Thank you.
Good. Thanks, Sam. I just want to explore a bit more whether you think we have the capacity to have AOD nurses leading community-based rehab services, or we...
Capacity. There's capacity within the nursing scope of practice to do that type of work, for sure. So nurses are highly educated to master's and PhD levels, are highly experienced in terms of the type of care that they've delivered, frequently manage services to very senior levels. So I think it's well within a nursing scope of practice to undertake that kind of work. Whether we've got the numbers would be the question. And
if we don't, how do we get them?
So we've got it's hard to answer the question about numbers because workforce planning doesn't go down to the level of AOD nursing as a specialty.
Okay.
It goes down to, it'll go to broad categories like primary care or mental health
Yeah.
as categories, but it doesn't include drug and alcohol. And drug and alcohol could fit in under either of those and faces unique challenges. So that's one thing. When you look at the best indicators that we have, so the little tick box in the nursing registration, it says that there's about just over 2,000 AOD nurses in Australia, and that's growing in line with the nursing workforce. However, there's that AOD census workforce in New South Wales had a vacancy rate of about 14% for that workforce as well. So there's a workforce shortage. Where that workforce shortage is in terms of acute hospital, community, rehabilitation, treatment or harm reduction, I don't have the granularity to say.
Right.
How we grow it, I think, is those things that we've talked about already. So raising the prestige, that stigma that affects our patients also affects the speciality. And that is through those things that I've mentioned already. Greater exposure to AOD content in undergraduate and new graduate positions, and credentialing to raise the profile of the expertise of drug and alcohol nurses, and also those opportunities for expert practice, so nurse practitioner roles, nurse prescriber roles, and those senior leader champion roles like nurse navigators, but at senior nurse levels.
Right. But it is possible to do, you think?
I think so, but yes, they would, yeah.
The reason I ask these questions is that people focus very much on the residential rehabilitation, and yet we've heard from a number of sources that that works while you're in residential accommodation, but once you leave, there's less and less effectiveness because of lack of follow-up.
So there are nurses working in residential rehab settings. It is difficult to compete with public healthcare settings with the awards that are offered in the awards and the contracts that are offered in the public health setting. So for that to attract nurses into that sector would require, I think, more work on how to adequately remunerate those positions so that they're as attractive as public health systems. To how you link care between those two systems, so residential rehab system and the broader healthcare system, I think nurses do a very good job of doing that, because often they're in places. So if you take a place-based approach to health, but I think is a very sensible way of working in a population where you've got intersecting physical, mental and social needs, those nurses can be really good at being with people for a long time, knowing how to create those linkages between services, because nurses are good at spotting gaps and coming up with a way of meeting with them. And that is kind of that takes a lot of hard work, I think, in terms of not just knowing people, but also working with systems, like I said earlier, where people might prefer to not have patients with the AOD issues. And having a nurse who is based in a hospital but working into a GP practice, or based in a GP practice but working into a residential rehab, I think there's lots of ways of kind of working with systems to bridge those gaps. And I think there'll always need to be kind of place-based, just in terms of resources always vary and needs always vary in places. So I think the thing that is needed is kind of the supply of nurses into those systems to help bridge those gaps.
Great. Thank you very much. Any other questions? No? Good. Well, thank you for giving evidence today. If you've been asked to provide any additional information, could you please forward it to the Secretariat within the next 2 weeks? You'll be sent a copy of the transcript of your evidence and will have an opportunity to request any corrections to transcription errors. And once again, thanks for appearing and giving us your valuable evidence today. Thank you.
Yeah. Thank you for the opportunity.
Thanks. Now, we will now have a short break and we will reconvene at 10:45. No, I didn't go through that, did I? Okay. Thank you for appearing before the Standing Committee on Health, Aged Care and Disability. For the Hansard record, before giving evidence, could you please state your full names and the capacity in which you appear before the committee?
Hi, I'm Rebecca Stephen. I'm the Executive Manager for Strategy, Engagement and Community at Palmerston.
Good morning, I'm Andy Niblock, Executive Manager for Business Development at Palmerston Association.
Good morning, Michael Winton, General Manager of Operations for Palmerston Association.
Thank you. Although the committee doesn't require you to give evidence under oath, I should advise you that the hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of respective houses. The giving of false or misleading evidence is a serious matter, may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I will invite you to make a brief opening statement before we proceed to discussion. To assist with the transcription of the public hearing, it would be appreciated if you could please state your name before responding to each question. I would now just like to invite my committee members to introduce themselves, starting from Mr. Birrell.
Sam Birrell, Member for Nichols in Northern Victoria. I'm also the Shadow Assistant Minister for Agriculture and Regional Education.
Monique Ryan, Member for Kooyong in Inner Eastern Melbourne.
Mike Freelander, Chair of the Committee, Member for Macarthur in South Western Sydney.
Alice Jordan-Baird, Member for Gorton, Melbourne's Western Suburbs.
Amy France, Member for Dixon in Queensland, north of Brisbane.
I'd like to invite one of you to make a brief opening statement before we proceed to discussion.
Thank you. I should do that. Dr. Freelander, Chair of the Select Committee and committee members. Thank you for the opportunity to speak today and to contribute to this important inquiry. It's my honour to represent Palmerston today and provide an opening statement to the committee. As stated, I'm Andy Niblock, the Executive Manager for Business Development at Palmerston Association, and I've worked for Palmerston for around 6 years. Before I continue, I'd like to take the opportunity to acknowledge that I am speaking with you on Noongar Budja today, and to acknowledge the traditional custodians of the land that we're meeting on, the Whadjuk Noongar people, and I'd like to pay my respects to elders past, present and emerging, and also recognise again the strength, resilience and capacity of Noongar people in this land. As a not-for-profit organisation, Palmerston have more than 45 years experience in responding to the harmful and often devastating consequences of alcohol and other drugs. Hereinafter, I'll refer to AOD as the acronym. Palmerston, we see over 7,500 clients each year and families as well. And we have over 220 employees, many of who come with a lived experience, which they bring with them to the workplace. We're really challenged to respond to and prevent the health impacts of alcohol-related harm, and it's a real imperative for Palmerston. Our work across WA spans across 15 community and residential locations, providing broad-ranging treatment, prevention and community development. Everything we do, it's guided by Palmerston's model of care, which really sets out the non-negotiable principles that underpin how we work with people, families and communities affected by AOD. Our central message is that the health impacts of AOD cannot be understood nor effectively addressed in isolation. AOD use and harms are deeply interconnected with broader social issues, including trauma and social and economic disadvantage. It's our view that a whole of government, whole of community approach is required if we are able to make further strides on the prevention front. While specialist AOD treatment is most appropriately targeted to people with chronic and dependent use, the majority of AOD-related harm in the community is actually experienced by people who are not dependent. And alcohol remains the single largest contribution to this harm. But evidence tells us that brief, low-cost interventions and harm minimisation approaches are highly effective for this group. Yet these responses are still not well embedded across mainstream services, often contributing to inappropriate referrals, long waiting times, and people being passed between systems without meaningful support. We submit that a renewed focus on supporting the development of professional and practice capability within the broader human services sector is effective prevention and will serve to reduce the need to always refer to the specialist AOD sector. A defining feature of our client population is co-occurring need, and the majority of people who seek AOD treatment also experience mental health challenges, neurodiversity, histories of trauma, homelessness, justice, involvement, and a range of other needs. These complexities are the rule, not the exception, and the research is clear that people with these intersecting needs do seek help, but too often receive none. We see this not as individual failure, but as a failure of systems that often remain fragmented, crisis-driven, and poorly aligned with the evidence. So Palmerston, consequently, we operate on a clear no wrong door principle, where no person should be turned away because their needs are complex or they do not fit neat funding boundaries. Our model of care is purposefully person-centred, trauma-informed. We seek to support people to define what recovery looks like for them, and we work holistically, recognising that AOD use does not occur in isolation, and we must respond to the full complexity of people's lives. Trauma-informed practice is really foundational to our model of care. It's not a programme, it's a way of working at the very heart of everything we do. We know that AOD treatment works. We see this every day, and in our submission which you've received, we've proudly presented the committee with some examples of the innovative work that we've done in areas such as community-based detox, dental health, and supporting children programmes. We are making a difference, but we know we cannot do this work alone. Investment upstream is in prevention, and community development presents the greatest opportunity for health gain. And our central proposition is that it's only by working collaboratively to reduce disadvantage and build protective factors that AOD use can be effectively reduced and associated harms prevented. We submit policy efforts that are targeted to AOD prevention and broad professional development present a critical opportunity for holistic system-wide change, but only if supported by coordinated policy, flexible funding, and genuine cross-sector collaboration. As a NFP, we rely on long-term funding to provide the right conditions for stability and growth. And the reality is that many of our state and Commonwealth contracts are short-term. Some are 12 months, and the continuation is sometimes only decided weeks before the contract is due to end. So as a result, NFPs like Palmerston often lose good staff, really capable staff to government services where contracts are longer term, where they offer more security, and as an NFP, we're often unable to compete with contract longevity to secure staff on a longer term basis. But with a bold strategic vision, Palmerston were committed to meeting the most vulnerable where they're at. And in recent years, this has meant stepping outside of AOD treatment as we know it, as we recognise that, as we've said before, you can't just treat one thing in isolation. And we work and really are required to understand intersectionality, the belief that individuals are not shaped by one factor alone, and that inequality cannot be solved by just focusing on a single issue such as AOD in isolation. So we've really tailored our services in recent years to meet these intersecting aspects, but this work is not always funded appropriately or recognised in our commissioning arrangements. And we've decided to step into, a brave, bold space to offer more support, more innovative services on Noongar Budget. And this has been enabled by a variety of funding sources, often non-traditional sources such as local government, community funding, and others who, whilst not our traditional core funders, they assist us to allow innovation to flourish within our services. And in closing, I would just like to provide a short overview of some of these examples of some new services. Firstly, as I mentioned earlier, we've had a really successful dental programme for the last 4 years, which we've piloted in our AOD residential services. It's the first of its kind in Australia. And this requires and helps residents in our programs to have access to free dental clinics where we address issues such as fillings, extractions, dentures, and root canals. And by supporting physical health, improving self-esteem and motivation, the programs really help residents to stay longer, often beyond 12 weeks in a program, but importantly restores their dignity and has built hope for the future. Last year, Palmerston, we started a new initiative with short-term funding from the City of Rockingham and WAFA to provide AOD outreach services to street-present populations in Rockingham and Albany. And this has resulted in us working in partnership with GP services, with homelessness specialists, and we've seen an incredible range of people supported into positive health and wellbeing outcomes. And in 2025, we were successful in gaining funding from the state to open a new women's refuge in the town of Katanning in the Great Southern. And this is working in partnership with Katagini Aboriginal Corporation. And this service really expands our integrated trauma-informed support for women and children experiencing family and domestic violence, alongside co-occurring AOD and mental health challenges. Thanks to 2 years of Commonwealth funding, another example is Kadala Maya, which is Noongar for Day House. And this is a 10-week day program for young people aged 10 to 17, living in the Peel Binjara region. The program supports young people to address their substance use and offending behaviours and build confidence, practical skills and connections. And to date, we've seen a range of powerful outcomes, such as young people moving into training and employment, returning as mentors, improving connection to their culture, and reduction in AOD use. And the latest cohort has seen 18 young people screened for 10 places, but many really presenting with some highly complex needs. Lastly, but not least, it's a really exciting time for us, is a recent merger that we've been involved with. And this happened in March 2026 when Palmerston formally merged with Sussex Street Community Law Service to create and embed a health justice partnership within our service system. So this merger reflects the reality that for many people accessing AOD services, the challenges, as I've said earlier, rarely exist in isolation, and they commonly include legal issues such as housing instability, tenancy matters, financial distress, such as fines and debt, family law issues, protection orders, and unmet disability support needs. And where these services have often operated in silos, people are forced to juggle multiple disconnected systems, repeat their story, often relive the trauma, often while delays and escalating stress can increase the risk of relapse, mental health deterioration, and justice contact. And this integrated model is designed to provide a no-wrong-door access with earlier intervention and coordinated support, including shared intake triage and handovers across AOD counselling and recovery supports, alongside legal assistance, financial counselling, housing advocacy, and disability supports, so that legal and practical barriers that undermine recovery and health can be addressed as part of care. Thank you for the opportunity to share, and we welcome ongoing discussion with the committee.
Thank you. Might start with you, Els.
Thank you so much for appearing for our committee today. It's really wonderful to have you here. I'm really interested in AOD use and its impact on young people, so I was really excited to hear about your Kadala Mia Dayhab model. Would you mind expanding a little bit about that? You sort of mentioned the programs for children between 10 and 17, and I was just wondering if you could talk us through the evidence around starting at that sort of 10-year-old age. I'm sure it's very well informed the reason why, but I'd love to hear a bit more about that from you, and I'd love to also hear about the referral pathways on how these children come into the program as well.
Thank you for the opportunity. I'll hand to Mike, who oversees that program. Yeah.
Thanks for the question, and I've just got something prepared, luckily enough. But Kadala Maya is a small program, in my portfolio that is achieving really big outcomes as far as we're concerned. The funding model does sit outside of Palmerston's core funding structure and is currently only guaranteed for 2 years. And after that, we're at risk of the program not continuing. Despite this, Kettle and Meyer reflects Palmerston's commitment to innovation and to future-proofing what we think effective service delivery for young people in that cohort would look like. The co-design process identified the hours between 4 and 8 p.m. as the highest risk time for those young people in terms of safety, vulnerability and risk. In response, the program engages young people, our 10 people at a time, by picking them up from school, transporting them to the program, spending 4 hours with them and then transporting them home. And often the best engagement occurs while we're in transit, and really deep and trusting engagement. Kettle and Meyer incorporates several key features that have proven very successful for Palmerston. One of them is inclusion versus exclusion. So for a lot of the young people, particularly between 10 and 13 years old, they don't suit any program and they are constantly declined because of the risk. We invite the high-risk participants and nominations, and we adapt our program delivery to mitigate that risk. So the program itself is really flexible. We really look for reasons to include rather than exclude. A really important fact for us. And the common denominator for a lot of these young people is rejection from programs and interventions. They're just not suitable for any programs at all. The program actively engages families and significant others as well. It's our belief that we get the best outcomes when we include families or chosen families in people's treatment, in young people's treatment. The program is grounded in the therapeutic community principle of community as method. So we really focus a sense of belonging to the program and mutual accountability. So everyone's responsible for everyone when they're in the program. And we see that overflow even in the schools when we have 2 or 3 participants in our program attending the same school, that they look out for each other and often support each other in their brief intervention or relapse prevention with alcohol and drugs. So while they never engaged each other at school, they now know each other and look out for their own, each other's AOD use, which we think is really powerful. The evidence of the success is not only reflected in the data, but the lived experience of the young people themselves. Many who report a newfound sense of hope, and sometimes that hope is for the very first time, and some direction. Several graduates of this program have gone on to make some significant changes in their life, engaging in training and employment, getting driver's license, just practical things that they never had access to before. Importantly for us, we have 4 of those young people returning to the program as mentors. Really impacting the new young people that are coming through. And it's a part of the TC kind of process about giving back, or reciprocity, if you like. Again, often for the first time. Since implementation, and we're a year into the pilot program, we have supported over 40 of the most vulnerable young people in Mandurah. It is being evaluated independently by the University of WA across the whole life of the program, so it is being progressively evaluated, and the early indicators for us are really encouraging, and we're looking forward to the outcome. In terms of the age cohort, we split the program into 2 because there are different vulnerabilities and learning styles, and also we have to manage the psychological safety. 10-year-olds to 13-year-olds are kept in one group. We have some common activities that would include cooking and preparing a meal and serving the meal, and then they have their own key workers, and they would be doing age-appropriate activities, and our 14 to 17-year-olds would be doing more mature activities such as learning to drive, some sports and some boot camp activities. A lot of the presentation that we see, particularly in the 10 to 13-year-olds, are young people surviving trauma and neglect, complete disconnect from culture for Aboriginal young people, particularly who are living in group homes, food insecurity, so it's really new for them to come into a facility where there is food available and they're all participating in cooking. We call it a sensory experience where we start cooking the food often before they arrive. So when they walk in, they can smell food cooking. And for a lot of those young people, they've never experienced that before. I remember that from being a kid coming in and my mum was cooking, and lots of them come back and comment on that it does evoke a sense of security. A small thing for us, but a really powerful experience for the young people. There's some sexualised behaviour in the 10 to 13-year-old and some young people reporting surviving sexual assault. So we collaborate with specialist services, particularly those services that are mandated reporters, and we work closely in partnership with those people. When these young people finish their 10 weeks program, they have access to ongoing case management as well as their parents, and often that will happen as a group. Small program, big outcomes.
And where do you get the referrals for the program? Is it from schools? Is it from families? How do...
Anyone can refer, and we call them nominations rather than referrals, just to get out of that kind of practice, so young people can nominate themselves. But we have a stakeholder group that we meet with once a month, and we invite nominations from those people. That would be schools, cultural centres, Banksia Hill Detention Centre, Department of Justice and youth justice agencies. And as the program is gaining momentum, that network of stakeholders is really growing.
The police themselves refer? Or?
Yes, they do. Yep. The requirement eligibility for this program is have interaction with police or justice and having an AOD experience, either their own or a significant other's.
I'm just interested in the 17-year-old, sort of the higher age range in the program. How do you support them to transition out of the program in terms of their other, referring them to other sort of support services when they're sort of aged out of the program?
The case management is a really powerful tool for that, and we really walk alongside those young people, particularly the young males. We have a very powerful young youth worker who connects with them really well, and will meet them on their own terms and in their own times, and that works really well for us. So we connect with things, age-appropriate things like martial arts, 10-pin bowling, the activities that they like to do, and we kind of do that incidental counselling alongside.
That's great. What a fantastic program.
Do you pick up kids with disabilities, with fetal alcohol syndrome, for example, or anything like that?
We suspect that we do have that. We don't collect that information,
right.
But certainly open to that. I don't think that there's any exclusion, and we would certainly be looking for a very diverse group.
Right. But what happens if you have a kid there that you think might fit into the fetal alcohol spectrum? Do you have any way of getting them assessed, or...?
We don't have a pathway to assessment,
right.
But within our network in the wider Palmerston, we certainly have those agencies that we could employ. It hasn't occurred yet, but we're certainly open to that challenge.
Okay. Ali.
Thank you all for coming along today. We really appreciate it. I love the sound of that program. It sounds amazing. We've heard a lot about the barriers to access and the exclusion criteria and things like that, so it's good to hear of one door, no wrong door access. What about for adults? And do you have a day hab model for adults, and what are you seeing? Because obviously we've also heard that housing, having to leave housing, cost, different things like that. So can you explain maybe a bit about that?
Yeah, we can. Maybe I can start, and then Mike, who manages those services as well, can contribute as well. I mean, Palmerston has, we have 2 therapeutic communities, which are residential programs, where we offer over 60 bed spaces in those 2 places. And they've been going for many years. So I think, what we're seeing in there is definitely a trend towards, I guess, more immediate treatment. So people are asking for kind of help quickly and wanting to move into these programs pretty quickly, and that's when we have to really be flexible and really look at the barriers that might slow down a referral into some of these programs. In terms of day habs, and it's something that Palmerston's really looking to pilot and innovate more in. We've got the youth example here, but we're really interested in looking at an adult day hab, which I guess there's a cohort of people who may be working, have childcare responsibilities at home that can't commit to a residential program, but they may want to come for, 5 or 6 hours a day for 3 or 4 days a week. And we think we can do some really valuable work alongside people there. So again, it's an innovation. We'd love the opportunity to, I guess, identify funding to try that out in the coming years.
Yeah, okay, thank you.
Thank you.
Thank you.
Good, Monique.
Thank you. We've heard this morning and on other occasions in front of this committee about the difficulties helping people access drug and alcohol services when they have other issues going on, whether that be mental health problems or other physical challenges. Are you able to tell us how you deal with those sorts of things? You mentioned that you have a model that is able to address all of those issues. How do you physically do that? How do you fund the services and engage other carers to provide people the supports they need?
Right, Mike.
Shall I start?
Yeah, I think you can do an answer on that.
We've intentionally refocused our workforce to include senior alcohol and drug and mental health clinicians so that we can actually sit right in that intersection and deal with both of those things. One of the biggest shifts that we have recently initiated is we've opened a new hub in West Leederville where we've integrated our Perth office, our clinical team, with our corporate team. And so it's a really one-stop shop, including psychology. We have got some external funding and we've introduced psychologists into our team. And we have rooms where visiting services come in, and our concept, we only opened yesterday, our concept is to have the specialists, so it's really, really new. So next time you're here, come and have a look. But the concept is that we can have specialist services on site as a one-stop shop for everything that people need, rather than, we believe in warm referrals, they work really well, but if we've got people on site within that window of opportunity when people are help seeking, then I think that we can be much more effective. So that's a real physical action towards working in that intersection.
So how do you fund that? Because obviously we're hearing from many people that that's the biggest challenge. You said you've got some external funding. How have you managed that?
It is.
Maybe explain. We just didn't get some funding recently, which I suppose is disappointing because we constantly are putting in applications to value add to the services that we know that we need. But maybe the example of the sites is a good one.
I mean, for the hub, that was an investment essentially from Palmerston. So we've purchased the property, but we've thankfully had funding from Lottery West to actually fit out the actual facility. So as a capital project, it's worked seamlessly, I guess, with external funders. But I guess the operational side year in year out is the challenge, is the sustainability. And as Mike's described, because we don't see AOD in isolation, we're trying to bring these allied health services to the client so that they don't have to constantly go to different services, kilometres away and retell their stories. So the challenge for us is how do we innovate and identify sources of funding that can bring in additional roles to add to a client's, overall journey, but how do we make that funding available year on, year out? Because there's a lot of, obviously we build therapeutic alliance with a client and there's that connection, and then if we have to backtrack from the service, it's a real challenge. So, that's constantly something that we as a team are totally having to work through and identify those different areas for funding.
So is there cost to people who attend your services?
No, all our services are free. There's a small cost for people who go to our residential programs, which is for board and lodgings, which is standard across residential programs, but all our other services are free.
That's amazing.
Including the dental program as well,
I was going to ask about that.
That's amazing. Okay, so just on that, the residential services we heard this morning from people with lived experience about the challenges of accessing residential services, particularly, they were talking about services where there was a cost and where people who weren't receiving Centrelink payments weren't able to access those services. And but they also, so that's one question. I guess I'd be interested in your input on that. But the other side of the coin was they were commenting on the difficulties if you go into residential care with walking away from your rental property, from your pet. and from other commitments that you have and responsibilities that you have within the community. So I was wondering if you could give us your thoughts on those issues.
Yeah. Do you want to start, Mike, and I can finish? Yeah.
I'll always start. And they're great points. They're really good points, and they are barriers that we're aware of. We're in the middle of reforming what our therapeutic communities look like. We believe that there should be streams for different needs in our services, and we're certainly looking to establish that. And some of those streams may be that there may be intensive mental health support that's required on and off-site while you're in the residential setting. Some people may require a shorter stay or a stabilisation period rather than a 12-week episode of care. So we're really trying to tailor our program into what people need rather than just having a one blanket 12-week episode program. We also need to be much culturally more appropriate and safer for our Aboriginal and CALD communities, so we're certainly looking to include those things. I don't have all of the answers at this point because it's mid-project, but it certainly is a priority for our therapeutic communities. And I think aftercare is really important in continuing care. We believe that the continuum of care should start at your first point of contact. You know, that should be the stage one of the program. It shouldn't be a separate piece of work as you transition into a residential or intensive period of care and then transitioning out. We believe that that continuum should be really, really clear and available. We do have a fee-for-service offering for people that's, you know, it's obviously not accessible for everybody, but it's certainly on our agenda to look at to make sure that we are accessible and equitable across the board.
Maybe just to add, so I live in Albany, so from the Great Southern point of view, for someone to get to one of our residential locations in the metropolitan area, and there is a commitment from the state government to build one in the Great Southern, which we are actively supporting. There's a lot of those barriers around getting on a bus, getting to Perth, getting to the farm, and so we've changed quite a lot of our intake processes so that we can walk alongside that client and there isn't that barrier as well as doing our community detox beds at the farm. So that's funded through the proceeds of crime. So we've been able to use that money to flip some of the beds at the farm so that if someone is homeless or street present and are suitable, they can come and do their detox at the farm. And then as well as when they leave, partnering with housing providers. So in the Great Southern Advanced Housings, we've got an MOU to that transitional housing and helping that client along that journey of reintegrating back into community. And we've got the 15 sites across the southwest and Great Southern that then if a client comes up to a metropolitan location, they come back to the Great Southern, they're supported with our team in the Great Southern to then continue their journey and that ongoing support. So they're not just left to their own devices when they do come out of residential as well.
So can I just interrupt and ask, you do provide rehabilitation that's non-residential, do you, or is it all residential?
Yes.
Yeah.
Yeah.
Yep.
So is that a significant part of your work, the non-residential program?
Yeah, it's probably the majority.
Yeah.
Okay.
Yeah.
Right.
Yeah.
So of the 15 locations, it's probably 11 or 12 that are community-based.
Right.
So
Yeah.
people can walk in, you know, it's in their locality,
Yeah.
whereas the residential are in specific locations across WA. Yeah.
Good.
We have integrated community sites with Next Step, who are the detox medical specialists. So
Right.
we have integrated works with psychology, GPs, counsellors for Palmerston and Next Step Detox at 6 sites.
Right. Okay. Thanks.
Thank you. That's true.
Sam?
Thank you. Firstly, Andy, your title, Business Development Manager, indicates that even though it's a non-for-profit, you've got to run it like a business. So you've got to understand having capacity, making sure that revenue is there to deal with capacity, the way any business would. But I'm hearing you express some difficulty and frustration with the way that government funding comes in, and that must be very difficult to manage capacity with having such short-term and uncertain funding mechanisms. Can you tell us a bit about that and what would make it easier for you to operate a more sustainable business?
Yeah, thank you. Yeah, I'll try and keep that short. I'm aware of time. I think it's a challenge probably for the whole sector that we have to, obviously, you probably heard it numerous times recently. And I think it's something that we've had to engage with, particularly looking at, I guess, our core funding, and then, but also organic, inorganic growth. Like, how does an organisation like Palmerston create stability, but also be bold in terms of how we innovate?
Yeah.
And I think the challenge for us has been, has often been, I guess, understanding why some of our, I guess, the government, whether it's state or federal, can, I guess, offer slightly longer contracts, which bring that stability, allow us to innovate, allow our staff to feel a sense of certainty of a role. But I think there's a lot of advocacy that's happening through peak bodies to challenge our government partners around some of the CPI increases, some of the ERO award-related, I guess, challenges we've all had as providers. So I think it's something we keep telling our story, advocating to government and to the peak bodies for. But in the meantime, Palmerston, we can't stand still. We want to keep innovating, keep growing in a sustainable way. So for us, that's why we innovate, and we have to look at different ways of diversifying. Did you want to say anything?
One thing that would be fabulous, whether the state or federal government wanted to do something along those lines, is maybe like a market-led proposal that happens in other sectors, like NRM. You can put a proposal in and it gets assessed, and it could be a one-off kind of pot of money where the community sector can actually pitch for innovative ideas, because sometimes a lot of our contracts are set contracts and then they're kicked down the road a bit more and they're not re-looked at. And so when we tender for some of the contracts, they're 3 and 5 years, and then they're added another 2 years, and so it's actually not contemporary, and it's not really of the need of what is needed at the time. And so I think if there was an innovative way of having a pot of funding that was market-led and the community sector could put into it, that then potentially these pilots turn into actual outcomes rather than continuing short pilots. It would help the sector innovate, and you'd get incredible outcomes for community and for, it'd be amazing.
Well, as members of Parliament, we've got two stakeholders in this. One stakeholder is the people that you're looking after, and we want them to get the best treatment possible, but the other stakeholder is the taxpayer, and we want their money to be spent. So if there are better ways to spend a similar amount of money over a longer period and get a better outcome, that's really what we're looking to trying to flesh out to see whether that's possible.
Yeah, and I think that's federally, well, dental, for example, we would love.
Ready to ask about that, don't you?
Yeah. So in our new building, we've been fortunate enough to build a dental, like we've got a dental room, which is Uniting Smiles is our partner, and they're a not-for-profit as well, and that's the only way we can really fund that. And we would love to fund a dentist, but there's just nowhere to apply. Like, we try, as you can imagine, to find funding all over. We've got a car from Bendigo Bank, we've got bits and pieces, but AOD isn't as, I guess, the appetite isn't there from philanthropy like there is for mental health. So AOD really sits in a really awkward and weird space for attracting external funding. Minderoo, they love early learning. So yeah, it's been a pretty interesting. I've only been in the organisation 9 months, and we are often and always looking for additional funding to.
So with a market-led proposal, it would work like organisations such as yourself, maybe even a bunch of organisations coming together and saying to government, we can do we think we can get the outcomes that you're looking for, and here's the way we'd structure the financial agreement, and for that then to be negotiated, rather than the government puts out guidelines, everyone can apply, it's competitive, everyone's trying to hoover up what's there, and then that might last for a year or so.
I think there's that you need to have the set government kind of opportunities and procurement, and for all the right reasons. But I think we often partner with people like Anglicare but we also, I think there's a real, you could lose some of the small players, like Palmerston are sitting in that kind of middle level not-for-profit, and we do have financial backing, so we have been able to take some bold and proper.
And you have a track record.
and we have a track record, whereas I think you'd lose some of those smaller organisations. But back to your market-led proposal, I think if it was an invitation and there was a certain amount of money that you could pitch for to create greater outcomes, I think that would work. But I think the core funding still needs to stay with some of those, the way it kind of is happening, but with that innovation space.
Okay, thank you.
Thank you. Look, I could ask you a million questions about some of your very innovative programs, but I really want to concentrate on the dental program, because I'm someone who thinks that healthcare starts at dental care and has implications across, as you've already mentioned, self-esteem and ongoing commitment to improvement and whatever. But I'm just interested on how you do fund it, and whether it is a complete service or whether there are limitations on what services can be provided, and how you get your dentists.
Yeah. So some of the concept came from our CEO, Emma Jarvis, who had often recognised that I guess people's challenges with their teeth was a missing piece of the jigsaw, really, in terms of their recovery. So 4 years ago, we identified a retired dentist who was prepared to provide pro bono dentistry into the pilot. So I guess that was through networks, and really that kind of sense, we're a large organisation with relationships, we can kind of make that happen. But we also partnered with St Pat's community organisation in Fremantle. They at that time had a dental suite themselves, and they're a homelessness organisation. So we were able to start with a pilot that aimed at our residential residents in our treatment programs. We would bus them in to the facility in Fremantle, and they'd get their free dental checks, but treatment in that place, in that dental suite. All that treatment was effectively paid for at that time by Palmerston. So our board were prepared to commit to a small amount of money to pay for anything that wasn't, I guess, covered by the public health system. And going forward in our new hub that you've heard about, where we have a brand new amazing dental suite, we partnered with Uniting Smiles, who again are a group of dentists who have chosen to volunteer their time.
So they're effectively doing it pro bono.
Pro bono, yeah. And they are going to offer their time for weekly clinics that will work with the most vulnerable, including our clients. So it's exciting, but again, it's a sustainability, and it does rely on finding dentists who are prepared to give up their time, which is why, as Beck said, ideally we'd love to fund a full-time or nearly full-time dentist who would say, I'm happy to commit to that weekly,
Yeah, okay, that's good. And you did bring up Bendaroo. Have they been approached for some funding in the AOD space?
Yeah, we have a healthy relationship with Bendaroo. Over the years, we have met with them and approached them for opportunities. But yeah, the reality is strategically they may have different themes at this stage. And I guess we often, with philanthropy, the challenge is understanding what philanthropists may expect government to fund and what they may be prepared to fund in terms of what they see as their priorities. So we do kind of keep an eye out to see if there's an opportunity coming up with people like Bendaroo, but obviously the focus normally is on things that aren't necessarily AOD related. It could be about location. They tend to invest in areas where they have obviously their own services and industry.
Yeah. Okay, good. And do you get any federal government funding for Palmerston?
Small amount, yes. Majority is state funding. And we do have some federal.
And you've also been able to get some local government funding. I'm interested in that because that has been an area of difficulty for some time.
Okay, back you can talk about that.
Yeah, and so I sit on a local council, so I find it quite interesting that the City of Rockingham helped fund the homeless outreach program.
Yeah.
To the tune of, it's not a huge amount, is it?
500, I think.
Yeah, so significant for a council that, and I think it was more presented around the street presence in the community and the safety, and maybe you speak about the connection that's brought together from a local government, state, and the whole, like the police and the whole community, and the outcomes for the community. I think that's how the local government's been interested. Our other connections with local government's quite limited, and their funding doesn't come very much at all. But they support what we do. It's probably the best way to put it.
Good. Growing area.
And I think it was the first time a local council had actually funded an AOD agency, and it was in response to a growing homelessness or transient population in the city of Rockingham, with high AOD encampments growing and high AOD use. So we partnered with St Pat's for housing, homeless healthcare, and our alcohol and drug services, and we hit the streets in an assertive outreach model 4 days a week, and we've done incredibly well.
Yeah.
We've got fantastic continuum from engagement, detox, community detox, counselling, into our residential services or into housing, so incredible outcomes. And there was always the potential of continued funding, but we've just been advised that that funding will not continue. It was just a pilot. So I guess for us, the concern is about the therapeutic relationship we've got with those people, and that some of them were already service resistant. And what are we going to do with those people, you know, as we roll out this kind of contract?
Excellent. Good. All right. Well, look, thank you very much for coming today. It has been really valuable, and we've really, I think, learned a lot from your very innovative programs. If you've been asked to provide any additional information, could you please forward it to the Secretariat within 2 weeks? You'll be sent a copy of the transcript of your evidence, and we'll have an opportunity to request corrections to any transcription errors. And once again, thank you so much for coming along today. And we'll just have a little 5-minute break while we get the new witnesses to be. Yeah. Thank you. Thank you. Good. Now, I'd like to call witnesses from the Queensland Mental Health Commission to give evidence to the Standing Committee on Health, Aged Care and Disability. If we could get them online. Oh. Hello.
Hello. This is Sean Popovich from the Queensland Mental Health Commission. I'm not sure whether the committee can see me, but I am on video as well. Oh, wonderful. Excellent.
Right. Hi. How are you? I've just got to go through the official introduction. For the Hansard record, could you please state your full name and the capacity in which you appear before the Standing Committee?
Full name is Sean Popovich. I'm the Director of Alcohol and Other Drugs Reform and the Queensland Trauma Strategy at the Queensland Mental Health Commission.
Great. Although the committee doesn't require you to give evidence under oath, I should advise you this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I'd like to now invite you to make a brief opening statement before we proceed to discussion. And to assist with the transcription of the public hearing, it would be appreciated if you could please state your name before responding to any questions. I now invite you to give a brief opening statement. Thank you.
Thank you very much. And thank you to the committee for the opportunity to appear today. Before I begin my opening statement, I'd like to acknowledge the traditional custodians of the lands on which we're meeting today and pay my respects to elders past and present. The Queensland Mental Health Commission welcomes the committee's focus on the health impacts of alcohol and other drugs in Australia and the opportunity to contribute. As outlined in our submission, alcohol and other drugs-related harm is shaped by a range of social, economic and structural factors, including housing, trauma, justice system interaction, and the broader community conditions. While there are many effective services and programs across Australia, the system is not consistently experienced as integrated. Fragmentation across sectors, variability in access, and gaps in coordination can limit the overall effectiveness of responses, particularly for those with the highest level of need. We also note that access to services remains uneven, including for people in regional or remote areas, First Nations communities, and individuals with co-occurring mental health and substance use issues. These inequities impact system performance and they impact outcomes for people in the community. There's an opportunity to strengthen the system through a more coordinated and evidence-informed approach, including improving integration across health and related sectors, strengthening early intervention and prevention, and ensuring that investment is aligned with approaches that are known to improve outcomes. The Commission's focus is on reform and system reform and strengthening how the system operates as a whole. The Commission is established under the Queensland Mental Health Commission Act as an independent statutory authority, though we are a part of government, the Queensland Government. And we note that both national and international evidence continues to evolve in relation to approaches that reduce harm and improve engagement with care and support. I'll leave it there, but thank you for the opportunity once again, and I'm happy to respond to any questions in relation to our submission.
Thank you. Sam, would you like to start?
Just have a moment.
Oh, Nick? Okay. Alex?
Thank you for appearing before our committee. I'm constantly told, I'm a Queensland MP, and in my electorate of Dixon, lots of people talk about the lack of residential beds in the mental health space, but also the AOD space. And correct me if I'm wrong, I'm not sure that there's any facility that deals with both. And if there is, there's very few beds to deal with them both. Can you just tell us a bit about the the landscape in Queensland at the moment and what the biggest issues are for getting people the support that they need, particularly the residential programs?
I can certainly do my best. It might be helpful for the committee to understand the way in which the alcohol and other drugs system broadly operates in the first instance. So there are a range of treatment types that people can access as part of alcohol and other drugs treatment. Those include psychosocial interventions, which might be delivered on an outreach basis, for example. And I believe you just heard from Palmerston. I was fortunate to hear some of Palmerston's comments delivering an assertive outreach model. So that would be a psychosocial intervention type model. There are also options for treatment that relate to withdrawal management. So detox and that kind of thing. And within that, that approach, there are also different options within that approach. So if you think of inpatient hospital withdrawal management, outpatient withdrawal management, or community-based withdrawal management, which might be bed-based or delivered by, for example, a GP in the community. So there are all these different levels and options based on complexity and severity, and some of that is medical complexity and some of that is psychosocial complexity. So considering that, there are also then different residential care options as well. So when we talk about residential rehabilitation, or rehabilitation in general, there's the residential bed-based component, but then there's also the component that might be like a day program, a residential day program. And again, different, forgive the phrase, but different strokes for different folks. You know, depending on the level of complexity, what the person's identified need is, and also, you know, in collaboration with a clinician who might help to assess that need, it will help to determine what type of response that person gets. There are some system gaps in relation to the way that those within the alcohol and other drug system, those treatment settings are able to operate together as well. So if we think about things like access to withdrawal management, for example, there's in Queensland, the Queensland landscape, particularly with inpatient withdrawal management, there is a large system gap. And what happens is some of those residential rehabilitation services require people to have safely withdrawn from their substance of concern before they can enter a rehabilitation service, a bed-based rehabilitation service. What that means is when there's no withdrawal management available, and if it's, say, a complex withdrawal like alcohol or benzodiazepines, then the person who needs support needs to wait until there's the withdrawal service available, and then there might be a logistical issue with arranging a transfer from the withdrawal service to the rehabilitation service, which could take weeks, and obviously that's not how substance dependence or those types of things work. So the system doesn't readily kind of link in that way, if that makes sense, from the perspective of the person accessing the service. And then there's the availability issue that you kind of are alluding to. So one of the issues, not just in relation to withdrawal management, but more broadly across the alcohol and other drugs treatment system in Queensland and across Australia, there's good evidence to suggest that actually, you know, the investment into the system doesn't actually meet demand, not at all. And there's been some work done both nationally and in Queensland to look at what that demand is and how we can at least build on investment in the space. But again, the colleagues over at Palmerston have already mentioned some of the challenges with that as well in terms of you know, workforce sustainability and ongoing funding for services and how that can kind of impact on workforce churn and that kind of thing. So there are a range of issues with availability, but to answer your question directly, there's certainly not enough services available across Australia for responding to alcohol and other drugs.
Thank you. Thank you.
Good. Have you explored more innovative ways of rehabilitation using non-residential programs as a government or government department?
Look, I can't comment on behalf of the Queensland Government, but I can say what the evidence suggests and what the Commission has done as an independent statutory body.
Yep.
Our role is really in the implementation of whole of government plans, so those being the overarching plan being shifting lines, and then the sub-plans, so being Achieving Balance, which is the alcohol and other drugs, and the Queensland Trauma Strategy, and also Every Life, which is our suicide prevention plan. Under the alcohol and other drugs plan, Achieving Balance, its primary focus is around that upstream system reform in many respects, so your prevention and early intervention, harm reduction, that sort of thing.
Sure.
And the funding under that plan, which is noted in our submission, but so the Achieving Balance plan had received over the course of 5 years $29.35 million of funding for those, I guess, those upstream initiatives. In terms of the investment that goes into treatment itself, that's really a question for Queensland Health more broadly. But there are initiatives under Achieving Balance that look at, what types of models might help to facilitate some change across the system. So, for example, there's an initiative at the moment that the Queensland Mental Health Commission is funding in relation to, I guess, what you'd call through care, and how we can support people who are, on wait lists to access services and might need that immediate support. There's a good evidence to show that if you can support early, then and sort of hold people while they're waiting for access to treatment, then that's got will lead to better outcomes, and likewise when they leave treatment. So small initiatives like that, but we're not doing anything in the treatment model space, if that makes sense.
Sure. What about initiatives for prevention, like reducing availability of alcohol, for example? Did you make any comments in those areas?
So there is a couple of things to consider in relation to availability of alcohol. So one of the more recent things has been around the rapid delivery, online delivery and sales of alcohol. Different states across Australia have responded to this in different ways. And there are some, the evidence suggests there are some concerns around rapid delivery of alcohol, for example, where people may, be already intoxicated, be able to get delivered alcohol to their door, and the link being to things like domestic and family violence, and increasing, I guess, community harm because of that increased availability. So there are certainly things across Australia that we should continue to do to look at what the evidence suggests and how we might address those availability issues because of the harm that is potentially leading to, especially in that social sense. There's also, I'm aware of things like there's been some trials across Australia in relation to things like minimum unit pricing for alcohol, and there's some evidence to suggest nationally and internationally that minimum unit pricing as a measure is effective on a public health level, obviously it would be highly dependent on context and I guess the way that each state would implement such a thing if it were to be implemented. But the flip side of that is that there's also some genuine concern around how minimum unit pricing could potentially impact marginalised communities as well. So all of these things need to be deeply considered in terms of what both the intended and unintended consequences might be. So I'm not sure if that fully responded to your question.
Yeah, no, that's good. They're the sort of things we've been hearing about from other witnesses as well, so giving some reinforcement of that is important. And I guess, you know, we have also heard a lot about the social determinants of health and mental health, and housing's come up a lot. Has that been an issue that you've been looking at? How we can get more housing for people with mental health issues?
Yeah, so there's some really, I guess, great models in locally here in Brisbane around responding to people with alcohol and other drugs, mental health concerns and housing concerns. One of the providers that I'm familiar with is, so there's a service called Common Ground, and they do some work with another service called Micah Projects and another by the name of Quinn in Queensland. And each of those services have it's a partnership type approach, and each of those services has I guess a specialist area that they kind of work in. Common Ground provide the tenancy arrangements, and Quinn provide the specialist alcohol and drug support, and Micah provide more the community-based case management sort of support. And that's a really, my understanding is that's a really effective model in terms of addressing those issues, particularly with relation to the alcohol and other drugs space, because often what we see with, I guess, in a specialist housing or homelessness setting is that, you know, where alcohol or other drug use, particularly illicit drug use, is a concern, it can lead to, I guess, the tenancy being put at risk. And sometimes that can also occur as a result of stigma as well, not just the illicit drug use itself, but really the response of the provider as well, not knowing what to do when a person is using illicit drugs, and how do we manage this so you know, perhaps it's not our role. So there are these complications where there are workforce capacity building needs across these systems, and it gets quite challenging because really each of the related systems is trying to understand what's the scope, what's the focus and scope of my role. And so if I'm a housing specialist, how much do I need to know about drugs in order to appropriately support the people that I'm working with? And so there's always this tension within the system about how do we facilitate the capacity building of the related workforces in this space, and also reduce stigma that you know, is sometimes perpetuated within those workforces. And
we've heard a bit about that today, actually.
And yes, so we can provide the best outcomes for the people we're working with.
And we also heard that there needs to be better workforce education and support in the community around housing and alcohol and other drugs and mental illness as well. So that's been very useful. Any questions, Monique? Or?
Oh, thank you. Yes, we've heard from a number of people who've spoken to us about the difficulties in accessing services if you have other sorts of issues, intersectional issues like physical health problems, active health problems and mental health problems. And you've spoken in your submission about the challenges involved in caring for people who are actively withdrawing from medications or detoxing. How do you address those with your organisation? How do you provide wraparound care?
We don't provide service delivery support within the Queensland Mental Health Commission. So we are not providing direct services or wraparound supports.
So I mean, like, how would you provide that how would you suggest that we ensure that those sorts of supports be provided? Or
I think that's a very big question. There are a couple of key issues, I guess, within that. So our service system, in my understanding, provides quite a good level of support with the resources that it has. And the question often becomes, how do we, and when I use the term integration, I use it meaning collaboration, coordination, and I guess a seamless sense of support from the perspective of the person who's receiving it. And so there are a range of challenges that relate to that. Some of those are, funding challenges, which I touched on earlier. So you end up with this, as I mentioned with the earlier question around within the alcohol and other drug system, so from withdrawal management to residential rehabilitation being the example there, is that because the system is, the resourcing of the system is a challenge, then you end up with these disparate services operating with gaps, and particularly in Queensland, like a large geographical location. And so that is also the case with things like housing and mental health services and so on and so forth. And so providing that wraparound support is often a matter of addressing those broader system challenges, which are in relation to workforce capacity, workforce availability. In some places in Queensland, we have fly-in, fly-out arrangements with workforce, and they're not always available and not always there when people need it. So they're perennial problems in many respects. I think largely, by and large, from a system perspective, which is the perspective that the Queensland Mental Health Commission has, is that many of these issues are about that broader, how do we rebalance our system investment so that we can better meet the needs of the community based on what we understand the community needs through things like investment modelling, like the Queensland Drug and Alcohol Services Planning model or whatever it is.
Good. All right. Well, look, thank you very much.
I've got a question.
You've got, sorry,
I don't know if
Alice?
Sam does as
Or
well.
Sam?
Yeah, look, while we've got a moment, I'm going to just ask a question just for your view on when we talk about these issues, you'll have a lot of the discussion will be around government services, which are important, how they're funded and how they're offered, but also then there'll be some people who'll talk about a personal responsibility narrative and harnessing that and giving people agency. And I guess it was interesting to hear you talk about issues around rapid availability of alcohol. Is there any other way that you see, there's treatment, there's the government's role in it, but there's also helping people with their own agency when battling these issues? Have you got a comment on how that might work based on your observations?
I'm not sure I do. I'm not sure. You might, if you can indulge me, please, and follow on the question. I'm not sure I fully understand the question.
How can society enable people to have their to enable their personal responsibility in looking after themselves in relation to temptations of drugs and alcohol, and one of those issues was the issues around rapid availability. Are there other issues that you see? I know that's an open-ended question, but it seems that I do want to just get your perspective based on the fact that we talk a lot about dealing with people who are suffering from addiction, and that's very important. But how do people? Is there a way to stop people from finding themselves in these issues in a societal way?
Look, I think we've got really good measures that actually do help with those things. So, you know, the National Drug Strategy talks about the 3 pillars under the National Drug Strategy. So it's really important that we consider those in the context of a question like this, and all of, no doubt the committee is aware, but, you know, supply reduction being one measure under the National Drug Strategy, which can encompass a whole range of things like enforcement, but also like things like, you know, reducing the ability of people to access rapid delivery of alcohol, being another example. There's also the demand reduction initiatives. So those are things like treatment or, you know, public health campaigns, for example. So we have a range of measures that we use in that respect. And then there's the harm reduction, which is also a really, really important component. So, you know, we're enhancing people's safety who continue to choose to use alcohol and other drugs. And all of those taken together are what makes a strategy in alcohol and other drugs effective. So to come to your point about if there are things that we can be doing, I think that actually there are really good examples. So for example, you know, some, I guess, evidence around services like drug checking, where around services like drug checking in the harm reduction pillar. So the evidence is well established in that respect. You know, where people are considering using drugs, that's often a last line of defence for access to a health worker who can have a conversation with that person and help to reduce the demand. And it's often the first time a person has had a chat with a health worker about their substance use. So there are methods that we can use and can you know, really facilitate I guess demand and harm reduction in that respect, and they're very well evidence informed methods. So there are other things that we can do in these spaces. I think part of the challenge is often the priorities that we have as you know, socially in terms of what we invest in and how we invest that money. But there's a good deal of evidence for a range of additional initiatives that we can implement that actually work.
So just to paraphrase a little bit, the National Drug Strategy, it's sort of on the right track, and there's some good evidence and some good initiatives happening. It's just looking further into that to see whether that can be, whether the things that are working should be expanded at all.
Yeah, I mean, I think that's a fair statement. And I also think that, you know, it's worth pointing out, which is in our submission as well, it's worth pointing out that the investment across those 3 pillars, so supply reduction, demand reduction and harm reduction, is really not well balanced at the moment. There was a recent, I believe there was a recent, and I think it's referenced in our submission, but there was a recent report by a drug policy modelling program that, again, kind of touched on what the investment looks like across those 3 pillars. And from memory, so please forgive me on these figures, from memory, it is around about, I think, 20% or 25% of the money goes to of the investment goes to demand reduction initiatives. Then you've got about 2% that goes to harm reduction, and the rest goes to supply reduction. So that's actually one of the things that we need to consider, is how we can rebalance that investment to ensure that it's actually achieving what we mean it to achieve and getting the outcomes that it needs to. And I'll refer back again to our Palmerston colleagues. You know, speaking about, there was a question, I think that it may have been asked by yourself, which was around the interest in looking at how we can do what we, the best we can with the bucket of money that we currently have. And I believe that the rebalancing of investment is our answer to that question. It's understanding where our money is most effective based on the evidence, and putting our money into where it's most effective based on the evidence.
Great, thanks.
Thank you.
Alice.
I just have one quick question. Thanks so much for appearing for our committee today. My question is just on data collection. Do you think the way we collect data on AOD harm in cold communities, for people in custody and young people, is adequate? Or if not, how do you think we can improve this?
It certainly, so starting with cold communities, we know that it's not adequate. We don't have adequate data in that space. It's very much the same with other priority communities as well. I'm sorry, I don't have answers to that question. I think that we need to work with those communities to understand, in the first instance, how we can have better conversations around alcohol and other drugs, because part of the problem is, my understanding is part of the problem is for those communities, because particularly illicit drugs use is very, very stigmatised. Those communities are less likely to disclose their use, less likely to disclose any problems that they might be experiencing, less likely to seek help. And so even with the best data systems and the best assessments and all that sort of stuff, we still have a gap in our ability to kind of, reduce the stigma of talking about those things as well. But beyond that, I think consistency in data collection is another point that probably needs to be made. Some of our national data sets, understandably, they're slow to change because there's an effect where we want the previous data to still match the existing data. But our national data sets sometimes also don't capture the full picture of things. So I'm thinking here about the Alcohol and Other Drugs Treatment Services National Minimum Data Set, where there are data items in that data set that perhaps could be improved to help with that as well. Sorry, I know that's not a very clear answer to the question, but...
Yeah, all good, thank you.
Thank you very much, and thank you very much for your evidence today and for your attendance. If you've been asked to provide any additional information, could you please forward it to the Secretariat within the next 2 weeks? You'll be sent a copy of the transcript of your evidence, and we'll have an opportunity to request corrections to any transcription errors. And once again, thanks very much for giving us your valuable time today.
Thank you to the committee. Thank you.
Thank you. Good. Now, I'd like to call representatives of the Northern Territory Health Department to give evidence today. Hello.
Good afternoon. Can you hear me?
Yep. We can. Hello, how are you?
Good. Yourselves?
Good. You can hear us okay?
Yeah, I can.
Good.
It's Samina Branca from the Department of Health, and I'm the Director for Community-Led Harm Reduction.
Great, thank you. For the Hansard record, you've already given us your full name, the capacity in which you appear before the committee. Although the committee doesn't require you to give evidence under oath, I should advise you this hearing is a legal proceeding of the Parliament, therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a brief opening statement before we proceed to discussion. To assist with the transcription of the public hearing, it'd be appreciated if you could please state your name before responding to each question. I'll just get my committee members to introduce themselves.
Sam Birrell, member for Nichols in Northern Victoria, Shadow Assistant Minister for Agriculture and Regional Education.
Monique Ryan, Deputy Chair of the Committee and member for Kooyong in Inner Eastern Melbourne.
Mike Freelander, member for Macarthur and South Western Sydney and Chair of the Committee.
Alice Jordan-Baird, member for Gorton, Melbourne's Western Suburbs.
Ailey France, member for Dixon in Queensland in northern Brisbane.
I now invite you to make a brief opening statement before we proceed to discussion. Thank you.
Thank you for allowing the time today to speak at the hearing. In the Northern Territory, we have a key focus on tackling problem drinking, and with the key elements of that, as the counterpart before us spoke about, the under those 3 pillars of supply, demand and harm reduction. And with reducing supply and reducing the unsafe access to alcohol, We aim to maintain strong and enforceable restrictions on alcohol sales and with delivery timeframes. The use of risk-based licensing that our counterparts in the Department of Trades and Asian Business Relations do, and the use of the banned drinker register and banned drinker orders to prevent takeaway alcohol purchases where people are subject to such orders. In terms of reducing demand through prevention, early intervention and treatment, we have a number of programs that are funded under the Northern Territory Remote Aboriginal Investment through the Alcohol Harm Reduction Schedule that have a focus on creating those clear pathways for people who are dealing with alcohol within quite complex scenarios from remote communities and have found themselves in towns, to then being able to support their access to treatment, alcohol treatment services, to then follow up that through support to access support returning back to communities, and then further support through social and emotional wellbeing based programs in communities. And in terms of reducing harm, there are also a number of programs we are tackling, most particularly the community alcohol planning that's undertaken through the Department of Health, and the delivery of the community-led solutions that communities identify strategies and initiatives that they see are pivotal in reducing alcohol-related harm. We know in the Northern Territory we have one of the highest per capita of alcohol consumption and the highest rates of hospitalisations and deaths from alcohol misuse. And alcohol-related harm remains a key issue for us, and given the significance and complexities of it, a number of initiatives and programs that we are currently undertaking and also in development.
Good. Thank you. Monique, do you have any questions?
Thank you very much. Do you have any sort of specific policy suggestions regarding how we can decrease alcohol harm in the NT? I'm particularly interested in, I'm a paediatrician by training, so I'm very interested in fecal alcohol syndrome and related disorders and what we can do to decrease its incidence and prevalence.
Yeah. So one thing we do here with our work we're undertaking with communities across the Northern Territory is a need for education, and education needs to be place-based and culturally tailored to the groups that they're working with, but also education that's strength-based and really utilises culture as a protective factor in addressing alcohol-related harm, particularly around obligations for parents, and not just focus on women as well. As what we're currently hearing is there also needs to be inclusiveness of the wider family unit and maintaining support and structure to address alcohol consumption in the family unit that also impacts those that are women that are pregnant. Our efforts to, I guess, support this and recognise communities are best placed with the answers is increasing or is extending funding for Aboriginal community controlled health services who work closely with their communities in addressing FASD in ways, in strategies that meets their community needs. So we do see a little bit of a differences across the regions that the services are delivered, with a particular focus, where some have been strongly focusing on, a social and emotional wellbeing approach to working with the women and families, and others are running quite significant public health campaigns in their communities.
Thank you. I guess one of the challenges is making sure that these sorts of education programs are culturally sensitive. How do we do that for different Indigenous communities, for example? Would it be necessary to have a different program for every community, would you think, or?
I think an outline of program kind of guidelines is what we're hearing is required, but then also the adaptation and delivery and design of that particular program needs to be nuanced to the region and the community, and recognise also the assets that exist in the community and also the barriers and challenges that exist as well. So the answer is yes and no, that yes, we can have a bit of an outline of a program that can be applicable across the territory, as long as it's been kind of developed in ways that recognises the needs across all the common themes that we're hearing across communities across the territory. But any delivery and the design of that delivery does need to be nuanced to those particular communities, and particularly around cultural elements. That's with regards to education, and that's delivering it from more of a cultural lens perspective, absolutely needs to be tailored and reflective of those practices that exist within that community.
Thank you. Last question, if I may. And do we have the workforce to deliver those sorts of supports and services, do you think?
Look, as other jurisdictions around Australia are finding, workforce is one of our biggest challenges, and it is an enabler as well, though. We in the Territory recognise we actually have an untapped workforce that exists out there in remote communities, and we're taking an approach of actually looking at ways how we can better create jobs that are more relevant, more appropriate, and recognising the skills of local people, and create better pathways into these jobs, and recognise better ways of training people that takes in consideration, place-based training and micro-credentialing, where learning is conducted in micro sessions. So yes, workforce is a huge challenge, but we also recognise there are untapped workforces out there in remote communities that can also contribute to this, and also that local people in their communities are the experts in their livelihoods and can really help shape and form the delivery and design of programs. Noting though that if we do need to engage with more that specialist end of the particular professions, and then we also need to have a focus on that and what that looks like and the challenges that exist in that space as well. But generalised sorts of professions and positions can definitely look at how we can better enable and access local people to do those jobs.
Thank you.
Ali.
Thank you for appearing before us today. We really appreciate it. I was just interested in your submission, which I think was submitted a little while ago, but you talked about pharmaceutical drug misuse in the NT. Just for context, like, is it much higher than, because it talks about high rates of pharmaceutical drug misuse, but is it, what is the national perspective? Like, do you have any figures on, is it much higher than other states? And do you think enough is being done in that space, and what is being done in that space to address the issue?
Unfortunately, I don't have any stats in front of me that I can share with you all today, but I'm happy to take on notice and provide any relevant information outside that can answer that question. Take that one on notice.
Yeah, thank you. Do you know of any specific initiatives or measures to target pharmaceutical drug misuse in the NT?
Yeah, I guess one way is a focus on supporting clinical decisions and conversations to reduce medication-related harm. So a focus at the primary healthcare level and the frontline workers who are working with the communities. And we also note too that opioid use is less common than what we see in the larger jurisdictions. But that opioid pharmacology data shows ongoing treatment and demand, and that there is program and clinical guidelines currently under review to address that as well.
Okay, thank you.
Alice.
Thanks so much for appearing before our committee today. My question is just around one of your recommendations to ensure treatment of AOD use to consider co-occurring mental health conditions, eliminating entry barriers and allowing concurrent treatment. We've heard from a number of people this morning and over the course of this inquiry about exactly this issue and a bit about exclusion criteria as well. Could you expand on how you see this working in practice and what recommendations you'd make to the committee around this specific issue?
I guess one approach that we have here in the Territory is working towards a no wrong door policy, and ensuring that when people front up to whatever service that they're using, that they're going to be supported in a timely way to address or link them in with their, with the relevant supports or services that they require. So that's one way to ensure that at the front of it all, and particularly during the client's journey, that they're not going to be turned away at all. Another way is also taking an approach, particularly for Aboriginal populations up here in the Territory, is utilising the holistic view of social and emotional wellbeing and taking that approach of looking at services and design and delivery that takes that whole social emotional wellbeing approach, where we're not just particularly treating one co-occurring mental health issue or one body part in the wider health scheme, but we're actually treating the person as a whole. And looking, innovatively about how can we do that at our level in terms of commissioning services to not just provide one or two sorts of interventions, but also how can they work within the wider system. And looking at opportunities for better collaboration across other different funding bodies as well is another area of focus that we're particularly tackling. That we know that silo policies and programs also create fragmentation on the ground, and we're also aware, as others have spoken before us, that those restrictions and limitations on those services, if eligibility requirements, further exacerbates fragmentation on the ground. So really coming from a base that we're operating from an inclusive approach where we possibly can.
Great, thank you.
Sam.
Thank you. Follows on from Dr. Ryan's question a little bit, but just the targeted approach to dealing with these issues in remote communities as opposed to Darwin or Alice Springs, just given that they've all got their own challenges and idiosyncrasies in terms of those communities. Do we need different approaches to regional communities and regional or cities, and different rules?
I guess we take the approach that a lot of we have a high, mobility of people from remote communities staying for short periods of time or even longer periods in our rural towns, and so the shorter answer is yes, we do take an approach and recognise that different settings require different approaches. But generally, we're looking at it from a pathway where we're wanting, no matter how someone accesses a support service, or if it is in town that they're accessing it, or if it is in a remote community, that we want to build a system where they can follow through that pathway, however that looks like for them. If it does look like moving into a residential rehabilitation centre for a stinted treatment that's based in town, then that's what it can look like, or it does look like returning back to community after an episode of living rough in town, then they're going to be well supported. So the short answer is yes, we do take different approaches, but the main aim is to create more of a smooth pathway that people can come in and out of their journey to reducing harm or living with alcohol in safe ways. Wherever they are, whatever setting they're accessing it out.
And we also heard some evidence today about it's all very well to treat, and the treatment can be very good, but if the person then goes back to an environment where there's instability with residents and violence and easy access to alcohol, it can undo a lot of the good work that's been done. So have you got a view on access to, you spoke about services then in different communities, have you got a view on access to alcohol?
So one of the key, initiatives that we are running up here in the Northern Territory is community-led solutions, where communities are supported to identify and design and deliver what they see as their strategies, initiatives, programs, activities, or even community-based rules to reduce alcohol-related harm. And so that's one way that we're investing in the communities to really empower them to make these tough decisions around alcohol and reduce harm at a place-based level. We do, through this work that we do across the Territory, we do recognise that a lot of our communities are quite conservative in their views around introducing supplies of alcohol, and are quite concerned around already the rates of violence that is occurring in their communities that's associated with what we call slide grogging. So that is illegal alcohol being brought in on the black market in communities. So I hope that answers your question, but please do reiterate that, because I've slightly lost the question myself.
No, that's a really interesting answer. I suppose I was going to follow on and say that, and you talked about the conservative approach to alcohol in communities. Does that depend on, when you say community sort of making the decisions themselves about how they want to deal with this, which is good? Does that depend on the community leadership and how strong that community leadership is to go down a certain path? And then I suppose it's up to the government, in this case the Northern Territory government, to adequately police that and make sure that the will of the community is not being overridden by people breaking the law and bringing black market alcohol into places.
Yes, so it definitely does require community leadership in that respect, and we do recognise that as every community is different, every leadership group within that particular community is also different, and we work with communities to take a responsive approach to meet them where they're at. So if community leadership is still emerging because they've also experienced quite a number of deaths of elders and leaders, so we work closely with them to build up their capabilities to take on these more, quite contentious issues, and those tough conversations that are occurring at a community level around reducing supply and reducing harm and reducing demand related to alcohol. But we do see there is always been a quite strong history of community leadership in tackling alcohol problems across the Territory, and a lot of our communities have been the first ones to advocate strongly around the association of alcohol and harm that's created in communities. Yes, there definitely is divergence between community leadership, but we take a responsive approach to support communities and their leadership groups that they determine to help support them in their efforts to reduce harm.
Thank you. Thank you very much.
Great, thanks, Sam. I've just got a couple of questions around alcohol supply. I was recently in Alice Springs. I was shocked by the level of public drunkenness and the level of this distress in some of the women, talking about what alcohol was doing to their communities. Are we restricting supply enough? Is there more that we should be doing?
I won't be best placed to answer that particular question, given it is quite particular to Alice Springs. I think from our overall position, though, is that we need a multi-pronged approach to addressing alcohol related harm that we experience here in the Territory. And it's not just one solution, or it's not just one agency, or it's not just one bucket of money that's going to resolve and resolve this issue that we're experiencing. What we do see, though, is that when all key parties involved in this, whether it is the police at the front line, whether it is health playing a role through a community development approach to supporting communities, or where it is community leaderships and taking their own initiatives to call it out for what it is and address those issues from a community response. We know that can actually work quite well in terms of at a small scale, community size, when the police have a strong relationship with the community, when the community is well supported, and when we can fund their initiatives that they think is going to reduce harm. At a wider, larger scale and with complexities that we see down there in Alice Springs, there isn't, I feel, a one answer that's going to solve or resolve this. I think, though, there is a lot of effort to reduce harm out there in Alice Springs, with particular action planning that's been undertaken, and efforts to date that has been looking at reducing the supply components that are associated with that. But then we also know we do need to, whilst we reduce supply, we also need to enhance around the social emotional wellbeing and community safety, initiatives and programs that need to also help with reducing demand for alcohol.
Mm-hmm. And should we be training more Indigenous health workers in alcohol and other drug management?
We definitely recognise that, and what we do is we have a program up here called the Support and Healing Program, which was formerly called the Remote Alcohol and Other Drug Workforce Program, that looks at training and looks at supporting through practical workforce supports a local Aboriginal workforce to tackle alcohol problems in their communities by delivering education, by delivering initiatives and programs and activities such as diversionary community-based events that promote, non-alcohol, alcohol-free activities and programs that can occur. So yeah, we do recognise that and support that, and are currently delivering that.
Thank you. Good. All right. Well, any other questions? No. Well, thank you very much for giving evidence to us today. It's been very valuable. So thank you for your time. If you've been asked to provide any further information, I don't think you have, could you please forward it to the Secretariat within the next 2 weeks? Shall we send a copy of the transcript of your evidence? We'll have an opportunity to request corrections to any transcription errors. So thank you very much once again.
Thank you all for allowing me to speak today.
Good. And we will now suspend and we'll reconvene at 1:15. Thank you. Thank you, everyone. Good. Well, I'd like to now reconvene this meeting of the Standing Committee on Health, Aged Care and Disability, and I'd like to call witnesses from the Western Australian Primary Health Alliance to give evidence today. Good afternoon, Mr. Ray. For the Hansard record, could you please state your full name and the capacity in which you appear before the committee?
Yes, I'm David Ray. I'm Senior Policy Analyst, part-time with the WA Primary Health Alliance, and here representing WAFA and the CEO Bernadette Kenny.
Great, thanks. Although the committee doesn't require you to give evidence under oath, I should advise you this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a brief opening statement before we proceed with discussion. To assist with the transcription of the public hearing, it would be appreciated if you could please state your name before responding to each question. I now invite you to make an opening statement. Thank you.
Yeah, thank you. Dr. Freelander and committee members. Thank you for the opportunity to present today and to contribute to the important inquiry. So my name's David Ray and my honour to represent the WA Primary Health Alliance, which is the operator of Western Australia's 3 primary health networks. I'm WAFA's Senior Policy Analyst and represent our CEO, Bernadette Kenny, who sends her apologies. Today, I'm summarising WAFA's submission to the inquiry via a 5-minute overview. Alcohol and other drugs continues to have a significant impact on individuals, families, communities and the broad health system. So WAFA operates Western Australia's 3 primary health networks, which are Perth North, Perth South and Country WA, and commissions AOD services on behalf of the Commonwealth Department of Health, Disability and Ageing. Our AOD commissioning budget is approximately $13 million this year, which is around only 10% of the state's investment through the WA Mental Health Commission. Primary health care responses are central to addressing AOD-related harms, particularly for people who experience disadvantage and poor access to mainstream services. The key purpose of our submission was to outline how WAFA's commissioning approach contributes to reducing AOD-related harm, particularly by targeting health equity, by strengthening the state's AOD treatment system, and by purposefully addressing the social and structural drivers of addiction in Western Australia through our commission services. Health equity is the North Star that guides our commissioning activity. We've seen that many people affected by AOD harms fall through the gaps in the health system due to complex overlapping social and economic disadvantage, including low income, job insecurity, social isolation, low health literacy and geographical disadvantage, particularly in rural and remote areas of Western Australia. WAFA focuses on commissioning services that reach those under-serviced populations to complement Medicare-funded primary health care. Our AOD strategy outlines 4 overarching AOD commissioning priorities for 23 to 26. They're building workforce capacity, improving access, improving safety and quality, and finally, enhancing system efficiency and client experiences. Our focus going forward is firmly on supporting primary health deliverables in each of these priority areas. We do this through 2 key approaches that we highlighted in our submission. Firstly, we acknowledge that effective responses to AOD harm requires more than treatment alone. In particular, our submission highlights the importance of addressing biopsychosocial contributors to addiction, which include housing insecurity, mental health comorbidity, trauma and social exclusion. And secondly, we stress the importance of joined-up planning, a priority reflected in a number of bilateral documents and reviews. Our submission described how WAFA have led the way through formalised commissioning partnerships with the WA Mental Health Commission to ensure collaborative and coordinated statewide approaches to the planning of services here in WA. Thank you.
Thanks. I might start with a couple of questions, and I don't think there's any disagreement that primary health care is central to managing AOD harm, but how do we do it? How can we encourage primary health networks, GPs, nurses, community health organisations to engage with AOD management?
Well, I guess first of all, they already are. So AOD is a very prevalent issue facing GPs and other primary health practitioners already.
Yep.
And there are, in fact, requirements on GPs around things like conducting screening of patients as part of their accreditation processes. So WAFA really is there to try to support those processes and make it easier wherever possible.
We have met with the College of GPs and the AMA, and they all say that they don't have enough time.
Yep. Yep.
How can we encourage?
Yep. Big focus is multidisciplinary teams, and the AOD sector provide that. I think the workforce actually is already multidisciplinary, but the key is around how we can form more effective partnerships with GPs. There are some good successes in that regard through funding streams, but we want to do more. I think probably the solutions to that are individual as well, so there's no one size fits all.
Sure.
Co-location is, probably kind of a gold standard. We'd love to see more of that, but the practicalities in GP surgeries very often prohibit that. Virtual-based consultations, and really developing shared pathways with the primary health sector so that people can flow through and receive the services that they need to receive at the appropriate time.
College of GPs says we should be increasing funding for more prolonged consultation. Do you think that is a worthwhile support?
Yeah, look, I can't really comment on the Medicare reforms for the AOD. I'm not quite across that, but there have certainly been a lot of Medicare reforms to enable longer consultations, which I would imagine extend to AOD as well. But it's also around making more effective use of the items that are already there. And that's certainly one of the things that we'd like to see providers doing, is supporting GPs to make use of those items already. Just as a little kind of aside, my understanding is that in GP land, for every one long consultation, you require around 13 short consultations, because otherwise the service very quickly tips to become a specialist and can be quickly kind of occupied with a cohort of patients rather than family practice. So that's part of the challenge, is supporting more GPs to take on a smaller number of clients rather than only a few GPs to take on large numbers, if that makes sense.
Yeah. Okay, another thing that has come up is better training for our nurse practitioners and community nursing cohort in alcohol and other drug management. And there has been a bit of a discussion around stigma for that. Has that come across your research as a workforce issue?
Look, certainly in terms of nurse practitioners and what they can contribute to this, we've got a program here, the Dawn service, Drug and Alcohol Withdrawal Network, which supports GPs and their patients to withdrawal in the home. And that's proven to be very, very effective. I do think that huge gaps in withdrawal services. and large waits for people to be able to access. Some of the anecdotal evidence is that people only get into the central drug unit if they have very kind of strong comorbidities, so pregnant and health conditions that are running alongside their withdrawal, for example. So the majority of people don't need to be getting that type of withdrawal service inpatient.
Right, so it's called the DAWN, did you?
That's DAWN, yeah, the Drug and Alcohol Withdrawal Network, which is a home-based. My point there was just that there's large gaps in withdrawal services, and primary health has a big role to play.
And is that in your submission at all, or not?
Don't think so. No, I think we're focusing really on equity.
Yeah. Is there any information you could send us about that?
Yes.
Only because there's been a lot of focus on residential management, which clearly is, expensive and limited access to people that don't necessarily live in central business districts or big cities. So we are keen to look at more innovative models.
Yeah, look, I can send through some general information on it. I think it's actually funded by the Mental Health Commission, that program.
All right, well, anything you'd send us about that would be appreciated. Multiple issues have come up in this inquiry, and clearly we're looking at all different aspects, but one of them is availability of alcohol and other drugs, and around some of the easy availability of alcohol, the low cost. Do you have any views, or does the PHN have any views on those issues?
Look, our remit in prevention is largely around secondary prevention rather than primary. And I know that the WA Mental Health Commission provided information around their efforts in availability and their actions in that regard.
Good. All right. Any questions, Monique?
Yeah, thank you. Thank you for coming to the committee today. Can I ask about, I think last time your group's submission to this inquiry in the last Parliament, you were talking about the nexus that you'd established with mental health services for WA. Are you able to give us an we've been hearing a little bit about the difficulty in providing appropriate drug and alcohol support services to people who have active or untreated mental health issues.
Right.
Are you able to give us any information about how it's working in WA and what's been effective and what perhaps has been more challenging?
Gosh. Look, it's an expectation within WAFA funded services that there's collaboration around comorbidity, but I do think it's an area where there needs to be a greater focus. It's certainly a joint priority with the WA Mental Health Commission as well. They're really leading that work. We try to fill some of the gaps with a focus on primary health and what GPs and other primary health practitioners can better do in that space. But yeah, as we said in the submission, it's the norm, not the exception, that people have complexities going on in their life, including mental health comorbidities, alongside a whole range of other biopsychosocial. So our commissioning intent is broad services. It's treating people rather than diagnoses.
Okay, thank you. And the three areas that you represent, the two from Perth, but then also the country of West Australia, To what extent are services or provision of services by the primary health networks in rural WA different from those in metropolitan Perth?
How are they different?
Yeah.
Well, I guess, the first thing to say is the sparsity of services, and populations are scattered where services are very often centralised. So there are, the WA Mental Health Commission purchased the services of drug service teams located in regional centres, and I'm sure they do their best, and we try to supplement that with our funding to enable them to do outreach beyond the regional centres. But WA is a huge space and providing equitable services across the region is a real challenge. And in Wee Wade, with our little bits of funding, how can we supplement that to make that more effective so that people are not disadvantaged by geographical isolation. But we have a small amount of money.
Yeah, sure. I appreciate that. Thank you. Thank you, Chair.
Sam?
Thank you. When you're looking at analysing policy, I assume you might be analysing trends as well in terms of societal use of drugs and alcohol, different age groups, different parts of society, and presentations, and so what the system has to deal with. Are there any trends that you can share with us? What you're seeing?
I mean, COVID had a big impact, and some of the research might be getting a little bit outdated now, but around alcohol use disorder amongst middle-aged people in particular, and the challenges that are happening in the healthcare system for that particular cohort. So I think that's a important area to be focusing on.
Just, do we know if that was a phenomenon that sort of ended with COVID or shortly after COVID, or is it, or not ended, but reduced, or do we see it as a triggering thing that's caused an increasing or plateauing problem?
Yeah, I think the latter. So I'm not sure if that trend is continuing now, but certainly over the last few years, you saw a rapid increase in consumption by that particular cohort.
And do you have any insight into why that was? Was it because people found themselves at home early in the afternoon with not much else to do, or was it the anxiety of the situation?
Not really 100% sure.
Okay.
I think COVID probably exacerbated something, but this is around societal norms and expectations. And I mean, you do see it in other cohorts as well. So different groups that will be drinking at harmful levels, and young, middle-aged and seniors as well. But that seniors one, the middle-aged one was something that really stood out for me.
And are you seeing, I've asked other witnesses in other hearings this, but are you seeing, we anecdotally feel that there are trends about younger people moving away from alcohol and more towards other drugs? Are you seeing that as well, traditionally?
I don't know what the latest NDS household surveys are reflecting around other drugs, but certainly we've seen a downward trend in alcohol use, which has got to be great news.
Yep. Thank you.
Yeah.
Do you have any questions?
Yes, apologies, I was a little bit late. My name's Alice Jordan-Bett. I'm the member for Gordon in Melbourne's western suburbs. My question is just around improving the current care arrangements and patient outcomes with co-occurring mental illness and AOD use. It's something that my local PHN raises with me quite a lot. We've got quite a high
population of people in this category. What do you think we can do to improve this care?
Yeah, well, we talked a little bit about that in your absence. To note that this is the norm rather than the exception. And yeah, I actually think that the AOD sector have been very good at treating people rather than diagnoses, more so probably than the mental health sector. And, you know, that's you know, something to see more of kind of going forward. And that's what we try to do in our commissioning, is recognising that people present with a whole plethora of problems. Alcohol and other drugs is one of those issues. And to really be effective, you need to treat the whole, not the part. AOD is really valuable though because it's a trigger point. It's often the reason that individuals and communities really will start to address some of the most tricky issues that are facing them and us. And so it's a great kind of foot in the door to actually address those things. So people will present to AOD services with a range of problems which include problematic drug use. And what we try to do in our commissioning is ensure that the whole person is being treated, not just the AOD part. Yeah.
I just got one last question. You represent all the three PHs in WA, so
a bit unusual.
Probably get a pretty good overview. Is there pressure on you from the GPs to improve access to AOD services, or is it something that sort of flies under the radar a bit? People just accept it as part of life?
Look, I've certainly heard anecdotally, and we've had some focus groups with GPs which have highlighted gaps in services, absolutely. Like I say, you know, we've only got a relatively small purchasing budget compared to the state. We want to lever off the services and the commissioning that's been done by the state to fill the gaps and target to the most needy areas. And, you know, GPs are critical to that. So partnerships with the other services and commissioning activities that we're doing and how we can, you know, do that holistically, I guess.
Good. All right, thank you. And thanks for your evidence today. It's been very valuable. If you've been asked to provide any additional information, I think it was just that one thing around the dawn service. As we approach Anzac Day, I don't mean that sort of dawn service, I mean that. Could you forward it to the Secretariat within the next 2 weeks? That'd be great. Yep. You'll be sent a copy of the transcript of your evidence, and we'll have an opportunity to request any corrections to transcription errors. And once again, thanks for appearing. Thank you.
Thank you.
Good. I'd now like to call representatives of Alcohol Change Australia and Western Australia Network for Alcohol and Other Drugs to give evidence today. Good afternoon.
Good afternoon. We're from Wynarda and we have Alcohol Change Australia online.
Right. Hello. Good. Well, I'll try and do this as seamlessly as possible, but I've got to go through it for everyone. For the Hansard record, could you please state your full names and the capacity in which you appear before the committee? And we might start with Mr. Dessauer.
Sure. My name is Paul Dessauer. I'd like to clarify I'm not actually the CEO of Wynarda. I'm the CEO of Peer-Based Harm Reduction WA, but I'm a member of the board of Wynarda, and I'm here with both hats on.
Good, thank you.
I'm Rochelle McIntosh, and I am the 2IC and Sector Development Manager at WNADA, which is the peak body for the alcohol and other drug sector in WA.
And Jill Rundle, the CEO of the Western Australian Network of Alcohol and Other Drug Agencies, or WNADA.
Good. And Alcohol Change Australia, would you like to give us your name
Thank
and the
you.
capacity in which you appear? Yeah.
I'm Erin Layla, I'm the Chair of Alcohol Change Australia.
And I'm Hannah Pearce, I'm Executive Officer for Alcohol Change Australia.
Great. Although the committee doesn't require you to give evidence under oath, I should advise you this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and tracks parliamentary privilege. To assist with the transcription of the public hearing, it would be appreciated if you could please state your name before responding to each question. And I now invite a representative to make a brief opening statement before we proceed to discussion. So I'm thinking WNADA would like to make a brief opening statement, and then we might follow with Alcohol Change Australia. But if we could keep the opening statement brief to allow time for questions, that'd be great.
Thank you. Jill Rundle, for the record, we thank the committee for inviting us to appear today. I acknowledge the traditional owners of the land on which we meet, the Whadjuk people of the Noongar Nation, and pay respects to elders past and present. The West Australian Network of Alcohol and Other Drug Agencies, WNADA, is the peak body for the specialist alcohol and other drug services in Western Australia. WNADA is an independent, membership-driven, not-for-profit association. Our membership is predominantly comprised of community-based, not-for-profit organisations, and we have close to 100 member services located across the state, metropolitan, regional, rural and remote locations. At least 90% of the specialist alcohol and other drug sector in Western Australia are not-for-profit. Our broad membership represents the system of services needed to respond to alcohol and other drugs. For example, we have community development and prevention services, harm reduction services, and treatment services including withdrawal, counselling, residential and aftercare services. All of these services empower changed behaviour for improved wellbeing. WNADA's two submissions for this inquiry emphasise the need for an effective governance structure and which oversees and monitors the implementation of the National Drug Strategy and the range of related strategies aimed at minimising harm associated with alcohol and other drugs. This includes harms associated with stigma and discrimination at a systemic level. Our third recommendation is related to regulation and provides a practical example of the role of a governance body to oversee and monitor nationally agreed developments, in this case the National Quality Framework, which was released in 2018. The National Quality Framework identified shared responsibility between state, territory governments and the Commonwealth under the governance arrangement of the Ministerial Drug and Alcohol Forum, which was disbanded in May 2020. The National Quality Framework identified the need for regulation of alcohol and other drug treatment services, specifically focused on those not receiving government funding. To date, regulation has not been achieved, as far as I'm aware, in any jurisdiction, including Western Australia. I do, however, acknowledge that there's been some developments in WA towards licensing and regulation, driven by, to a large extent, by a state inquiry into the significant, harmful and dehumanising practices at a service that was not funded by government. The last two of WNADA's recommendations, split over both submissions, are focused on systemic practice solutions, i.e. the need to support capability building across all human service sectors and support for community-led approaches or solutions that build on the evidence base for a balanced system of services that meets community needs. If there is interest in exploring these issues, we have two people presenting with me at this hearing as well that are well placed to contribute to the discussion. We have Paul Dessauer, you know what his role is, and also Rochelle. Paul is well placed to speak directly to the work of harm reduction services. Peer-based harm reduction WA is a consumer-led, peer-based service and the state's largest provider of health and harm reduction services for people who inject drugs. Harm reduction in general contributes significantly to reducing the impact on the health system. Rochelle is well placed to speak to effectively building cross-sector alcohol and other drug capability and brings experience of enabling community-led solutions. Concerns related to alcohol and other drugs do not happen in isolation, just as alcohol and other drug services need to be responsive to the many intersecting issues. All human service sectors need to be responsive to alcohol and other drugs, whether this is providing evidenced information, early intervention, or referring to appropriate specialist services, whether they're harm reduction or treatment services. WNADA's experience in supporting community-led solutions has contributed to raising awareness of the network of cross-sector services available and the need for these services to work collaboratively with the shared objective of improving wellbeing, including for people impacted by alcohol and other drugs. In summary, WNADA strongly believes the specialist alcohol and other drug service sector in Western Australia contributes to reducing the impact on ambulance, emergency departments, hospitals and the broader health system, as well as reducing the burden across human services generally. There are not enough alcohol and other drug services to meet community demand. There is a need for a systemic approach to address harms associated with alcohol and other drug use, which relies on cross-sector sector services responding within their capability to alcohol and other drugs. While more resources are clearly needed for the specialist sector, there is also a need for efficient collaboration that best meets individual, family and community needs. Thank you.
And we'll now ask Alcohol Harm Prevention Group to...
Thank you. Hannah Pearce. We thank the committee for the opportunity to appear today and to provide an opening statement. I'd like to acknowledge the traditional owners of the land from which we are joining today, the Wurundjeri people of the Kulin Nation, and pay my respects to elders past and present. Alcohol Change Australia is an alliance of health and community organisations working together to prevent and reduce harm from alcohol among Australian individuals, families and communities. The committee will have already heard extensive evidence on the harm caused by alcohol products. They contribute to thousands of deaths each year, placing enormous strain on our hospitals, ambulance services, law enforcement and justice system. You will also have heard about the extensive significant pressure on AOD treatment services, with demand far exceeding available programs across the country. But behind these statements are real people. They're countless Australian families whose lives are disrupted, homes affected, and wellbeing undermined by alcohol products. The scale of harm cannot be disputed. Today we will focus on what works to reduce and prevent harm from alcohol. The World Health Organization identifies 3 best buys: effective taxation, comprehensive restrictions on advertising, and limits on availability. These measures address the drivers of alcohol use, reducing demand for treatment services and improving outcomes across the system. Importantly, these measures aren't new. They're reflected in our national alcohol strategy. The issue is not a lack of evidence, but a lack of implementation. First, taxation. Over 15 years ago, Ken Henry called our alcohol tax system incoherent, and unfortunately, this assessment still holds true today. Public health advocates in the alcohol industry rarely agree, but you will hear from all quarters that the current system is broken. It taxes alcohol products inconsistently, making it inefficient, inequitable, and a driver of harm. Tax reform is feasible. The United Kingdom recently simplified its alcohol duty to address similar issues of complexity, market distortion, and administrative burden. Learning from this, Australia's Treasury should undertake evidence-based analysis and modelling to develop a simplified, equitable and transparent alcohol taxation system that better aligns fiscal and health objectives. The second of the WHO best buys is alcohol marketing. Australia continues to rely on a system of self-regulation that does not protect children and young people from exposure to alcohol marketing. The Australian government can no longer legitimise a system that is failing the community. It should withdraw from current arrangements and develop enforceable legislation to regulate harmful product marketing. The last of the WHO best buys is alcohol availability. While primarily a state and territory responsibility, it remains central to reducing harm, particularly in addressing alcohol's role in gender-based violence. National leadership on this issue is essential. Finally, these regulatory measures must be complemented by sustained investment in prevention. This includes public education campaigns, clear product labelling, and community-based programs that build capacity and reduce risk at the local level. In closing, the path forward is clear. What is needed is an increased focus on prevention, using coordinated, decisive action to implement measures that will improve the health and wellbeing of all Australians. Thank you.
Thank you. And we'll go to questions. So I think Ms. France.
Hi, I'm Ailey France. I'm the member for Dixon. Thank you all for giving evidence today to our inquiry. We appreciate you taking the time. I have two questions. First, for both WANADA and Alcohol Change Australia. What have you seen over the last 10 years in the complexity and the patient presentations that you think, the trends that you think should be addressed in a new national strategy or a new national approach? And the second question is specifically for WANADA. Could you just give some examples of non-regulated services and what's the evidence of their impact? So 2 questions, if that's okay. Thank you.
So the first question is...
First question for both of you, just around over the last 10 years since the last, the current strategy was developed, what's changed? What are the big things that need to be addressed in a new strategy? What's changed in terms of complexity or patient trends, presentations? Like, what are the big things that have changed?
Whether it's a change or not, Jill Rundle, sorry, from WANADA. Whether it's a change or not, we don't have enough services to meet demand, and we don't have enough harm reduction services to meet harm reduction demand. In WA, we did there was a national population modelling for treatment services. We also, in Western Australia, did a population modelling for harm reduction services and justice services and et cetera, et cetera. So we clearly do not have enough harm reduction. We do not have enough services, whether at whatever level, whether they're support, whether they're counselling, whether they're residential, whether they're withdrawal, et cetera, et cetera, et cetera. There have been some developments in WA based on to build the withdrawal supports, whether that's low, medium withdrawal, I know that David spoke about home-based withdrawal, but there's been an increase in low to medium medically supervised withdrawal. We've also seen some increases in some residential services, but nowhere near enough services to meet demand. The trends are perpetually changing, I suppose, in regards to different substances and different issues. In Western Australia, we have one of the highest rates, the second highest rate compared with Northern Territory in regards to alcohol consumption per population. We have the highest, if not the second highest, consumption of methamphetamine per population. The trends, the complexity of people presenting to alcohol and other drug services, more often than not, is as a result of inadequate response from cross-sector. So the alcohol and other drug services are seeing people with more complexity on the basis that they're not being picked up by other services. So that early intervention that can be happening at other services is not happening. So that is contributing to the acuity of conditions that present to alcohol and other drug services. Please.
Can I make a brief comment here? There are social and economic determinants of health, yeah? And that applies to people's mental health and to their alcohol and other drug use as well. The demand for alcohol and other drugs within the community is not necessarily something government has levers to control. So one of the trends I've seen most prominently in my work in the last decade is increasing housing insecurity, increasing cost of living pressures, and we tend to see more problematic patterns of substance use in response to those pressures. And so there's a temptation to think, that if we increase alcohol taxes that we'll see reduced alcohol consumption. But there is a price point where increasing the price doesn't reduce use anymore, it just creates incentive for a black market, and that's what we've seen happen with tobacco in Australia. So I think the alcohol taxation system most definitely needs to be reformed, and it should really be based on units of alcohol, yeah. but you need to have this broader perspective, more nuanced perspective, of what are the possible unintended consequences of focusing on one element of the picture and not looking at the rest. So the people who framed our national drug strategy had a really good understanding of this, and that's why they divided it into 3 pillars, and the idea is the 3 pillars are complementary. But if we overinvest in one or underinvest in another, we run the risk of accidentally creating problems. Yeah.
Did Alcohol Change Australia, did you have a response to?
Thank you. It's Erin Laylor speaking. I support the comments made by Jill and Paul. I think in addition to patient complexity, which they've addressed, there's also changing complexity in the world in which people are living, which is impacting on their alcohol and drug patterns of use and the harms that they may experience from them. And you've spoken about this with other people who've talked to you. One of them is COVID, natural disasters, a world that is becoming slightly more incoherent each day is impacting on people's resilience and their ability to cope, and often substance use is a result of that. We're also seeing changes in the way industry, particularly the alcohol industry, is marketing to individuals with what emerged during COVID, a real growth in online sale and delivery of alcohol into the home. We know that the majority of presentations, for example, to an emergency department occur from alcohol that is drunk within the home, purchased as packaged liquor. We also know that there's novel synthetic substances which are emerging. Stigma plays a huge part in the ability for people to be able to self-manage their substance use without significant harm. And we're seeing an increase in alcohol-related harms, increasing deaths, hospitalisations. To Paul's point, the allocation of investment to prevention and harm reduction as opposed to law enforcement and treatment is unweighted, with a heavy focus on law enforcement. So I think it's important not just to think about the complexity of the caseload and the people who are needing treatment, but to think about what we can do with the environment in which they operate to reduce the harms and pull the load off the treatment system as well.
Thank you.
Jill Rundle, just in relation to your second question of examples of unregulated services, the inquiry that I mentioned in Western Australia was the Esther Foundation inquiry, which found a number, as I said, a number of human rights abuses effectively at that service. And this service was not funded by government in terms of the delivery of the service.
So the National Quality Framework applies to any agencies receiving state or federal funding, but there are agencies that operate outside of that framework, and there's no regulatory oversight at all.
Thank you. Okay. Thank you.
Alice.
Hi, I'm Alice Jordan-Baird. I'm the member for Gorton. I represent community in Melbourne's western suburbs. We're one of the youngest electorates in the country, so I'm really interested on AOD use and its impact on young people. And I know Alcohol Change Australia do great work with a lot of our local sporting clubs, among many others. My question is around celebrity endorsements. There's no doubt that young people spend a lot of time on social media, and seeing, a certain celebrity with a certain seltzer or whatever it is very impactful. Could you provide your perspective on celebrity partnerships with alcohol companies for the committee? This is sort of a question to both of you.
Hannah.
I'm happy to start. Hannah Pierce, Alcohol Change Australia. We know that the alcohol industry uses influencers, celebrities to promote their products because it works. It's a tactic that works. There's evidence that children as young as 6 can recognise companies on their favourite sports stars, alcohol companies, gambling companies, etc. And so that is a strategy that the industry use to really market their products to young audiences. As I said, it works from a marketing perspective, but it's reflected in some of the trends we're seeing among young people's drinking. So the latest NDHS data shows that we have been seeing some falls in drinking alcohol use among young people. That in some some groups is actually reversing. So we saw increasing alcohol use among young women in particular, 18 to 24-year-olds, and the marketing from alcohol companies is a big part of that. So, we have a system of advertising regulation in Australia that is self-regulated. The alcohol and advertising industries fund the system, they manage it, they write their own code, and conveniently, a lot of the time, celebrity endorsement is not included because they explicitly state that they don't include sports sponsorship as a form of alcohol marketing. So it's a grey area that the industry is really using to their advantage.
Thank you. Do you have any comments you'd like to add?
Yeah, I'd love to. Rochelle McIntosh from Wanata. We've just recently worked in partnership with the Aboriginal Regional Governance Group in one of our regional areas to design, to revisit and redesign a approach to young people and alcohol and other drug use in the region, which is remote and very remote. And the findings from that, including the data and the research, is for this particular cohort, young and predominantly Aboriginal communities, cannabis is the primary drug of concern, and that is from very, very, very early ages, as young as 8 and 10, consistently reported across the community. And that's, again, consistent with other research into regional remote areas. Alcohol absolutely is an issue, but becomes more of an issue in the older years, and those older years being from 15 to 18 and then 18 to 25 and so on. So I think it's really important for some cohorts that we talk about there are other drugs that are primary drugs of concern, and the impact of that type of drug use, any type of drug use from very young ages, can be have permanent impacts for those children, obviously, their families and their communities.
Thank you. No further questions.
Monique, any questions?
Oh, thank you. I've got a question for Hannah, if I could, please. You mentioned that you think of our alcohol tax system as being incoherent, I think is the word that you used. Are you able to give us a bit more information about why you use that word in particular, and what you might propose regarding that taxation of alcohol in Australia?
I think you said Ken Henry said it was incoherent.
Yeah. Yes, Hannah Pierce, I did. I borrowed that phrase from Ken Henry. That was back in 2009 or 2010. That was his description of the alcohol tax system following his review of the tax system as a whole. So the current alcohol tax system is really working for nobody. The primary beneficiaries at the moment are the major liquor retailers and the multinational alcohol producers. The small independents, government and the community are the ones losing and the ones bearing the cost. So we essentially have a two-tax system when it comes to alcohol. Beer and spirits are taxed based largely on their alcohol content, so the stronger the product, the more tax that is paid. Wine is subject to the wine equalisation tax. That's a values-based tax, which means the cheaper the wine product, the less tax that is paid. And so that's how Aldi can sell $3.50 bottles of wine, and Dan Murphy's can sell 4 litres of cask wine for $25 or as little as 30 cents a standard drink. The tax system is favouring wine over other alcohol products. And then within wine as a category, the tax system's actually favouring the major liquor retailers who have become vertically integrated businesses. So they own the wineries, they harvest the grapes, they make the wine, they produce it, distribute it, market it, and then sell it in their retail stores. So, we've seen the review of the wine industry last year by Wine Australia highlighted the issues around these vertically integrated businesses and how they can manipulate the tax that they pay on their products, because they can artificially lower the wholesale price because a loss from the winery is a gain for the retailer. The parent company doesn't lose out at all because they're all owned by the same people. Small independents are not able to do that. They cannot manipulate the tax system in the same way. So the small independent wineries are losing. small craft brewers and craft distillers are losing because they're paying significantly higher tax on their products, despite beer actually having lower alcohol content than wine. We know that there's been at least 10 reviews, inquiries, consultations that have examined the tax system and said that alcohol should be taxed volumetrically. So wine products should be taxed based on their volume, like beer and spirits are. What we really need now is for Treasury to have a good look at the tax system, conduct the appropriate modelling and analysis that we need to determine what a reformed system with wine taxed volumetrically would look like.
Has that sort of volumetric tax been instituted in any other jurisdictions that you know of?
Yeah, so the UK provides a really good case study for Australia. Firstly, because the UK is quite a comparable nation in terms of it's a high-income, developed country. Pre-tax reform, their alcohol tax system was similar to us in that products were taxed differently, it was inconsistent, distorted markets. And thirdly, they've completed the tax reform over the last 6 years. So through COVID, through global inflation, through cost of living concerns, the UK Treasury has conducted a review of the tax system, identified that all alcohol products should be taxed volumetrically, and implemented a reformed system. And I will note that most of the reforms came in over a couple of years with transitional measures in place to support businesses that would have been most affected by the change system. But they have done that. They've also funded, the government has funded the University of Sheffield to conduct an evaluation of the reform. So they've got quite a comprehensive 5-year work program that is looking at the impacts of the reform tax system. And, it's early days, but to date they've found that there's been modest consumption impacts, so modest reductions in alcohol use. There's been limited impacts on levels of equity, so it's not causing greater inequity. And quite importantly, they've seen that the industry is reformulating their products to bring it to a lower tax rate, which from a public health perspective is a good thing. If people are choosing to drink alcohol, choosing low alcohol products is a good option.
Thank you. Do I have time for one more, Chair?
Of course you do.
Oh, thank you, very kind. Thank you. One more question, if I may. Last time we met, we heard from the ABAC about the alcohol advertising broadcasting code, and they had no concerns at all about that code or how it functions. Seemed quite satisfied with it in general. What are your thoughts about it and the extent to which it's effective?
I'm not surprised that they're quite satisfied, given it's funded by the alcohol and advertising industries. They would probably be quite happy with the performance. The issues with ABAC and self-regulation go back a long time. I would say ABAC is the perfect example of the fox guarding the hen house. They've written a code that's really narrow. It doesn't cover the whole industry, so it's voluntary. It has no penalties. So if an ad is found in breach of the code, they're told to remove it, and if they don't, there's no enforceable penalties in place. And so what we see time and time again is community members making complaints about alcohol advertising that concerns them. It might be an ad that their kid has seen while watching a YouTube video, or an alcohol ad during the broadcast of Carols in the Domain when the Wiggles were showing, and they just get dismissed because they're not in breach of the code and there's nothing that can be done about it. So it's very evident that self-regulation is failing in this instance, and the Australian government representative on the ABAC Management Committee is it adds credibility to a system that really is not credible. So as a first step, the Australian government representative should step off the management committee, and as a second step, we need a legislated form of advertising controls implemented.
Wow, Chair, can I just request that if you have any sort of supportive materials regarding that statement, that you'd be able to table them to the committee? Is that reasonable?
Yes, indeed.
Thank you. Really appreciate it.
And particularly if that's what you're recommending, that the Australian government representative be removed from that group, I think that would be important information.
Thank you. Thanks, Chair.
Good. Sam.
Thanks, Chair. Sam Birrell, member for Nichols. In your submission, I notice this sentence that struck me. Alcohol Change Australia further noted that empowering Australians with the knowledge that alcohol causes harm is an important part of a comprehensive approach to reducing harms. Would you acknowledge that alcohol is, whilst there is harm caused by alcohol, and we're hearing about that, most people use alcohol in a responsible way, and there are very limited, if any, harms, some would say societal good, from alcohol when used in moderation?
So I think, firstly, I would say that alcohol is a harmful substance, and we know that it's a carcinogenic. It's up there with asbestos and tobacco, according to the World Health Organization. It's a leading cause of injury, hospitalisations and death, and those harms are increasing. So I think we can't discount the harms from alcohol. We know that from the National Drug Strategy Household Survey, about 6 million Australians are drinking alcohol at levels that put their health at risk. So that's either a moderate or high risk group. So there are a large proportion of Australians who are not drinking alcohol in a way that doesn't jeopardise their health. It's only about a third of Australians drinking at that level. When we look at the people who are drinking alcohol at harmful levels, and we ask them whether they want to do anything about that, about a third of them say no. And that could be taken as a misunderstanding of the potential harms. It could be taken as a reluctance to do anything about their alcohol. All of those are completely understandable, and we understand that from behaviour change science that's been around for a very long time. But it does signal that there may be misperceptions amongst the Australian community about the harms from alcohol, which is why things like alcohol labelling on alcohol about cancer risks is being explored in other jurisdictions like Ireland and in some parts of Europe. It also indicates that we need to make it easier for people to be able to seek help. So the majority of people who are wanting to change behaviour want to do it themselves. About 80% of people want to do it themselves, and that's irrespective of whether they're moderate or high risk. And we know that if they are high risk users of alcohol, they are more likely to want the sorts of services that Wanada has been talking about, professional services that are delivered by treatment providers. So I think it's important to note that alcohol is not a harmless substance. Even when you drink at very low levels, you are increasing your risk of cancer. But the NH&MRC guidelines are clear around the levels at which the harm increases, and we know that that's more than 10 standard drinks a week and more than 4 in any one sitting.
So, you know, the evidence I've heard you give is very critical towards the alcohol industry, and I'd put it to you that the alcohol industry is probably an important part of Australian society, in the wineries and the breweries and that sort of thing, and employs a lot of people and creates a lot of enjoyment for people who use alcohol at a moderate level. So I just put that to you for comment, but also you're concerned about advertising, alcohol companies marketing and that being to younger people, but most of the analysts or people, when we've asked about trends around alcohol, they've told us that the trend for young people is away from alcohol and onto other possibly illegal substances. Would you agree with that? So that's a question in two parts.
I can take the second part of the question about the trends, and Hannah will respond to the industry part of the question. So as Hannah said, we have over many years seen alcohol use by people under the age of 18 declining. That trend is reversing, particularly in girls. So for the first time in a long time, we're seeing girls under the age of 18 more likely to use alcohol than boys, and more of them are using alcohol than they were in 2019. So in 2019, I think 28% of girls under the age of 18 had used alcohol. That number is now 35%. So the trend is not reversing. In the 18 to 24-year-old age group, we're seeing young women using alcohol at risky levels almost on par with young men. Young men were always the highest risk users of alcohol. That is not necessarily going to continue for much longer. So young girls, 18 to 24, about 40% of them are using alcohol compared to 45% of young men. So it's not a trend that is continuously going down. Yes, it was in the past, but that is reversing now. And a lot of it has to do with the way alcohol is promoted, priced and marketed, and that is about the alcohol industry.
Yeah, because, you know, the alcohol industry, their objective is to sell as much alcohol to as many people as possible. They're a for-profit business that sell a product. So that goal, that is their objective. There's no really denying that. And that objective does conflict with public health objectives to reduce harm from alcohol. But if, you know, say we look at tax reform, we're talking about wanting to reform the tax system. When we're looking at sectors of the alcohol industry, they're currently disadvantaged by the tax system. Independent winemakers and independent brewers are disadvantaged. The major liquor retailers are benefiting from the wine equalisation tax anomalies that exist, while the independents are facing higher costs and market barriers. Independent brewers pay significantly higher tax than wine producers. So when we're looking at tax reform, we're looking at achieving public health objectives, but we're also looking at addressing the inconsistency and anomalies that exist within the system that are disadvantaging sectors of the alcohol industry. And I think the other important element to look at is the cost of alcohol harm to Australia. So estimates are around $70 billion is what alcohol use is costing the Australian community, both in direct costs and indirect costs. When we consider what the industry delivers in terms of economic benefit, we have to take in the negative externalities that they're causing to our community and to our economy.
Could I just ask if there's a comment from the Wanata people on some of the points I've raised about alcohol use trends or, you know, alcohol's role in society and used in moderation?
Sure, Paul Dessar. I believe you're speaking with my colleague Paul Griffiths from National Drug Research Institute as well at some stage. He can probably speak more to large-scale trends. National Drug Research Institute, that's their job. We are seeing an increasing trend, as Hannah mentioned. I'm turning 60 next year. When I was a young man, everything was saturated with tobacco advertising. All sporting teams had the branding. Most of my colleagues and I, most of my contemporaries and I all started smoking in our teens. Paul Hogan was the spokesperson for anyhow, have a Winfield was a primary school catchphrase. Yeah. So Australia has addressed this sort of thing in the past. The tobacco industry was a very, very powerful industry. The alcohol industry is not a discrete thing. And I think Hannah has pointed to some of the inconsistencies in taxation, how it's actually favouring monopolies rather than supporting the local industry. So I guess there's a more nuanced conversation here. It's not about is the industry bad, it's about how do you regulate the industry.
I could also add that alcohol continues to be the principal drug of concern that of people accessing alcohol and other drug services. So that's been a constant, it continues as a constant. It is the drug that causes most harm and it's widely recognised.
And our modelling in Australia shows there's only about 50% of the places for treatment, as there are people in Australia seeking treatment for alcohol or other drug-related issues. So the treatment sector is most definitely underfunded.
Thank you.
Yeah, look, I've got a couple of questions, if I may, and I guess there is this perennial argument around alcohol availability and taxation, whatever, and we're interested in things we can do and things we can't. And I know that other jurisdictions have been quoted, but you know, they don't necessarily have a wine industry like Australia does. You know, there's no bottles of Cambridge claret on the shelves that I see, or whatever. So we do have to work within the reality of the situation. I'm interested in what we can do and what we can't. And a prominent thing that's come up is alcohol availability. and how we can look at recent trends, and COVID's been mentioned, and what's happened since COVID with the availability of alcohol 24 hours a day, ordered online or by the phone or whatever. Do you have any views on that, and whether we should be looking at reducing alcohol availability that way?
If I could just talk to, across Western Australia, we have various restrictions, different to different communities, different to different regions. I think, as Erin raised before, we need to raise a community awareness of the harms of alcohol and other drugs for that matter, so that the community can be empowered to make the appropriate choices. Restrictions or different sort of regulations or different processes will just result, as Paul indicated before, in slight grogging or in behaviour that criminalises their access to alcohol. So I think we've got to be careful of just having a top-down approach.
Yep.
Feeding in a much more of a community-led solution with raised awareness, so that we can tackle these problems, because the top-down approach just contributes to more and more complexities of how we might end up dealing with this problem.
Does that include the taxation approach as well?
Well, I think they need to come together I think we're very much supportive of minimum unit price and appropriate taxation and regulations of promotion, etc., and it needs to come with community awareness raising, and I think with community-based services who have their footprint on the ground in seeing what the issues and concerns are, and the communities that are experiencing these issues and concerns, they need to be empowered to have a voice to control what is going on in their communities.
Right. So, I mean, we've had education programs for a long time around alcohol harm, and maybe that's reduced consumption a bit, but we're still seeing high-risk behaviour.
Yes.
And we need to look at ways that we can reduce that. Taxation is one, availability is another, improving access to rehab is another. But there is evidence that reducing access can have an effect.
I'm not denying that, absolutely not.
Right.
I think that all I'm saying is it needs to come together with, and yes, there's media campaigns. I'm talking about grassroots community awareness raising.
Yeah.
That is actually needed. I think in some of and Rochelle can speak to some of this, just in terms of even working with Aboriginal community-controlled health organisations. There is no awareness of, at times there is no awareness of the harms of alcohol, and that there is an appropriate response. That we would like to see a response that is consistent with the specialist sector across all community services, whether that's the Aboriginal health services, whether or not that's domestic family violence, whether or not that's homeless services. There is no consistent approach to raising the awareness of alcohol and other drugs.
Mm-hmm. So a national campaign?
A capability building approach to raising, that includes raising awareness and a response, absolutely.
And, Paul Dessar, if I could just refer back to something I said earlier around social and economic determinants of health. You need a whole of government approach to these issues. If I meet someone who's homeless and they're drinking alcohol heavily, I don't expect them to stop drinking alcohol while they're homeless. I'm going to try and focus on getting them into stable, suitable accommodation, and then their alcohol use is going to be easier to deal with. As long as we're seeing these pressures in the community, as long as we're seeing life getting harder for people, increasing housing instability and so on, we're probably going to see increasing levels of problematic substance use. It's a coping strategy. And unless we take that broader view and look at if there's a community that's having issues, rather than trying to police the issues away, we should be trying to look at what we can do in that community to build its health. Yeah.
Yeah, and social determinants of health have been mentioned by virtually every group that's spoken to us, and I think there's a lot of agreement, but also a more connected response and a sort of a more one-stop shop approach, if you like, and stop restricting access to programs because of minor criteria changes. Yeah. Okay, if I can just go back to alcohol change. We have to be realistic about what we can recommend and what we can't. What are the three most important ways we could change the system if we look at it across the availability, taxation and advertising?
So I think Jill's touched a little on the way in which alcohol regulation and prevention programs and awareness programs come together. And I think it's worth remembering that the regulatory system sits around people within a community. So the Alcohol and Drug Foundation, I'm the CEO of the Alcohol and Drug Foundation, we run a program on behalf of the Australian Government called the Local Drug Action Team Program, where communities identify local needs and deliver local programs to prevent alcohol-related harm. 96% of the communities are demonstrating that they are doing that very, very effectively. But if they're doing work with young people in a community where it's very cheap to get alcohol, it's very easy to get alcohol, and alcohol is heavily promoted, it makes their efforts all that much harder. So we do need to think about investment in prevention programs, investment in awareness campaigns, because I don't know, Mike, that we've had a national alcohol awareness campaign in this country for very many years, apart from the FASD work, the wonderful FASD work that's happening at the moment. So we haven't really invested, as we have with tobacco, in getting Australians to understand harms of alcohol and how to get support to reduce their alcohol use. And then the issue of accessibility is often a state responsibility. So delivery of alcohol into the home is regulated through the Liquor Acts. There was commitment from First Ministers to look at the way that they may be able to address alcohol availability to reduce family domestic violence. We haven't seen a lot of activity associated with that commitment. The levers that the federal government has are much more around taxation, which is difficult. I think it's fair to say it's a difficult conversation to have, but we are seeing more countries recognise the benefits not just for community but for sector in taxation reform, but also in the way in which alcohol is marketed to individuals, particularly using online advertising.
And I'll just pick up in terms of recommendations around taxation. What we really need is Treasury to undertake some evidence-based modelling and analysis to help inform a tax system that both supports public health objectives as well as business objectives. And Treasury is well placed to do that as the central government agency.
I think that's a very, very good point.
Yeah.
Yeah.
Can I just layer into that as well? There's a lot of mention of campaigns, and Erin, I'm assuming you're talking at the national level when you mention campaigns, but you've also dovetailed down to the local drug action teams. Campaigns, to be effective in terms of community education and community-led change, are relevant at that local level. So a campaign could include or be inclusive of coordinated action led by community. And what is led by community in Kununurra is going to be very different to led by community in your electorate. So a campaign should be inclusive of coordinated activity, whether it's a national action or whether it's a regional or a local. That activity should be coordinated and be consistent and aligned with the pillars we've talked about and the dual approach or the balanced approach with prevention and those other levers that we can pull on.
Exactly. I mean, local government has been left out of the argument a bit, and they have significant power in terms like local planning laws, etc., around availability.
And are great enablers for coordinating action and bringing community along the journey in terms of the change journey and raising awareness, so that education isn't about education in a school system necessarily or a media campaign. It's about collaborating with community and having conversations and supporting different alternatives to drinking environments.
Yep. Good. Okay. Any other questions? No? All good? Well, thank you all for your evidence today. It's been been really valuable, and I think we've taken on board most of what you've seen and said. And I don't think you've been asked to provide anything, but if you have, could you forward it to the Secretariat by the next 2 weeks? You'll be sent a transcript of a copy of the transcripts of your evidence, and we'll have an opportunity to request corrections to any transcription errors. And once again, thanks very much.
Thank you.
Thank you.
Thank you so much.
Thank you.
So, I think we're getting the Treasury analysis of...
There's actually lots of...
minutes? Yeah. Secretariat will write to... Okay, we'll reconvene. I'd now like to call representatives of the University of Sydney and the Cicada and Alcohol and Other Drugs Knowledge Centre. It's Elizabeth Elliott, isn't it?
Yeah, she's not. It's overseas.
Yeah. Hello, Liz.
Hi, Michael.
How are you?
And I have with good, thanks. And I have with me Sharon Medlow and Fiona Roberts.
You're looking well. Good. I'll just go through the official statement. For the Hansard record, could you please state your full names and the capacity in which you appear before the committee?
Elizabeth Jane Elliott, and I am the Director of the NHMRC Centre of Research Excellence in Fetal Alcohol Spectrum Disorder and the lead of the New South Wales FASD Assessment Clinic.
Great.
Sorry, and I'm a Professor of Paediatrics at the University of Sydney.
Right. And you have with you?
I'm Sharon Medlow. I'm an Associate Professor at the University of Sydney and I'm the Manager of FASD Research Australia Centre of Research Excellence.
Good to have you. I've just got to go through these details. Although the committee doesn't require you to give evidence under oath, I should advise you that this hearing, which is in Perth today, of the Standing Committee on Health, Aged Care and Disability is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. Giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. To assist with the transcription of the public hearing, be appreciated if you could please state your names before responding to each question. I now invite you, one of you, to make a brief opening statement before we proceed to discussion.
Dr. Freelander, could we just introduce Dr. Robards first?
Yeah, so I'm Dr. Fiona Robards. I'm a Senior Lecturer and Senior Research Fellow at the University of Sydney.
Hi. Good. So welcome to all three of you. Would one of you like to make...
I'm going to give a brief statement.
Thanks.
So thanks very much for the invitation to speak today, and we acknowledge and pay respects to the traditional Aboriginal owners of the lands on which we live and work. Our Centre for Research Excellence brings together national and international research expertise to improve the identification, management and prevention of fetal alcohol spectrum disorder, or FASD, and translate research into better clinical outcomes. A critical focus of the CRE is prevention of the harms from alcohol use in pregnancy, which occurs in about 50% of all pregnancies and has consequences and costs for children, families and the broader community. Prenatal exposure to alcohol can result in FASD, a lifelong brain-based disability affecting learning, impulse control, language, memory and attention, and associated with birth defects and growth failure. We recently estimated that 3.6% of the general Australian population could have FASD. That is one child in every classroom. This is a higher prevalence than combined cerebral palsy and autism. Although potentially preventable, FASD remains under-recognised and underdiagnosed. Services are inadequately resourced and access to services is inequitable. Thus, wait lists are long and many children do not receive the early intervention they need to thrive. We need increased investment in health professional training and capacity and in publicly funded FASD-informed services in all jurisdictions. Community-level prevention programs reduce harm from prenatal alcohol exposure and remain critical. We require continued investment in public education campaigns, the ones you've just heard about, such as the Every Moment Matters campaign and the Strongborn campaign. We need enforcement of mandatory labels, warning of alcohol harms in pregnancy. We need support for community-led alcohol controls, including by Indigenous communities. And we need reinforcement of the NHMRC alcohol guidelines that recommend that there is no safe level of alcohol use in pregnancy and that women who are pregnant or planning a pregnancy should not drink alcohol. We must continue to fund the FASD Hub Australia, the National Organisation for FASD and Learning with FASD, which provide education and training to a wide range of professionals and to the community. Preventing alcohol-related harms in pregnancy also requires a strong universal health system response. we recommend routine prenatal screening for alcohol use in all pregnancies in all antenatal services. We need pathways for timely, non-judgmental treatment and referral for women who are drinking in pregnancy. This must be matched by improved access to alcohol and other drug treatment services, particularly in rural and remote areas, and they must have capacity to treat alcohol dependency in pregnancy. Long-term harm reduction also depends on legislating the levers that we know decrease alcohol harm, and these include taxation, pricing and limits on advertising and promotion. This requires political will and a commitment to preventing the alcohol industry from influencing public health policy. National assets such as the Australian Paediatric Surveillance Unit and the FASD Australian Registry and the new personal electronic patient records are essential for monitoring national trends in the prevalence of prenatal alcohol exposure and FASD and the impacts of prevention strategies, and these require ongoing support. The impacts of prenatal alcohol exposure, though, extend beyond health, and we recommend early routine screening to identify disability, including FASD, in schools and at the first point of contact with child protection and juvenile justice systems. We emphasise the need for long-term whole-of-system investment, including support for Aboriginal community-controlled organisations and for culturally informed responses to FASD, such as the Youth Koori Clinic. Finally, the National FASD Strategic Action Plan is due for renewal in 2028, and its implementation is being monitored by the National FASD Advisory Group, convened by the Department of Health. Funding will be required to revise this plan to enable it to address identified gaps in progress against the desired outcomes. Thank you.
Thank you. Sam, would you like to?
Yeah, thank you. I have had some experience of this in my electorate with people who are suffering from FASD and creating awareness about it. So there is that sense of awareness out there, the Red Shoes campaign. I'd like to ask you what the major cause of women drinking during pregnancy is. And when I think about it, I can think of there's probably three reasons. One is a lack of knowledge of the harm. Another one could be an acknowledgement of the harm but an addiction, or people drinking alcohol and not realising that they're pregnant. So having that time before you realise that you are pregnant, where you still drink alcohol, and then when you find you're pregnant, you stop, but maybe there's been some damage done. Can you comment on those? Are those the three? Am I missing something there, or are those the three scenarios?
Yes, you're absolutely right. First of all, people drink because they don't know they're pregnant, and most women will stop once they're pregnant.
Okay.
Unless they are alcohol dependent, and they can't then just stop. So we can't pretend that giving them advice or even information about harms will help them stop drinking. We've really got to provide specialist support. And my contention is really that support should be provided much earlier, before they even become pregnant. So we need awareness campaigns in schools, and we need GPs and primary health professionals and others to identify women who have a problem with alcohol before they become pregnant. So either they can use contraception, or they can be helped to stop using alcohol. And then the other reason is, yes, women don't know about the potential harms, and we've done a national survey and reckon that's still about 30%, although the Every Moment Matter campaign has been well evaluated and suggests that it's had tremendous reach and that awareness has increased. And then I guess there are the groups who are just disadvantaged by historic trauma and current disadvantage, and are living in overcrowded housing or are homeless, are living in domestic violence situations. and have little access to health services, and those include people in very remote communities.
And so I suppose the reason I asked, and whether there's any sense of what percentage are in the drink until find out you're pregnant, addicted, or just like the knowledge to know that there are harms, because that sort of that leads to the policy response. If there was, as you say, there's a lot of if a lot of it was lack of knowledge, then the awareness campaign might be there. But from what you're saying, there might be a better focused awareness campaign about if there's a chance that you might become pregnant, you need to do this. Or
yeah, there are two distinct groups. There's a general population. They need to know that, one, if they're drinking heavily, which many young girls are, binge drinking, they need to use contraception. Yeah. If they want to get pregnant, they need to stop drinking. Then there's the second group who need to be aware of the harms because they will stop drinking once they're pregnant. But the problem is that about 50% of pregnancies are still unplanned, and about 60% of women tell us that they drink alcohol during pregnancy. And then there's really the very small group who I do think require a very targeted response, and that requires identifying them well before they become pregnant, and that's the women who are alcohol dependent. Yeah. And there are many of them, and many of them tell us that they even alert health professionals, but that health professionals fail to respond. So I think we do have an added responsibility for that small proportion, but very significant proportion who cannot stop drinking just because they're warned of the harms.
Thank you very much. Thank you, Chair.
Monique.
Thank you. Thanks, Elizabeth. Good to see you. Can I ask you about, I was just looking at the Senate inquiry into FASD from 2021, and it's remarkable actually we've come a long way even since then. The warnings on alcohol products, on the label warnings, do you have any information on how effective they've been and any thoughts about whether they should be expanded to include warnings about other alcohol-related risks? We've just been having a conversation about the cancer risk associated with alcohol, for example, and the fact that I suspect most Australians aren't aware of that. What are your thoughts about the on-the-label warnings that we have in place right now?
Well, I'm very pleased that we've got them in place, because we first went to talk to Nicola Roxham about mandatory labelling back in 2010. And I think it was 2023 when they became mandated. And it is clear from evidence overseas that the labels raise awareness in the general community about the harms of alcohol. And we had a lot of battle about the type of label, so it had to be large print, black and white, with the red that attracted the attention and incited a warning in people. I'm not aware of any evaluation of the effectiveness of those labels in Australia, but I am aware that they are being well complied with. The labelling is being well complied with, and certainly anecdotally there's increased community awareness. There is a slight problem with them, and I think there's been some evaluation done by Simone Pettigrew in that the warning labels don't seem to apply to online sales. And so I think that's a little loophole that's being attended to. So all I can say is that the rationale for the labelling came from international evidence. I think it would be very good to evaluate the effectiveness of them. And that may be underway, and I know Simone has been doing some work in that regard. Overseas, as you know, there are much broader warning labels which advise about all the other harms of alcohol. Again, I don't know whether those have been well evaluated. I guess it could be like cigarettes that we rotate those labels. I suppose from our point of view, rotating out of the pregnancy warning label and into the liver disease or brain injury label might, detract from the prevention of fetal alcohol spectrum disorder and I might say the many other harms that occur from alcohol use in pregnancy before you even get to the level of fetal alcohol spectrum disorder. So it's hard to know. I think we perhaps should be looking, and we could undertake to do that, to look at the evidence of the effectiveness of the labelling, whether that's being evaluated in Australia, and what has been the impact of multiple labels overseas on the pregnancy warning.
Interesting. Thank you. That's really interesting. So just to clarify, so the online advertising of gambling doesn't or didn't?
Of alcohol.
Sorry, of alcohol, sorry. One joke, one. Of alcohol.
Get me into more trouble.
Doesn't necessarily?
There is a paper that showed up that loophole, and I will send that to you. But my understanding was that when you went into those online sites and ordered the alcohol, the labelling wasn't evident, whereas it is evident on all alcohol products and all packaging that you would buy in a shop.
Okay, thank you. That's really interesting. Thanks, Chair.
Alice.
Thanks so much for appearing for our committee today. We've heard quite a bit about FASD over the course of this inquiry, and it's really interesting. I didn't quite realise. I think you mentioned, Professor Elliott, 3.6% of the general population may have FASD, which is pretty significant. My question is more around school resourcing and how we can sort of create more awareness in the younger years. Do you think there's a role for us to work closer with the Department of Education to embed FASD awareness in the curriculum? Do you think it's something that every student should learn about when they get to a certain age?
Absolutely, and I can tell you that we have been working very closely with the Education Department and with early childhood workers. So we've developed some resources for the early childhood group, and they have been very well received. And we have currently got funding for a website called Learning with FASD, and we have developed resources for both primary and secondary school teachers, with input from educators and with input from people with lived experience. And we have currently got I think it's either NHMRC or MRFF grant application in to try and do a large cluster randomised controlled trial to introduce a module into high school education. And that module would include the harms of alcohol use, the harms of alcohol use in pregnancy, and contraception, because they all go very well together. And that work is proposed as a collaboration with the Matilda Centre, who has extensive experience in education, particularly regarding mental health and drugs and alcohol in schools. And we would propose to run this trial in 60 schools in over 4,000 children, and it would be really a world first if we got funded for that. So yes, I agree that we really do need to get in early, and perhaps we need to be getting in even earlier than high school. So we need to provide teachers with the supports, which I think we're doing, and early childhood educators, and we now need to inform school students themselves.
Thank you. Hi, I'm Ailey France. I'm the member for Dixon. I'm just, obviously prevention is much better than, is the best way to treat, before FASD happens. I'm just wondering about the assessments and how we diagnose FASD and what you would recommend around, like, where do you see that being most effective in newborn screening? Is it at early childhood education? Is it school referral? And is there a problem in general with, obviously some of it's in newborn screening, it's kind of like parents admitting that they've had a problem and owning up to it. Just any insights you have into where screening would occur?
Screening or prevention? I mean, I think
screening.
If I can go to your first point about prevention, I totally agree. We see children in our clinic every week who have, substantial challenges, and we see families where there are 4 or 5 affected children with these complex needs. So preventing alcohol use in pregnancy, and we've already discussed that to some extent, is crucial. With regard to early identification, which can then prevent some of the complications and the adolescent and adult problems, yes, the earlier the better. So again, we recommend, and we've just done a big trial in Hunter, New England, where we've screened people as early as possible in pregnancy, and we embedded the questions about alcohol in the electronic maternity records. And when doctors or nurses asked the question, they were then prompted with advice as to what they should do. They should reassure the woman, but tell them about the harms, or they should provide a brief intervention, which has been proven to be effective in helping women stop drinking, or if they were alcohol dependent, they should refer them to the appropriate service, and that service came up on their screen. So that's one approach. The second approach is the screening, and what we are doing at the moment is working with SUPS, which is the Substance Use in Pregnancy Program, New South Wales, and they are referring to us any child who they identified was exposed to alcohol prenatally. And we've established within our New South Wales Assessment Service a baby clinic. So we see these babies and we establish rapport with the parents, and then we follow those babies till school age. So whether or not they ever end up with a diagnosis of fetal alcohol spectrum disorder, we do identify if they have problems early, and we can provide them with early intervention. Otherwise, the age that we tend to see children in our clinic is between 8 and 9. When they're in primary school, they've got major behavioural problems, they've got problems with attention and learning. And, it's really often quite difficult to manage their behaviours even at that age. But again, the earlier they're identified and the earlier supports are put in place, the better they will do. And the better supported the parents they have, the better they will do. And the majority of our children in Australia with fetal alcohol spectrum disorder live in out-of-home care. So probably about 80% of them live in out-of-home care. So again, when any child goes into care, Child Protection should be asking about prenatal alcohol and other drug exposures, and should be looking at the maternity records and really providing the foster parents with as much support from early on as they can possibly give them. We know that children with good support will do better. We know that the brain is very malleable in early infancy and early childhood, and that early interventions have much better effectiveness than interventions provided later.
Thank you.
Thanks, Sally. Thanks, Liz, and thank you for all the work that you and your team have been doing over many, many years.
40 years, Mom.
It's still ongoing and valuable work, so we do appreciate it. I think that we know that there are cohorts at high risk. Should we be doing more in terms of supporting and educating those communities? It's already been brought up that...
When we developed the original guidelines for the assessment and diagnosis of fetal alcohol spectrum disorder, we did look at the developing a screening tool, and really the conclusion after literature review and expert consultation was that screening the general population was not going to be viable.
Yep.
However, there would be potential for screening at-risk populations, and I think the particular ones are any child going into foster care must be screened. Because if you're adopting or fostering a child with a severe congenital heart disease, a lesion, you need to know that they may develop symptoms, they may require treatment, they may require surgery, etc. So we do need to screen any child going into foster care. We need to, or adoptive care. We need to screen any child who comes in contact with the juvenile justice system. And FASD has been in the news, as you know, associated with time for adult crime, associated with the move to decrease the age of incarceration, associated with the civil unrest in Central Australia, with the Banksia Hill detention, all of those, FASD has been implicated in all of those things, and many of those children have had recurrent contact with the justice system and have never been assessed in any way, let alone for fetal alcohol spectrum disorder. Their cognitive impairment, often quite significant intellectual disability even, has never been recognised. So any child in contact with the justice system should be assessed and treated appropriately. And then any child who is identified as having neurodevelopmental problems at school, and as you know, we now have a national universal sort of screening for neurodevelopmental problems.
Yeah.
You know, this is one of the issues that should be thought of. Obviously, it's only one of hundreds of causes of neurodevelopmental delay and disability, but it should be considered.
We should have national recommendations, shouldn't we, around those areas?
We should. So they're the three big populations: out-of-home care, juvenile justice, and what was the third one? Foster care. And of course, we know that there are pockets of high alcohol use, not in all communities, but in some Indigenous communities, particularly the very remote communities which have been highly impacted by historic and current trauma. And then I suppose, obviously, kids who are siblings of a child with FASD or who are born to a mother who's known to be alcohol dependent.
Yeah.
But it's extraordinary to us in our clinic how often, as I said, we might see 4 or 5 children in different foster care placements from the same mother who have severe problems, which could have been prevented.
So some recommendations around a national at-risk screening program would be...
Screening of targeted screening of high-risk groups.
Okay. But how about for the communities themselves, where these kids are coming from? What can we do for them?
Well, the Aboriginal communities, in fact, have really led the way, and I was listening to the people giving evidence previous to us, and as you know, communities such as the Fitzroy Crossing community in the Kimberley in Western Australia have led community-led alcohol restrictions, which have been evaluated formally and found to be highly effective in decreasing the amount of alcohol that's sold, and in informing campaigns which have led to reductions in alcohol use in pregnancy. So yes, I think community control is a very important aspect of all of this.
Yeah.
And any program of prevention needs to be co-designed with the local community, and if it's an Aboriginal community, they're highly heterogeneous. So, and NACCHO has done an extremely good job as part of the Every Moment Matters campaign in developing resources for people living in Aboriginal communities and people working in Aboriginal communities. So there has been a lot of groundwork done, and perhaps they just need support to enable them to continue those education and support campaigns.
Great. Would any of your colleagues like to make any comments? Any information they think we should have?
Or Fiona?
Just wondering if anyone's interested in our research program as part of the Centre of Research Excellence. I'm happy to take any questions about that.
Sure. Are you looking Australia-wide with your research program, or is this... do you want to tell us about it?
Yeah, so I'd love to. It's organised in 3 streams, and the first one's looking at national data, so very much national surveillance and bringing that all together. And we're also looking at birth cohorts and comparing these with birth cohorts from overseas. So we're creating a really comprehensive picture of FASD here and comparing with data overseas. And as part of that, we're looking also at the true burden of disease, so looking at comorbidities in mental and physical health. And one of the really interesting projects it's in Australia first. We'll be looking at the health economics associated with FASD. And that will be looking at it in two ways. So one will be what's the cost of making a diagnosis, so the program cost to the assessment service. And the second way of looking at it is what is the cost to the individual and society. And we're looking at that really broadly, so adverse impacts in, say, education, justice, emergency departments and so forth, MBS, PBS, NDIS, all of those costs. So that's going to be, we think, really, really useful. At the moment, we tend to draw on overseas data when we talk about costs. So we know that they're high, but it'll be a really interesting piece of work. Yeah. And then just briefly, our other two streams of research, we're looking at diagnosis and management. So we're trying to think about how to have an accurate and effective diagnosis as early as possible, has already been discussed. And we know that it's quite expensive to come to our clinic for the government, and there's a long wait list. So we're thinking about what sorts of novel technologies can we be using that make access a bit easier, a bit more cost effective, and then of course looking at management and treatment when someone does have a FASD diagnosis. And then thirdly, we've spoken a lot about prevention today, and that's our third stream of research, and we're coming at that at all angles. So we had a question about education, and Liz has already spoken about that quite a lot, but education resources both for educators themselves and young people before they become parents. We're looking at helping clinicians to ask and advise about alcohol. And then we've got a program of policy research led by Dr. Robards here, and that allows us to translate all of the evidence, no matter what topic that we're studying, into policy-ready briefs and things ready for submission. So we hope that will be helpful nationally.
Yeah. Over what period of time is this research project running?
We have 5 years of funding, and we've just begun at the beginning of this year. So we'll be ending at the end of 2030. And of course, well before that time, we'll be thinking about the sustainability of the research centre and how we can continue our projects, because they're, a lot of them, you require a lot of long-term input. So, for example, some of the birth cohorts we're following, of course, we follow them as the children get older, and we learn more and more about that. Yeah. And then we've got the original projects we proposed, but we're thinking of new ones all the time. So we're hoping to have a long future, but 5 years is guaranteed.
Where's the funding from at the moment?
This is an NHMRC Centre for Research Excellence grant, which is the large sum of $3 million for 5 years, and there are 20 investigators, and we've got multiple projects. So, we will of course be applying for refunding at the end of that period, but there are a very small number of those grants given.
Great. Thank you. Any questions?
And so, I think in the future, and one of your questions was about data collection and research, would be, either sort of larger supports for these national collaborative centres of research excellence, or a longer duration for the grants, or both.
Great. Thank you. Any questions?
Fiona, did you want to make any comment?
No, I'm all good, thanks.
Well, I'm just interested, Chair, if I may. I mean, what would be the optimal way of giving you, permanent long-term support for the sort of data collection that you've instituted, but would like to, no doubt, continue in the long term? I mean, the issue with NHMRC or any other medical research grant, obviously, is the time-limited nature of the funding, and sometimes, I guess, limits to the scope of what you can undertake. Do you have any thoughts as to?
Yeah, look, I think money is scarce, but we know that there is some money that's unspent, which has been put aside for research. And I think that we need to look at perhaps comparative schemes. I understand that other schemes, I think the ARC, but I'd have to check that, provides a much larger amount of money for centres of research excellence, which are national endeavours designed to bring networks of researchers and clinician researchers together, and also to provide capacity building for the next generation of researchers. So, I think looking at the way in which that funding is provided and whether it's commensurate with the number of projects and the number of researchers and you know, whether 5 years is long enough to really make an impact would be worth reviewing.
Great.
Karen, did you want to comment?
Yeah, so it'd be wonderful, I guess, if it were possible not to have to be in a competitive round all of the time, because a lot of time it has to be spent creating those proposals, and I can understand that. But if there was some means of thinking that a research program, maybe it's competitively funded to begin with, but that it's working really well, it's been very effective. I wonder if there could be some sort of a mechanism for that then to evolve into sustained funding. And I think it would have proved its value at that point. So that's a model I'd like to see.
I mean, for example, Monique, NHMRC used to have a scheme called the Enabling Grant Scheme, and what that was to do was to enable infrastructure. So it was, for example, to enable, you know, national surveillance, or to enable a specific mechanism. And then, of course, the projects had to be funded on top of that, but it just provided security in the long term for an endeavour in an ongoing way. So, for example, we hope that the FASD Hub Australia, which is the website for health professionals, policymakers and researchers, would be something that might get infrastructure funding. Similarly, the national data collection. Similarly, the training for health professionals in how to use the diagnostic guidelines. Those sort of things are really key.
Yep.
Thank you.
Good.
Thanks, Chair.
All right, well, no further questions. Thank you, all of you, for your attendance today. If you've been asked to provide any additional information, would you please forward it to the Secretariat within the next 2 weeks. You'll be sent a copy of the transcript of your evidence, and we'll have an opportunity to request any corrections to transcription errors. And once again, thanks for giving us your time from all different places. It's been very, very valuable. Thank you.
Chair, excuse me, Chair, did you want to hear from the Alcohol and Knowledge Drug Centre? Because there is an intersection with FASD.
Sorry?
That's the next. It's in the separate.
This is a different inquiry, isn't it?
No, same inquiry.
Oh, it's a different...
Witness, additional witness.
This. Oh.
Yeah.
I didn't see the additional witness. Where is that?
So, under, where are we up to? The National Drug List. Yeah, Alcohol and Other Drugs Knowledge Centre. That's where they're from.
I didn't realise they were on the line. Look, I'm sorry. We didn't realise you were online. Would you like to introduce yourself? And
yes, absolutely. Yep. Professor Bep Hewick, the Director of the Australian Indigenous Health Infonet at Edith Cowan University, which runs the Alcohol and Other Drug Knowledge Centre, which is federally funded.
Right.
The Alcohol and Other Drugs Knowledge Centre is Australia's only dedicated national online hub for Aboriginal and Torres Strait Islander information about alcohol and drug use and research and policy. We do have a section dedicated to FASD, but we are in internal discussions around removing that section and renaming it around AOD use in pregnancy, because we are concerned about the focus on single indicator research and the single indicator focus on complications in pregnancy around AOD, particularly with the absence of discussion around the impact of smoking in pregnancy.
Right. And you listen to Professor Elliott and her colleagues?
Yeah, it's quite, as an Aboriginal woman myself, it's quite upsetting to hear that evidence. At the Health Infonet and AOD Knowledge Centre, we have a very strict evidence-based approach to placing information on our database, which includes peer-reviewed studies. Not to say that all those peer-reviewed studies are ones that we would recommend that practitioners listen to because of the low levels of evidence contained within them. We encourage people and consumers to read that evidence based on logic really and best practice science. And we have, grave concerns around some of the evidence that sits around FASD.
Okay. So we might just open it up for questions then. Monique, would you like to?
Yeah, thank you. I'm sorry we didn't the interface is a bit complicated. We didn't realise that you were there.
Okay.
I apologise for that. Could I ask you, Professor Bring, could you explain what's the nature of your concerns around the information? Are you talking about the stuff that's on the hub that Professor Elliott was referring to, or activities around FASD in general?
I will say on just the point on the hub, I note that under the Aboriginal and Torres Strait Islander resources section, there's about 46 listed, whereas on our FASD portal, which we currently have, there's over 275 publications, 29 policy documents, 37 programs, 95 resources and 14 organisations. So I'm not sure why the FASD hub hasn't captured those. But the concerns centre on single indicator research in pregnancy and this focus on single indicator research of what affects neurodevelopmental conditions. As you would be very aware, it's very impossible to disentangle what happens in childhood development once baby comes out of the womb. In the Fitzroy Valley study that's often cited, the exposure to early life trauma was removed from modelling due to low power in the sample size, and I don't believe that's been modelled or included again in models. So the original focus of that project being alcohol exposure and exposure to early life trauma, although only alcohol was focused on. We also have other teratogens, smoking, cannabis use, methamphetamine use that I haven't heard discussed, which need to also be screened for. And I also gave a keynote presentation towards the end of last year to the International Family Nursing Association, pointing out international research with Black mothers in America, for example. You could take a social factor such as racism. So mothers' experience of racial discrimination in healthcare is associated with the same level of executive function deficit that is reported in the FASD papers, which raises the question as why we don't have a racism in utero exposure disorder. It sounds absurd, but to me that's the absurdity level when we talk about single indicator research in pregnancy.
Okay. I think that you raise a fascinating and an incredibly important point, which is, the intersectional or compounding influence of I guess, things that can negatively impact children's early development. Do you have suggestions for us on how we could better understand how we can study these things and follow them longitudinally?
Yes, absolutely. So birth cohort studies, which are discussed, are an excellent way. They're very limited in Australia for Aboriginal people in particular. Very few studies at the moment recruit Aboriginal people into birth cohort studies, but following those to look at a comprehensive set of factors that sit around pregnancy and then into childhood, where you have enough power, enough representation in your sample to be able to model the multiple influences. It's called an interaction effect. There are lots of ways that you can model that quite easily to understand the proportion of variance in individual differences in disease and healthy outcomes that are attributable to certain factors. Most often than not, what we see in international samples is that it is an interaction effect between multiple factors. So you could have maternal alcohol use and domestic violence exposure interacting to create what we see as an outcome in the child. There's also child health outcomes such as hearing, which was also very impaired in the Fitzroy Valley study, and again, just the limitations in the diagnosis and the assessment of Aboriginal children with non-Aboriginal tools.
So such important issues, so important, I guess, that we look at them in detail and well. I guess that comes back to the last question that we were discussing with Professor Elliott and the team from the University of Sydney, how best to do that? Because we're talking about things which need to be done in detail over a long period of time with people, with the scientific knowledge, but also the cultural sensitivity required. How best would you propose that we do that?
Yep, so there's examples. There's Professor Sandra Eads from the University of Melbourne, who runs the Next Generation study, which is a birth cohort study, longitudinal study of Aboriginal children. There's expertise in Australia around recruitment of Aboriginal families into birth cohort studies that could be funded. They just need to have a whole holistic health focus in terms of looking at factors other than alcohol included, but other than alcohol, that bubbies are exposed to in their developmental journey, as well as correct assessment of their developmental abilities. There's opportunities for longitudinal research, although we would strongly urge that comes from a holistic healthcare model to look at all the factors that impact child development. There's also the Tackling Indigenous Smoking team, who, although are a service-focused team, have research capacity to also look at the impacts of smoking and pregnancy, and are doing quite a bit of work around preventing smoking and pregnancy. But we have quite a substantive list listed on the Alcohol and Knowledge Drug Centre research indicating some of the deficits that come, the health problems that come with smoking and pregnancy. So a birth cohort study that truly looks at the multiple indicators of child development and maternal outcomes would be the way to do it.
Yeah, okay, great. Thank you. Thanks, Chair.
Yeah, thanks. And look, sorry that we didn't hear from you as part of that original group, but let me get it clear. You feel that Professor Elliott's work focused too much on just one factor. Is that your concern? And that some kids who may have other neurodevelopmental risks may well have other causes rather than alcohol? Is that what you're saying?
Yes. Yep. Yeah, so the downstream consequence of that is anecdotally from community, from my own community, from communities we speak with in the Alcohol and Drug Knowledge Centre work.
Sorry, where's your community? Pardon my...
The Noongar community.
Sorry?
Yeah, I'm a Noongar woman. A Noongar woman.
Right. Okay, yep. And...
So the downstream consequence being that if we have campaigns to have children assessed for fetal alcohol syndrome, syndrome disorder, then we miss opportunities to look at other factors in children's lives that could be contributing to the difficulties that they are presenting with. We also have what we might call a reinscription of a colonial narrative as Aboriginal mothers as unfit parents. And although a lot of work has been done to reduce the bias in FASD diagnosis, when you're essentially saying that the deficit was within the child and the family, you are taking away from solutions around why there is such a level of alcoholism, for example, disadvantage, family violence in a community to start with.
So the intervention from the beginning.
Very different.
So it stigmatises...
What's that, sorry?
It stigmatises from the beginning.
Stigmatises from the beginning and directs attention towards a very narrow level of intervention rather than all the factors we know affect community health.
Yeah. And have you made a submission to the inquiry?
No, I haven't made a submission. I have my submission here on behalf of the Alcohol and Other Drugs Knowledge Centre, and our submission based on FASD is to move away, to communicate that we are moving away from that labelling on the website, and we'll be transitioning to labelling it around AOD use in pregnancy, again, to look at those multiple indicators.
Right. Okay, and your submission is here with the committee? We received... I
can send it through. I haven't given I wasn't asked for a written submission. We have other broader recommendations on the dissemination of research for alcohol and drug use and policy for Aboriginal and Torres Strait Islander people, which is in that submission as well.
Right. So sorry, I'm not clear. Have we received a submission?
No, she's going to send it through.
You will send that through?
Yes.
Can we accept that as a submission now?
Oh, once we get it, we'll have to read it first.
Yeah. Okay, if you could send that through to us as soon as possible, yes. That would be good.
Yes, no problems.
And hopefully we'll see that in the next few days.
Yeah,
good.
No problems.
Are there any suggestions of what you think we should do as a committee in our recommendations about FASD?
I would question why there is an Aboriginal and Torres Strait Islander section on the FASD hub that isn't as comprehensive as at least the one that is provided on the Alcohol and Other Drug Knowledge Centre, noting that we aren't specifically funded to collect that information, but we do it, we get captured in it. The other broad recommendation is that regardless of the condition we're talking about when it comes to alcohol and drug, conditions in Aboriginal and Torres Strait Islander populations. Our stakeholders, so our practitioners on the ground, tell us that they don't have the time to implement the evidence into the practice. So they don't have professional development and work development opportunities. So our recommendation would be building in that professional network of practice where they can learn from each other. That is something that practitioners call for. That is something that was recommended in the DAP funding review, the final evaluation report, to mimic something like the National Best Practice Unit that the Tackling Indigenous Smoking team have, which we are also a part of at the Health Info Net. So our recommendation would be a national best practice unit to between alcohol and drug workers and policymakers, researchers for Aboriginal and Torres Strait Islander people.
Great. Thank you very much. Any other questions?
I don't have any other questions. I just wanted to thank you, Professor Ewing, for your insights. I think they're really important. I think it's something for us to think about, you know, what other, you know, uses that pregnant women might be going through, like nicotine addiction and other things like that. So I think it's a really important point you made. So thanks for appearing today.
Thank you. Thank you. Thank you.
Thanks very much. We will now have a short break and we will reconvene at, I think, just after 3:30. Good. Now, witnesses from Dr. Kelly McNamara, Miss Ebony. Oh no, this is sorry. Yeah, Ebony Quintrell and the National Drug Research Institute to give evidence today. And for the Hansard record, would you please state your full names and the capacity in which you appear before the committee before giving evidence? So would you like to start from Ms Quintrell?
Yes, Ebony Quintrell, and I'm appearing in an individual capacity as a researcher at UWA.
Great. And
I'm Professor Paul Griffiths. I'm the Director of the National Drug Research Institute, and we're here representing Entry.
Good.
Yep. Dr. Jodie Grigg. I'm a Research Fellow at the National Drug Research Institute.
I'm Professor Simon Lenton from the National Drug Research Institute. We've also got 4 of our staff in our Melbourne office online.
Oh, okay.
Need to get.
So we get them. Will they be giving evidence? Or?
They've been given login details. They should have logged in. They have, yeah.
Yep.
So there's 5. I think there's 4 or 5 people online altogether.
They just need to talk.
Okay. For people online, hello.
Hello. Howdy.
Would
you like me to introduce myself?
Would you like to introduce yourselves? It's a bit difficult if they're not together.
Sure. I'm Professor Paul Dietz from the National Drug Research Institute.
Welcome.
Nick.
I'm Professor Nyanda McBride from the National Drug Research Institute.
Nyanda, go again.
I'm Dr. Oh, sorry.
I'm Professor Nyanda McBride from the National Drug Research Institute.
Nick.
I'm Dr. Nick Taylor from the National Drug Research Institute.
Welcome.
And is Michael Curtis with us today? It seems not.
And Kelly McNamara should be online too.
Sorry, I am. I was just having troubles getting microphone permissions. Dr. Michael Curtis, I'm a research fellow from the National Drug Research Institute.
Hello, welcome. So welcome everyone. This is just the details I have to go through.
And sorry, I'm online as well.
Dr. McNamara.
From the University of Newcastle, I'm an obstetrician.
Could you just repeat that? You're a bit quiet.
Sorry, I'm Dr. Kelly McNamara from the University of Newcastle. I'm an obstetrician gynaecologist.
Welcome. Although the committee doesn't require you to give evidence under oath, I should advise you that this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and tracks parliamentary privilege. I will invite you to make a brief opening statement and to assist with the transcription of the public hearing. Be appreciated if you could please state your name before responding to any question. I will give the committee a chance to introduce themselves, given there's so many people online, starting with Mr. Birrell.
Sam Birrell, Federal Member for Nichols, which is in Northern Victoria, and I'm the Shadow Assistant Minister for Agriculture and Regional Education.
Monique Ryan, Member for Kooyong in Melbourne and Deputy Chair of the Committee.
Mike Freelander, Member for Macarthur in South Western Sydney and Chair of the Committee.
Alice Jordan-Baird, Federal Member for Gordon in Melbourne's Western Suburbs.
Ailey France, I'm the Member for Dixon in Queensland.
Good. So would one of you like to make an opening statement?
Yeah. So it's Professor Simon Lenton from the National Drug Research Institute. Wonderful to have the opportunity to speak with you today. We put in a large submission back in November 2024, a 44-page submission with many hundreds of references attached to it. Yep. I don't think you all read it on the plane on the way over, that's fine. But let me just say that each of the people we have online speaks to a different part of that submission, and rather than taking up a lot of time summarising what's a large document, let me just tell you that we have addressed the following topics: the cost of alcohol and other drugs in Australia, responding to alcohol-related harm, school alcohol and drug education programs, fathers' contribution to exposure to alcohol-exposed pregnancies, harm reduction, drug overdose and toxicity, and prisons and people who inject drugs. Across those topics and any other questions that you have, we'll respond as appropriate.
Fantastic.
That's about it from us in terms of an opening statement.
Great. Thank you very much. And Ms. Quintrell, would you or Dr. McNamara like to make
Yes, I have an opening statement on behalf of both of us.
Thank you.
Ebony Quintrell. So thank you for the opportunity to appear before the committee. My name is Ebony Quintrell and I'm an epidemiologist presenting today in an individual capacity as a research fellow at the University of Western Australia. I've recently completed my PhD examining alcohol use disorder and alcohol withdrawal in pregnancy and the use and safety of pharmacological treatments. Joining me online is Dr. Kelly McNamara. Dr. McNamara is an obstetrician and gynaecologist at the University of Newcastle based on the Central Coast, New South Wales. She provides clinical and research expertise in substance use in pregnancy, and her PhD examined links between substance use disorder and unplanned pregnancy and birth outcomes, informing contraception pathways within alcohol and other drug services. Dr. McNamara recently contributed to an international review of clinical guidelines for the management of alcohol use disorder in pregnancy. There is no known safe level of alcohol use in pregnancy, therefore abstinence is recommended due to the risk of harm, including fetal alcohol spectrum disorder. However, not all women are able to stop drinking without assistance. There are significant gaps in clinical guidance for women who enter pregnancy with an alcohol use disorder, which is a medical disorder characterised by repeated or continuous use of alcohol, with many people experiencing dependency. Guidance is lacking on how to best identify alcohol use disorder, manage it safely and provide pregnancy-specific care. These shortcomings are evident in national and international guidelines and reflect a broader lack of research in this area. Alcohol use during pregnancy in Australia is common, with cohort studies suggesting up to 60% of women consuming alcohol at some point in pregnancy. Although many women reduce or cease consumption once pregnancy is identified, harm may have already occurred and a small proportion continue to drink at harmful levels. Despite broad use of validated screening tools, alcohol use remains under-recognised in maternity settings, with as few as 5% of women disclosing use to their provider. Complicating this, alcohol use and alcohol use disorder are poorly distinguished, and many women with drinking patterns suggestive of a use disorder are not referred to substance use pregnancy services. The reasons for under-recognition may reflect multiple intersecting factors. Women may be reluctant to disclose use due to stigma, fear of child protection involvement, perceptions of low risk of harm, or lack of effective interventions to support abstinence. In addition, alcohol use may not be asked about in ways that enable open and honest disclosure. Clinicians may lack time or training to properly implement screening, and available screening tools may not capture all aspects of drinking. As a result, alcohol use disorder in pregnancy is often missed or identified late, limiting opportunities for timely treatment, coordinated pregnancy care, and appropriate follow-up for alcohol-exposed infants. Often the first disclosure of alcohol use in pregnancy occurs many years later when the child is engaged in paediatric care for behavioural difficulties. Current pregnancy guidelines lack specific guidance for caring for pregnant women with an alcohol use disorder, including effective interventions to support cessation and appropriate obstetric management. As a result, care is inconsistent and clinicians must navigate complex decisions without adequate support. Medications such as naltrexone and acamprosate are effective for alcohol use disorder in the general population, but are underused and rarely considered in pregnancy. Although safety data in pregnancy are limited, available evidence does not indicate harm. In the absence of clear guidelines on pharmacological and psychosocial treatments, women with an alcohol use disorder in pregnancy have very few treatment options, despite alcohol's severe teratogenic effects. We recommend 3 key actions. First, to invest in research to improve detection and management of alcohol use disorder in pregnancy and to develop evidence-based approaches to pregnancy care. Second, support research into the safety and effectiveness of interventions for alcohol use disorder in pregnancy, including psychosocial and pharmacological treatments. And third, invest in the development of a multidisciplinary expert consensus living guideline for the detection and management of substance use disorders, including alcohol use disorder in pregnancy. Fetal alcohol spectrum disorder is preventable, yet has lifelong consequences for affected children and families. When evidence and guidance are lacking, the burden of complex and challenging decisions is placed on women and clinicians, often resulting in delayed and fragmented care. We hope to see meaningful progress in this area, and thank you for the opportunity to speak.
Thank you. Dr. Ryan.
Thank you. Thank you all for appearing in front of the committee today. I might start with the National Drug Research Institute, but I'll allow you to determine which one of you is best placed to answer this question. We've heard from a number of people who've talked to us today about the need to address the complexities of the tax system around alcohol in Australia, and a couple of people have suggested that the wine equalisation tax is contributing to some of the issues we see with very low-priced wine and the potential for abuse of that by people who have an issue with alcohol. Would you be in agreement with other people who've appeared in front of the committee today that we should look at a overall sort of simplification and modification of the alcohol taxation system in Australia that might perhaps better align both the sort of fiscal objectives of the taxation but also its potential health impacts?
Can I use an Australian vernacular and handball that to Dr. Nick Taylor in our Melbourne office, who wrote our submission on that matter?
Great.
Nick?
Yes, Dr. Nick Taylor here. In short, yes. In long, Australia's wine tax isn't based on the strength of the alcohol, whereas our tax on beer and spirits are. As a result, we've seen a real growth in cheap wine being made available, and over time, it's become our most consumed alcohol product. So yes, we really need major revisions to the taxation system, specifically the removal of the wine equalisation tax in some form, and for that to be restructured so that wine is taxed based on its alcohol content, or if that isn't an option for some reason, for there to be some sort of minimum price for alcohol that is related to the amount of alcohol contained in each product.
Thank you. Following up on an issue we discussed with another earlier person who appeared in front of the inquiry, we were hearing about, and you've touched on it in your submission as well, the issue of purchasing of alcohol online and of delivery to homes, and I know that you've expressed some concerns around people who access alcohol out of hours online tend to be those people who are at higher risk of harm from it. Could you just speak to that a little, whoever's most appropriate, and speak to your concerns around that, particularly with respect to whether or not there are appropriate warnings when people go to buy alcohol online, and that would include actually warnings for women of a childbearing age as to the potential complications associated with alcohol use if they might be pregnant?
Dr. Taylor?
Yep, Dr. Nick Taylor here again. I will say, yes, alcohol is very easily and readily available online, and we do not have a very good or any real system for monitoring the sale of alcohol online. We really, I think that speaks to a broader issue that we have in terms of beyond taxation, so a national monitor of just beer and spirits. We have very limited knowledge of how much alcohol is sold, what price point it's sold at, where it's sold at, when it's sold. So yes, in terms of online shops, we definitely, as well as other retailers and home delivery, we really need to make point of sale alcohol monitoring a part of our policy to be able to actually have any understanding of it all of how these different markets work and how they can influence harm. In terms of the second part about warnings, there's very few warnings or checks online. some of the bigger players or retailers may point to some of the safety checks that they've put in place, but there are very, very many different alcohol retailers online that take lots of different forms with varying levels of checks, including websites that themselves may not be an alcohol retailer, but they facilitate the sale of other people's alcohol. And so this may be something like Dan Murphy's Marketplace or Dick Smith or Kogan. There is very little monitoring in this space. There's very little warning around the nature of these products. And it's definitely something that's a blind spot for policy currently.
So is this an issue with regulation, or the legislation and the regulation around the selling of alcohol, or is it a problem with enforcement? Because we've heard from the ABAC that they had no concerns around advertising or regulation of alcohol sales in Australia.
Is that from ADAC, did you say?
ABAC.
ABAC, yeah.
I think it's definitely both. It's realistically it's both. In policy on this differs state by state. We know that there are issues with sales between different states, not necessarily following the same rules or regulations that another state might. We know that there are issues. I'll give the marketplace example again. We've heard accounts of people who don't actually have a license to sell alcohol being able to sell alcohol through these marketplaces. Now, it's very hard for enforcement to have any knowledge that that's even happening until after it's happened in the online space, and it's very difficult for enforcement to actually regulate a lot of this behaviour when they don't have the policy to back them up, and particularly when there is such discrepancies between policies from state to state. And, then you have the taxation issue. Taxation is handled obviously by the ATO, so that's a national department. Coordination nationally and between different states differs by state. And then there's the extra complexity that comes from different states having different regulations and different investment in enforcement.
Okay. I had a comment, please. Simon Lenton from the National Drug Research Institute. My understanding that ABAC is actually an industry constituted body of players within the alcohol industry and advertising associated with that. It doesn't surprise me that such a body says there's nothing to worry about in terms of the promotion of alcohol. I think there are vested interest questions that need to be asked, and my sense is that we need to have these matters, which are incredibly important from a public health perspective, regulated by governments, not left in the hands of self-regulation through industry bodies.
Thank you. I appreciate that.
Good.
Thank you all for appearing for our committee today. I've got two questions. My first is in relation to trends of alcohol use in young people. We've heard from a previous witness around the 18 to 24 cohort is seeing an increase in alcohol use in younger women, and that's trending up. And I was wondering is that what your research is saying as well, or you look quite concerned there, so maybe you disagree with what we've just heard. But my question was why you think that might be happening, why we're seeing an increase in alcohol use in that sort of young cohort of women.
Simon mentioned again, there may be other people on the panel that would like to comment, but I'd again hand over to Nick. Nick, did you want to comment on the gender difference in young people's drinking issue?
It's an interesting question in that we know that alcohol use across the population is declining in most age groups. I would ask, was this a proportional increase, or is this an overall increase in drinking that's been reported to the committee?
I'm not sure, but I think an overall increase was my understanding.
That was a suggestion, yes.
It's
Yeah, there's lots of, I will say this is a bit of a complex space. Women's drinking is lower than men's drinking. We do see movement in this space. We do see some people have described it as gender convergence, but my understanding is that men's drinking is dropping faster, and I believe that overall in the population there is a decline in women's drinking. However, it's not at the same rate that men's drinking is.
Interesting. What were you going to say? Sorry.
I was just going to say, Griffiths, National Drug Research Institute, generally the trends are in younger age cohorts downwards, but I would suggest that given that the data can be expressed in different ways depending how you look at it, we could reply in a sort of written follow-up to that question if you wanted us to produce something more definitive, because it is quite a complicated issue. Nonetheless, I think not just in Australia but internationally, in most countries we're seeing a decline in youth drinking trends at the moment.
Thank you.
And more pronounced in male populations. But
I'm happy to provide a bit of information for the Academic Guide. I submitted a very short brief that
No, Andy, your audio is breaking up.
That I'm doing
No, Andy, your audio is breaking up.
And see that. Yes, is it better now the video?
Keep talking.
Now?
Yep.
Yep, okay. So this is content based on the summary that I provided for this 2026 roundtable, and it's based on a qualitative study with high-risk youth in regional areas. And so qualitatively, what we're finding is that they're tending to try alcohol, which doesn't taste like alcohol, which tastes like other things. Into the market, we are seeing
Nyanda,
shift in women's alcohol use.
Sorry, Nyanda, it's really breaking up again. Yeah, you might have to provide some written evidence if...
Yes, you could make a submission for us, that would be good.
We will respond to this question specifically.
Okay, I'll take this on notification then.
That'd be great.
Thank you, that'd be great. I just have one follow-up question, if I may, Chair. It's just around pill testing. I'm a big supporter of pill testing, and I know we've got some really successful examples around the country of it working really well at festivals. And I see that your submission specifically calls that out as well. I was wondering if you could expand on that, and if you think there might be an opportunity to expand the programs we currently have and look at even other settings other than festivals.
Yeah, I'm Dr. Jodie Grigg. I can talk to that a bit. So the question was around what else can we be doing to expand? Yeah, so obviously we've got the 3 active services at the moment, New South Wales, ACT and Vic. Unfortunately, Queensland is no longer operating due to the change in government. I think it's widely agreed upon that we need both fixed sites and mobile sites, and most of the existing services are doing both. I think that needs to continue. But there's also acknowledgement that even in those jurisdictions that do have drug checking, it's not reaching everyone that needs to access it, and those windows that people are able to access it are very small, like sometimes just one afternoon due to a lack of funding, and they're operating under really challenging political circumstances. So I think that needs to be broadened to access more people, and that might mean that postal services or looking at other ways internationally that people have submitted their drugs. And we've got research at ENDRI on that very topic at the moment. So we can probably provide some further information on notice. But yeah, I think it needs to be expanded across all jurisdictions, because obviously there's a huge gap in Western Australia, and particularly with some of the high risk stuff we're seeing on the know. So I think there's a huge range of things we need to be doing to expand those services.
Can I add a brief comment? So Professor Simon Lenton from ENDRI, just going to your earlier part of your question about evidence around effectiveness and so on, I think there are two quick points that I'd want to make. The first thing is that there's good international evidence and growing evidence in Australia that when people attend drug checking services, when drug checking services are established at music festivals and other events, the number of people that are required to be transported to hospital for treatment for serious drug-related complications goes down. That's now been well established. And the second thing that's important is that for many people that attend drug checking services, this is the first time ever that these young people have ever discussed their drug use with a trained professional. And a lot of what goes on at a drug checking service isn't just about the chemical testings of the drugs, but it's also, for many people, the first conversation they've had about what they were intending to use, why they were using it, what they actually used, what they expected would happen, what some of the potential complications and risks are, and how those risks might be mitigated, including by not using drugs. So when we talk about drug checking, there's often a focus on the chemical checking, but actually there's a much bigger intervention that happens, which is a unique opportunity for many young people to discuss this important health issue. Thank you.
Thank you.
Paul Griffiths, National Drug Research Institute. Prior to this, I was responsible for the EU's early warning system on use of psychiatric substances, and I think one of the downside or upstream issues that drug checking can provide is with very dynamic and complex drug markets where we're seeing a lot of new substances appearing, we're seeing a lot of mixtures appearing. They can form a very important information point for actually keeping track of what's happening in the drug market, which is increasingly very dynamic and very complex, and often with quite nasty new challenges appearing in it. So I think as well as the intervention opportunities, as well as the public health role, as an epidemiological early warning system role in terms of keeping policy informed of market dynamics, they can play a useful role.
So could I add one really quick thing, Jodie Greig again, just in terms of thinking about expansion. I know one of the problems that has occurred is around liability and insurance, and I know that there's been actions within Victoria in order to make it more feasible. So from a national perspective, if it was more broadly recognised within a national framework, I think that might assist in those insurance and those challenges in terms of implementation.
Yeah, Ali.
It's all right. Thank you all for appearing today. We're really grateful. I could ask so many questions on all of the stuff that you've provided, but I think I'm interested in the access, and particularly after COVID, the increase in people being able to get alcohol at all hours, but also drinking more at home. Do you have evidence that having a cut-off point actually makes a difference, like any international evidence? And also, could it also create, a black market effect, because, everything's so immediate and online and people have become so used to. Do you have evidence around what works around access and 24/7 access?
So thanks for your question. Before Nick takes off, can I just clarify, when you're talking about a cut-off, you're talking about a closing hour in terms of late night trading or late night delivery services and those kind of issues?
I think in some of your recommendations you've recommended that delivery should be limited to 10 p.m. Like, does that then create a black market after 10 p.m? And, what's the evidence overseas? Has anyone done this? Has anyone? Yeah.
Over to you, Nick.
Dr. Nick Taylor here again. So I will say, in terms of home delivery, it is sort of more of an emerging space. But there is a lot of literature, both in terms of on-licence and off-licence venues, that show that the reduction in hour of service is significantly associated with substantial reductions in harm and as well as consumption. I will say I am doing a bit of illicit alcohol or black market research. Trading hours is not internationally one of the not one of the conditions that we've seen give rise to a black market. Particularly, I wouldn't think there would be a black market in that relatively small window of time when legal alcohol is available for most of the day, quickly delivered, as you've said. But also, I think it is worth noting that in our research on illicit alcohol so far, there is already an illicit alcohol market in Australia, and there are illegal products that are already available through home delivery apps with the current conditions that we have. So I don't think I don't think we should be really concerned about giving rise to an illicit alcohol market more than regulating the market so that the current illicit market can be reduced.
Okay, thank you.
Good. Sam?
Thank you. The home delivery of alcohol, that seems, just coming back to the question, I suppose might be for you, Nick, the question about regulation or enforcement. If I order a pizza or whatever, and I think those companies now say we can deliver you alcohol as well, so I'll order 12 cans of beer or whatever it is.
12.
I don't order that. I don't drink beer with pizza, but anyway, just wanted to get that on the record, Dr. Ryan. But let's just say that I did have order 12 cans of beer. Is the person who's delivering me the pizza, the delivery person, do they have to have a responsible service of alcohol qualification or certificate to see whether I shouldn't be served any more alcohol, as I would if I was ordering it in a restaurant or a pub? That's the first thing. Do they check for ID to see that I'm over 18? Are those things legislative or enforcement?
Do you want to start with that, Nick, or I've got a couple of comments as well?
Dr. Nick Taylor here again. So I will say it is state dependent to some degree, at least that's my understanding. I believe that the person delivering the alcohol is meant to make that check. I have been involved with some research projects where we have had people make these orders who may appear to be under the age of 25, so they should be getting checked. I believe in 25% of cases we didn't get ID checked, so there is a definite gap there. Sorry, was there more to that question?
The question was mainly, is it a legislative issue where it needs to be legislated that person is required to do that, or is it legislated? And I take your point that it's probably state dependent, or is it something where the legislation exists but it's just not enforced because this is probably an evolving method of selling alcohol to people, delivering alcohol to people?
It's very difficult to imagine how that could reasonably be enforced at all without the liquor regulator also being at the door when you get your home delivery. I would suggest that it really does need to be a policy issue in that the ID checker, the ID check needs to be made potentially online in some way, or at a point where that can be verified and can be monitored by the regulator, because we can't regulate every delivery to every person's door, and we can't guarantee that the person who's making that delivery is going to make that check every time. And I will note as well, I believe for some of these companies there's an incentive for the delivery person to make the delivery. I believe in some cases, if you fail to make a delivery, there is some sort of financial penalty to that. So it really shouldn't be on these people who are sort of almost in the most vulnerable position in the chain to be the ones that we're relying on to reliably make that check every time.
Simon Lenton from the National Drug Research Institute. Just a couple of quick comments. I think the question is an incredibly important one, because really what it's showing is that in this dynamic environment where things are changing very rapidly, and there are things happening now that we couldn't even have imagined having two years ago, where you've got low-status rideshare drivers on motorbikes delivering alcohol to people and putting it on their front doorstep and taking a photo that it's there, but there's no check done in terms of people's age and so on. So I think this is a new area. It's one where there are obvious, probably regulatory as well as legislative things that need to be tied down, and we're only really now starting to understand what some of those gaps are. I don't think we have answers to it, but I think there are serious questions which we do need to find answers to, because we know that these kind of matters in terms of responsible service of alcohol are one of the important measures in terms of alcohol-related harm, and particularly when we're talking about young people's access to alcohol. You know, in the olden days we used to knock it off from our parents' liquor cabinet, but now you can get it delivered straight from the liquor store to your front door, and I think that's a problematic issue that we need to sort out.
And just further to that, I'll tell you what anecdotally I think is happening, and probably COVID exacerbated this, is the percentage of people who drink alcohol at home compared with the people who do it in a venue 10 years ago compared to now, I would say it's massively increased. And the cost of alcohol, and this maybe goes to a taxation or a bureaucracy or red tape, whatever it is, but the cost of drinking the same amount of alcohol in a venue compared with drinking it at home is a huge difference. I would say, these are my rough calculations based on
a dozen bottles you drink
alcohol purchases that I might make. But I think a pint of beer, which would be 560 mils in a pub, would be about $14, $12 to $14. A carton of beer, which I calculate to be 9,000 mils of alcohol, would be about $60. So it's a huge expense. So that means that more people are drinking without getting it from a drink from someone who's got a certificate in responsible service of alcohol in a venue where people can be observed and monitored. Is that a concern?
I mean, I think it is a concern. I'd also note that there are lots of products that we consume at home that are a lot cheaper than what we would consume them elsewhere, like steak at home versus steak in a restaurant. So I think that's something that's across the board for all products. But alcohol is no ordinary commodity, as we know, and we need to be identifying where these problems are and resolving them. I don't have the data in my head about rates of consumption at home versus at a venue. We know about preloading, particularly for young people. It's more of an issue where, you know, drinking before you go out and so on. But Nick, did you want to comment on that issue about at-home drinking versus on-licence drinking?
Yes, I will say, so much of the research for in Australia shows that the predominant place of drinking is at home. That regardless of prior to COVID, yes, it became more and more at home during COVID and subsequently, but it has been the most predominant drinking place in Australia for a while. I do want to add, though, that in terms of taxation, taxation can't be the cause of this disparity between on-licence and off-licence. The taxation on the alcohol products in the off-licence is the same as the taxation of the alcohol products in the off-licence. Sorry, whichever one I didn't say first.
Yeah.
So where there are other costs associated with running an on-licence venue, there are other factors that go into the decisions behind those price points that are likely driving the more substantial increase that we've seen in these venues. But yes, just to reiterate that point, the off-licence is affected by the same taxation regime. So it really, a divergence can't be solely due to the tax system.
Just one more sort of...
Can I just Could I just jump in
Yep.
just to add to that? So it's Professor Paul Holtz here. I just think what Nick was sort of pointing towards was that one of the issues is that the price per standard drink in a licensed venue is just so much more than it is in a bottle shop. And so what people have been arguing for really is a minimum unit price to try and adjust for that, so that that would effectively make bottle shop alcohol purchases more expensive. So the taxation system can't necessarily adjust in the way that Nick was outlining, but something like a minimum unit price would actually mean that the costs could be equalised more.
The only other thing I'd say, coming from a regional electorate where we've had a lot of, issues of social isolation that have caused problem, and alcohol use at home probably has exacerbated that, and where people used to come together and go to pubs, even though there were issues around alcohol and driving and those sort of things, there was a social benefit to that. So I would like us to think about the social, social good that comes from responsible alcohol use, and whether that people doing that together rather than sitting at home, whether there's a way. So that's more of a comment. I'm interested if you've got a view on that, whether we should be looking at that.
Paul Griffiths, National Drug Research Institute. I would say more your question would reflect back on the earlier part of it, is how do we look at ensuring the same regulatory standards for home delivery and home consumption as we do for public consumption? And I think that's where the issues, where the policy gains are and where the policy levers probably are. So I think that would be probably, it's not that we need less attention on public drinking, we need more possible regulatory attention on what's happening in terms of market developments in terms of home drinking, would be my personal opinion. It's something that I think we would like to see more research, to be honest.
Thank you. Thank you for that discussion. Appreciate it. Good. Thank you, Chair.
Look, I've got a few questions, if we've got time. First of all, to Dr. McNamara and Ms. Quintrell, we've had some conflicting evidence today. I don't know if you saw the previous discussion with...
I didn't catch all of it, no.
No, with Professor Elliott and her group, and Dr. Ewick from the Alcohol and Other Drugs Knowledge Centre about fetal alcohol syndrome disorder, that raised concerns about the stigmatising effect on Indigenous communities of the concentration on fetal alcohol as a cause for neurodevelopmental problems in kids, where there may well be multiple other risk factors, and in particular frightening mothers about admitting alcohol use during pregnancy. Can you reflect on that for the populations that you've studied?
I might handball this to Dr. McNamara. She has clinical experience, which might be helpful in answering that question.
Dr. McNamara?
You're on mute, Dr. McNamara.
Sorry about that. So Kelly McNamara, obstetrician gynaecologist from the University of Newcastle. So I will speak to that, but from the maternal side rather than the paediatric side, as I work on that side of the patient spectrum. Look, there is stigmatisation around alcohol use, and this does have impacts on the Indigenous population. There is a prevailing misunderstanding in the maternity community, and perhaps more broadly, that fetal alcohol spectrum disorder is a disease or a disorder that is most common in Indigenous populations. And whilst there are populations with increased prevalence, the bulk of women that use alcohol during pregnancy in Australia are non-Indigenous women. And That's not clear in the rhetoric. There's a typical story of an older, highly educated woman that continues to use alcohol during pregnancy, that doesn't get screened for alcohol use during pregnancy because her providers perhaps don't recognise that she might be somebody that is using alcohol during pregnancy. She doesn't come under the watch of Child Protection Services because she doesn't meet preconceived ideas of what somebody who might be consuming alcohol in pregnancy might look like. And you can take that with the flip side of an Indigenous woman that might be over-examined in this regard by clinical services and child protective services, and has a very real sense of fear around the reporting of alcohol. So I do think it's a concern, the focus on harm for Indigenous population. I caught the tail end of the last discussion, probably the last 3 or 4 minutes, but the evidence being presented, I would have largely agreed with that I heard regarding this issue.
So we should
Does that answer your question?
Sort of. You're suggesting we need to take a broader view, that this is the whole community involved in this, that we need to be...
Yes, and there's women throughout the spectrum of society consuming alcohol. There's really 3 patterns, in 3 ways in which women consume alcohol in pregnancy. There's the woman that doesn't recognise the risk of harm that she is putting the child under by consuming alcohol in pregnancy, and that's quite amenable to public health campaigns, and there's some of those ongoing at the moment. Yeah. There's the woman that perhaps didn't realise she was pregnant and consumed alcohol up until the point where she recognised she was pregnant, and then typically stops or tries to reduce use, but that harm may have already been done in that time frame. And then there's a group of women with alcohol use disorder, which is what our submission was mainly focused on, women who can't just stop in pregnancy. And so it's not a homogenous situation across society, but there are women from all walks of life consuming alcohol in pregnancy.
Yeah, good. Thank you. That's important. So I've got some other questions, and perhaps Professor Griffiths, you could start with this. Are we seeing any trends in Australia? And I think you've already mentioned the synthetic opioids and nitazines, etc., that are becoming available here, that we should be worried about and should be doing more to look for them?
I mean, I will, Paul Griffiths, National Drug Research Institute, I'll make a brief opening comment on that, and if I can hand to maybe Jodie to you. I'm quite new to Australia, but what we're seeing is a very dynamic globalised drug market. We're seeing an increasing emphasis on synthetic drugs that can be produced near to consumer markets, and we're seeing much more complexity in terms of the products that are rising, the mixtures that are sold, and a blurring of boundaries, I think, between what illicit drugs, medicines, study aids, health food projects, supplements, and so things are getting very complicated. They're changing very quickly. We see the internet and digitalisation enabling that market, and we're really, I think our policies and surveillance systems are struggling to keep up. I'm quite new to Australia, so I'll hand over to one of my colleagues who are more informed about the dynamics of the situation here.
Sure.
Dr. Jodie Grigg. I'll just make a brief comment from the perspective that I work in, which is mainly around monitoring trends in ecstasy and related drug use in kind of party settings. And from my perspective, it is a concern. So the high potency novel synthetic opioids like nitazines wouldn't have really been on our radar for young people that are using stimulants like ecstasy, ketamine, cocaine. But now those opioids are infiltrating those markets, and they've been detected increasingly in those types of drugs. So I think that's quite an unprecedented concern for young people who have no experience with using opioids and wouldn't really know how to identify an opioid overdose or know how to respond. So it's a completely new risk from my perspective, and we should be doing more to monitor the market to detect that.
Should we be doing more with public health campaigns? About public availability of naltrexone and
I do believe the festival, like the harm reduction campaigns from the West Australian government, have started to acknowledge the risk of nitazenes and availability of naloxone.
Mm-hmm.
I don't know how broadly that's being done, but I do think that's worthwhile.
Okay.
Sure. So I might just, it's Professor Paul Dietz, could I just jump in, please? These things are really important. We've identified those new substances, but we've also shown just recently the massive shifts that we've seen in relation to heroin and methamphetamine, and we shouldn't forget those key substances as a major driver of drug-related harm in this country. So we've shown that the purity-adjusted price of heroin has declined by more than 50% since 2014. And what that means is that when people, and to use an analogy that might make sense in relation to alcohol, if you went up to a bar and you asked for a pot of beer and someone gave you a pot of whiskey, then all of a sudden you, for that same price, and you consume that whiskey in the way that you consume the beer, well, you're going to have a bigger effect, aren't you? And so what that has driven is a whole range of harms in relation to heroin. So we've seen an increase in ambulance attendances connected to heroin, an increase in opioid-related deaths that are connected to heroin. But at the same time, we've also seen a similar shift in the methamphetamine market that took place in about 2014. And right across the country, we now have high purity methamphetamine at record low prices. And we have seen a lot of the indicators of harm tail off, but they're still at record highs. They're higher than they ever were in 2009 and so on. So we've got to remember that, while we need to focus on these new and emerging substances, we also need to have this focus on some of the traditional ones there too in Australia that have been unaffected by all of these things like COVID, like wars and all of those sorts of things. And our policy responses are still lacking. So we don't have needle and syringe programs in prison. We don't have comprehensive opioid agonist therapies. We haven't looked at things like slow-release oral morphine and the things that we mentioned in our submission. There's so much more that we need to be doing in that space as well.
Thank you. Professor
Can I make one quick additional comment on this one?
Sure.
Simon Lenton from the National Drug Research Institute. Of course, Paul Griffiths is absolutely right. We're living in an international, very dynamic drug market where all these things are changing very quickly, and we've got various monitoring systems monitoring these things in Australia, and so far we haven't seen a huge flood of these new, very potent opioids in particular hitting our shores, but they have appeared, and they've appeared in strange things like, cannabis vapes and a range of other things where you wouldn't expect them, right? So you would have heard evidence from people around the country about that stuff. So we really need to be mindful of the threat posed by what's happening internationally, and be doing everything we can to be monitoring all different sorts of places where these drugs might emerge. And of course, one of them, which we've already mentioned once this afternoon, is the opportunity for festival-related drug checking to tell us a lot of what's happening on this, in the community now, not what happened with someone who died 2 years ago, but what's actually happening today and yesterday. And that's an incredibly important tool in terms of monitoring for these kind of new substances emerging. And we, from a public health and from a surveillance point of view, expanding drug checking just from that perspective would be incredibly helpful in terms of preventing Australian carnage from these substances.
Oh, I'm glad you brought up cannabis as well, because I've got some questions about that as well. But Professor Griffiths, you wanted to make a...
I'll just finish and try and bring together my colleagues' comments. We live in a much more complicated drug market where all substances seem to be cheaper, more widely available, increasingly available at high potency. So you've got new substances coming in. and you've also got established substances still which we can't take our eye off that important ball, and Professor Dietz is completely correct about that. I think, again, we have to see this global connection. It's increased production of heroin and methamphetamine in some Asian countries at the moment. It's probably partly responsible for why we're seeing increases in purity and potency, potency and decreasing costs here. I do think at the same time, though, we need effective early warning systems to keep on track with changes in the market. We have to see the market holistically. We have very good data sources in Australia, but there's still, I think, a need to join them up better. And it's importantly in this area, you need, I think, coordination at the federal level, because really you've got to bring these different data sets together, and you've got to create a real-time space for information exchange.
Mm-hmm. Yeah. And we're running out of time, but one last question I have is that we've heard evidence in this committee of enormous increases in the imports of medicinal cannabis. And I just wondered if you feel this is contributing to the problems we have with alcohol and other drugs as well, as a sort of add-on for people, or whether do have any concerns about...
Can I just clarify, when you were saying, Simon Linton from National Drug Research, when you were saying about the importation of medical cannabis, are you thinking illicit importation, or are you thinking through the system?
Through the system.
Look, I mean, I think that, is it okay if I comment on this one? I think, you know, the way the medical cannabis scheme has unfolded in Australia, there's been some benefits, but there's also been some costs, and you will know that very early on, you know, from 2016 when the scheme first set up in Victoria and then other states caught on, and then we had an Australian federal legislation, it was very tightly regulated and there was only a few conditions for which it could be used. And then what we've seen was advocating from industry saying there was too much red tape and the people weren't able to get their medicine and so on. So we saw a growth happening outside of the regulatory system through special access arrangements. And what has happened is that since 2019, the number of prescriptions for cannabis per year is now 10 times higher than it was back in 2018. So there's been a huge expansion, and what's happened is that we've seen vertical integration where companies set up, you know, cultivation, manufacturing of products, and medical assessment and prescription and online delivery. And that's a very concerning development, because the ability for proper scrutiny of this has been undermined. And we've now seen the TGA last year institute an inquiry into this. So we've gone from a very tightly controlled system which had its problems to now a system that is very unregulated, and there's many people who are on medical cannabis, many of whom will have legitimate reason for it, but there are questions about the way the system's been set up. So for me, the concern is about the commercialisation of the medical cannabis system in Australia.
And the vertical integration.
And vertical integration, absolutely right. And you know, we think it's very timely that the TGA is looking into it, and the Commonwealth is looking into it as well. And we think that's, from my point of view, I think that's important.
Great. Any other questions? No. Good. Well, look, we have run out of time, but there's many more questions we could have asked you, I know. And thank you for your time, both here and online. It's been very valuable. If you've been asked to provide any further information, could you please deliver it to the Secretariat within the next 2 weeks? You'll be sent a copy of the transcript of your evidence, and we'll have an opportunity to request any corrections to transcription errors. And if you don't have any questions of us, just thank you very much for all the effort you've put in. So thank you.
Thank you. Thank you all.
Thank you. Thank you.
Excuse me. Thanks.
Thank you all.
Bye. Now like to call representatives of injury matters to give evidence today. That, I believe, is Ms. Sandy Lujanowski. Hello.
Hi, how you going?
Good, how are you?
I'm well, thank you.
Good. I'm just going to go through the formalities. So for the Hansard record, could you please state your full name and the capacity in which you appear before the committee?
My name is Sandy Lujanowski and I'm the Chief Executive of Injury Matters.
Okay. Although the committee doesn't require you to give evidence under oath, I should advise you that this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and tracks parliamentary privilege. I now invite you to make a brief opening statement before we proceed to discussion. To assist with the transcription of the public hearing, it would be appreciated if you could please state your name before responding to each question. And now if you'd like to make a brief opening statement, that would be great. Thank you.
Sure, thank you. I'll keep it really brief because I know that you've been having people going over time and it's shuffling back and I'm conscious of your evening. So just to very quickly, I wanted to introduce Injury Matters as a not-for-profit organisation that innovates and delivers injury prevention and recovery solutions that empower people, organisations and policymakers. We're based in Western Australia and we support informed, safer choices. So we work in areas from road safety and trauma recovery to falls and substance-related harm, and also provide vital frontline education support programs. We also equally support critical research that enables agencies and policymakers to make informed decisions that help to mitigate the personal and broader economic impacts of injury within the community. I think it might be easier if I skip to what questions you've got and then we can utilise the time in the best possible way for you.
Good. Well, happy to start. Questions? Ms. France, would you like to?
Yeah, thank you so much for appearing today. We really, really appreciate it. Do you want to give us a little bit of an overview of your older adults pilot and what you found and, just some insights into that? That would be great.
Yeah. Of course. So we, not too long ago now, I think it was towards the end of last year, finished a pilot program that was funded through Healthway, which piloted the use of the Assist Light tool. So that's a world-renowned tool that's been put in place to support allied health workers working directly, generally with older adults mostly, but mainly working in regional areas is where we focus the pilot, because we recognise that there is a disparity between what's available within regional areas and what's available in the metro area. So within that, we provided a lot of education and assistance to close to 100 allied health support workers within one region to help upskill them so that they could ascertain and understand where risk factors were and could potentially look to cut off usage before it started to become problematic and divert them to appropriate services and supports to enable a healthier community and also better outcomes, because we know that there are strong links between alcohol and injury. So the main thing that we really took away from the pilot was that our allied health support workers were not adequately trained. They weren't confident to be able to know where they could refer somebody to and when they should intervene, when it is problematic or when it's valuable for them to say something, and also to have the tools to be able to start some of those conversations. That's what this really helped them to do, was to almost have a very clear checklist to be able to help them to ascertain, okay, this looks problematic and this is a pathway within which I can support this person too.
Thank you. So would you say, I think Dr. Mike, you raised it earlier about, would you see a role for sort of an alcohol and other drugs nurse navigator kind of situation where, and some sort of education of allied health professionals and GPs and that sort of thing?
Yeah, I think educating the workforce is critical because they're our front line that are there at the coalface that can potentially work in that prevention area, because at the moment a lot of the funds and the investment are needing to go to crisis and sort of end care types of goals as opposed to trying to cut it off before it happens. So I know that in the previous group there was talk about whether or not public health campaigns might be beneficial, and I think that there is definitely a role for things like public health campaigns that heavily look at the behaviour change, so how we can help people to understand what problematic alcohol intake looks like and what the possible impacts are. But we would need to dovetail that with what are the current issues with alcohol advertising, because we're not going to be able to match the volume that is probably there across the market with a public service campaign. So it would be really important to have a look at how we're scrutinising what's actually making it to whether it's on free-to-air TV or on digital marketing.
Thank you. Thank you. That was useful. Thank you.
Alice?
Thank you for appearing for our committee today. You mentioned before you did some work in the road safety space, and I was just wondering if you could expand on what that was. Is it in terms of drink driving or sort of awareness? I'd love to hear from you about that.
Yeah, sure. So in Western Australia, we run the Road Trauma Support Program. So that is for anybody that has been impacted by a road crash in Western Australia, irrespective of the fault or blame. So we see everybody right through from a police officer, a non-professional first responder, the person that caused the crash, right through to maybe somebody that's lost a loved one in a crash, and that whole breadth there in between. But what we also do know is that alcohol in Western Australia impacted 9.5% of fatal road crashes in 2023. So that's one of the most recent stats that we have around what that looks like and trying to quantify that a little bit. So that's 15 people that died as a result of that.
Thank you. No further questions, Chair.
Monique?
Thank you. Thanks for appearing in front of the committee today. The submission that you gave us a couple of years ago now, many of the themes in it are very consistent with things that we've heard from other people who've appeared in front of the committee today. I just wanted to ask you about one of them. You've talked about the need to reduce exposure to alcohol marketing, particularly for children and young adults, and expressed some concerns in that submission about the alcohol beverage advertising code, feeling that it's largely unregulated, and expressed that a voluntary industry-run code is an ineffective way of protecting children and young people from alcohol. Are you able to give us a bit more detail about those concerns and perhaps some illustrative examples of the sorts of things that have prompted that comment?
Yeah, I'm sure that we would be able to pull some examples for you to be able to demonstrate what that actually looks like in practice. But ultimately, it is the industry almost policing the industry. So that therefore then means that slope starts to get a little bit more and more slippery, and we start to see more and more that actually don't even meet what the criteria are that they've set for themselves. However, there is no real teeth to it. There is no real consequences based on what people are putting out there. So it's also quite difficult because it's hard to see what reaches a young person or a child versus what also is reaching what would be their target market and being adults that are of legal drinking age. So it's not that we necessarily want to be the fun police and say that, no, you can't advertise these things and you can't have them there, but it's really important that they're not appealing to children. When we're seeing advertising with people all looking like they're having a great time, often on the water, we see that more and more drownings are involving alcohol now. So there are lots of different risk factors that they're almost modelling without probably quite inadvertently. And I think it's really important that we start to have a look at that as well, because we are normalising some of these different things that would be important for us to create a more accurate picture.
Right. The concerns that you have around alcohol advertising, are they in traditional media platforms like TV and radio, or are we talking about online, or all of the above?
I think it would be a bit of all of the above, because we're seeing what used to be on free to air sort of morphing through into your digital platforms. So it's on your streaming platforms and all of those different types of ways of people now consuming media. So it's sort of moved through that way. And we also see a lot of young people now that choose not to engage with the news or direct public health messaging that doesn't come via an app, whether that be TikTok or Instagram or whatever their app of choice is. So it's really important that the way that we get messaging out is not exclusionary, and that it's going to reach all of the different demographics across our community. We're seeing older adults that are actually one of the largest growing sectors of drinking between 60 and 69 years old. They're increasingly drinking over the last couple of years, and you could draw a whole heap of different conclusions on that, whether that is to do with being a little bit more sedentary, whether that's to do with changes since COVID, or a mix of a whole lot of different things. However, it's with an ageing population, it would be really important for us to be making sure that we're reaching each of those different segments. So right through from your free to air to your streaming platforms would be important.
Thank you. That's really helpful. Thanks, Chair.
Sam.
Thank you. One of the points in your submission there is that Injury Matters noted that there has been a lack of public reporting regarding the effectiveness of the National Alcohol Strategy. Does that mean that you think that the National Alcohol Strategy has been really effective and it hasn't been reported? Is that what that means?
It's more so we don't know. So it would be really valuable for us to be able to see what that to date, well, when we wrote this, there might be very different now. When we wrote this, there hadn't been anything published to date. So it was really about just that transparency of data and information, just to see how it's tracking. For organisations like Injury Matters that work at the community level, we want to see what's working really well, because that helps us to know how best to reach people, and where also to refer people and to support positive behaviour change in the community.
And another point you make there, again, around the limited evidence around effectiveness of education programs. So what encourages, so young people, what encourages them towards a healthy approach to alcohol consumption, or not consuming alcohol, or sort of going for I would say the binge style culture that existed when I was a young person, which is a while ago now. But it seems to be very different now. I think it seems to be a healthier culture. But your point there is that there is not that much evidence about if there is a better culture now, what's caused it, or do we need to keep going down a certain path?
It's a bit of all of that. So again, it comes down to, you'll notice in our submission, we talked about the availability of data, because that's what really tells us the story, and that is what helps us to understand the levers that we're able to pull and why we're seeing. I would definitely agree with your point that it appears that our younger generations are taking a slightly different approach, which is positive to see when you look at it from an alcohol-focused lens. I think some of the things that would be really important to have a look at when we look at the different levers that really work for young people, it's potentially going to be looking at things like your minimum unit pricing. So as soon as things start to impact how much it costs you, when you're problematic drinking, it becomes a choice. It becomes something that you look at and reevaluate. Whereas if it is something that you are a bit older and more established and more financially stable, it probably has a little bit less of an impact, and that's where some of those other behaviour change campaigns come in. That's not to say that I don't think that a behaviour change campaign would be really effective with younger people, but it would be really important to get evidence and understand what those particular drivers are that are really going to reach young people. And there are some different countries that have done that across the globe, so it would be really valuable to look at those sorts of things as an example. Not to say that it will always work in an Australian context, but it gives us something to at least aim towards or further understand.
Thank you, Chair.
Thanks. And yeah, thanks once again for coming today. But I'm just wondering, we've heard a lot in our inquiry around the stigma associated with drug and alcohol abuse. And I just wondered if you have done any work with the health providers around this space to see how we can make it easier or more appropriate for them to see these issues as health problems rather than socialisation difficulties or things like that. Have you done any work in that area?
I think the pilot that we did via Healthway was a good indication of that, and just working with the allied health support workers that were having daily access to the community. It was really important to see, there were stigmas, there were thought sort of patterns that were well established within that group. However, this gave us an opportunity to really talk about, this is what problematic use looks like. This is more so what some of the profiles look like. They don't always look like you might necessarily think. And also that it is your role as a health provider to support somebody towards a prevention approach. You are doing really important health-based work by doing that. Whereas I think that some people probably came into their first bit of training thinking, oh, this is one of those conversations I hate, I avoid it, I prefer not to butt in, it's not my place. And so it's really around equipping those different providers with more tools. So I think a lot of there needs to be, in terms of the education that happens, it needs to happen at the community level and the workforce level. It's vital that it comes from all sides.
Yeah. I just wondered if you've done any work with GPs as well, this issue.
Only a little bit. So we've done a bit, mainly with GPs around older adults and falls prevention. It's one of the big things that we've really worked on with them. And they've also raised in terms of the fact that the alcohol guidelines don't exactly work as well for somebody that's 75 as what they do for somebody that's 25. So, I think that, look, as soon as you start adding comorbidities in there, and as we get a little bit older, it's also important for us to have a look at, should that look a little bit different? And GPs have raised that as an area whereby they find that a little bit difficult because they don't have something to hang their hat on to really say, this is what the guideline says.
Yeah. Now, what about in terms of time for consultation? Have they raised any of those issues?
I think it's pretty much an across the board thing that we often hear from practitioners is that they're pretty time poor. So it's difficult for them to get access to information as well and to SWAT up on it to be able to share it with their community as well. So it's a common issue that we've definitely heard echoed.
Great. Thank you. Well, I don't have any further questions. Any further questions? Nope. Well, thank you very much for giving evidence today and for your submission. It's very valuable. And I don't think you've been asked to give us any further information, but if you have, if you could forward it to the Secretariat within the next two weeks. And once again, thank you so much.
Thank you. No problems. Thank you.
Good. Thank you. I'd now like to call witnesses from the Financial Counsellors Association of Western Australia to give us evidence today. Good afternoon.
Afternoon.
Thank you for coming. So sorry, I know you've heard it all, but I've got to go through it.
Absolutely.
Yeah. For the Hansard record, could you please state your full names and the capacity in which you appear before the committee?
Melanie Hopkinson, Chief Executive Officer of Financial Counsellors Association here in WA.
I'm Sarah Holman. I'm the Policy and Advocacy Lead at the Financial Counsellors Association of WA.
Thank you. Although the committee doesn't require you to give evidence under oath, I should advise you that this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. Giving a false or misleading evidence is a serious matter and may be recognised as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I'd now like to invite you to make a brief opening statement before we proceed to discussion. To assist with the transcription of the public hearing, it would be appreciated if you could please state your name before responding to each question. And I now invite you to make a brief opening statement before we proceed to discussion. Thank you.
Thank you. And thanks for the opportunity to appear today. As mentioned, we're here on behalf of the Financial Counselling Association of WA, and we are the state body for financial counselling profession. Financial counsellors, you may be aware, provide free, independent and confidential support to individuals and families experiencing financial hardship and work across housing, justice, family violence, gambling harm and community services. Financial hardship, including debt, housing instability, fines, income disruption and economic abuse, has strong and enduring impacts on public and people's health, well-being and life outcomes. So we believe that the financial counselling profession has a very important role within alcohol and other drug responses because financial security is a key determinant of well-being in today's economic environment. Financial stress is both a driver and a consequence of alcohol and other drug harm. Rising cost of living pressures, insecure housing, unmanageable debt, fines, economic abuse and income instability are well-established social determinants that increase vulnerability to harmful alcohol and other drug use and reduce a person's capacity to engage with treatment and recovery supports. And this has been reflected in submissions to the inquiry and in broader social outcomes research. You would have heard from WA Network and Alcohol Drug Agencies today, and they noted in their submission that alcohol and drug-related harms are intrinsically linked to broader determinants of health, including socio-economic disadvantage. Other submitters, including the Australian Multicultural Action Network and the Western Region Alcohol and Drug Centre, RAD Health, have highlighted that financial hardship, housing stress and family pressure are common features of the lived experience of people affected by alcohol and other drug harms. The pattern that we see is reinforced by national front-round evidence. The National Debt Helpline consistently reports high level of alcohol and other drug-related complexity among their callers who are experiencing financial hardship. The national data shows that financial stress, housing instability, fines and income disruption commonly co-occur with alcohol and other drug issues, demonstrating that these are not isolated or localised experiences. It's also important to note that AOD involvement is frequently under-recorded in financial counselling data. Many services are unable to isolate AOD issues because they are captured within broader health or well-being categories rather than recorded as a standalone presenting issue. As a result, low recorded figures reflect limitations in data structures, not lived experience. Frontline services report that AOD issues are embedded across mental health, employment, family violence, housing and legal systems, even where they're not identified as the presenting issue. So this means that the quantitative data alone can really underestimate the prevalence and impact of the AOD-related harm. So accessibility is central to effective engagement. Evidence to this committee has highlighted that people experiencing alcohol and other drug harm do not follow through on external referrals due to shame, chaos in their lives, limited transport, or limited capacity to navigate fragmented systems. Co-located on-site financial counselling within alcohol and other drug services removes these barriers by providing immediate, trusted support as part of the care team. Wraparound service models allow financial and clinical issues to be addressed co-concurrently, strengthening engagement and reducing drop-off from care. Evidence from integrated models supports this approach. Odyssey House Victoria specialist on-site financial counselling within residential rehabilitation demonstrate improves retention and smoother transitions when financial stresses are addressed alongside clinical treatment. The economic case for embedded financial counselling is equally strong. A cost-benefit analysis undertaken in 2014 by the University of Adelaide found that for every dollar invested in financial counselling, it returns approximately a $5 return, even using understated assumptions. More recently, Financial Counselling Victoria commissioned a return on investment analysis that was published in 2025. It estimated a social return of investment of between $3.70 and $5.30 per dollar invested in the general population, confirming that financial counselling remains a cost-effective early intervention in the current policy settings. The same analysis identified returns of up to $8 per dollar invested for people experiencing high and complex disadvantage, reflecting the greater costs avoided through early intervention. Now, it's important to note that these estimates do not capture longer-term benefits and non-economic outcomes such as improved financial capability, mental health or housing stability, indicating that the true value of financial counselling is likely understated. So our position is that financial counselling profession should be embedded within alcohol and other drug frameworks as a core psychosocial support, not an optional add-on or bolt-on service, not referral-based, but delivered on-site as part of multidisciplinary care. Now, this would mean embedding the profession within services, warm on-site engagement rather than reliance on referrals. This also importantly requires cross-portfolio commissioning of the profession across alcohol and other drug, housing, justice, mental health, in relation to social services department which currently fund financial counselling services. Without addressing the financial drivers of harm, policy will continue to treat symptoms rather than causes. We thank the committee for the leadership on this issue and welcome continued collaboration to strengthen prevention, recovery and long-term outcomes for individuals and families. Thank you.
Thank you. Sam, would you like to...
Unless you want to have someone else. My question, financial counselling is very important, very valuable. How much, will we need as much, I'll put it like emergency or crisis financial counselling, if we had better financial literacy lessons in schools?
Great question. I think the short answer to that is absolutely.
Absolutely, we wouldn't, you mean?
Yes, we wouldn't.
Yeah, sorry.
I think both Sarah and I are very big proponents for that early intervention engagement work. I think it's how it is embedded within the curriculum as the way we embed other really important things into the curriculum. Often it's seen as, as an add-on, as a bolt-on. It's often given to health. So it's about how it's done, but totally agree that improving financial literacy certainly helps those longer-term outcomes for people. I think I would want to say it wouldn't remove the need for financial counselling and the awareness of financial counselling to be raised. But yeah, that's a great...
No, definitely not. I wasn't implying that at all. It will always be very necessary, and it probably, maybe we need to front-end it into education campaigns. But you must be, well, I'll ask you, do you see people in terrible situations that need your assistance with financial counselling, if they just had the knowledge from the time when we ask people to become adults, which is 18 years old, if they just had the knowledge that they could gain in the later years of school about credit cards, interest rates, savings, budgets, all of those things, you know, the things that you do need to have money for, would you see people who maybe manage to avoid some of the problems that you're trying to deal with?
I think they'd make different choices. Knowledge, it's not just about the financial literacy education. We also know it's about having the tools to implement that. So whilst the education is really important, it's then how do we make sure they're embedding that and using those actual tools to set themselves up well, especially in today's world of, buy now, pay later and all the options that young people have, whereas before it was a lot more difficult to get credit. And of course, the other big thing that we see is the gambling and the gambling harms on particularly young men in terms of the decisions they're making. So there's a lot involved. I totally agree, though. Education is key. I think it's how we then scaffold that into the rest of people's lives.
And I think I'd probably add to that. So Sarah Holman here, back to your original question, is if they had that literacy from school age onwards, would we still see people with these big issues coming into finance? Yes, we would, because each person's financial hardship comes from different means. So you could have the best role models is usually where our money values come from our home. So you could have had the best setup from home or school, but you still may hit financial hardship through other means, excess medical bills, separation from a partner. There's many mental health concerns. There's many reasons why someone may be impacted by financial hardship. I don't believe that it would fully address the situation. While it would help people to learn better ways in managing money and their options, it still will not replace when people are impacted and have those life events pop up that do need that additional advocacy help. As you'll be well aware, many people do very well at self-advocating with any areas of their life, but especially if you're impacted by mental health, sometimes that's one of the first things that can fall off, is that you're not very equipped to self-advocate. And that's where financial counselling's gold.
Thank you. Thank you, Chair.
Nick.
Thank you very much for appearing in front of the committee and giving us your expertise. Do you have any particular suggestions for us regarding younger people and their access to financial counsellors? I suspect that young adults don't perhaps access financial counselling in the same way that people of my generation think about it and go there. Do you have any?
I think a big problem is awareness. Most people have never heard of financial counselling, or if they have, they don't necessarily think it's for them. I heard someone also talk earlier about the shame and stigma with alcohol and other drugs. You see exactly the same with people's finances. People don't want to accept that they're struggling. For us, if we just go back to submission, would be the same for, we don't see financial counselling embedded, the profession embedded into programs. It sits separately. So I'll constantly see sort of media releases about new programs, new funding, and then when I look into it, there is no financial counselling. It's always expected that that will be referred out. And what we know is if there's a financial counsellor in the mix, part of that sort of case care of that individual, it lowers the myths. That financial counsellor's not going to tell me that I have to stop my cigarettes or I have to stop my vaping. They're going to work with me together. And we just lose a lot of people in that referral, and that would stand particularly for young people. So we do see it. So Vinnie's do have a young people's program where, because they've got financial counsellors, the young people do get soft referred in, and they see some good outcomes. But again, the financial counselling is not part of the program. It just so happens that Vinnie's also has financial counselling on board.
Vinnie's does.
Yeah. So for us, it's about integrating the financial counselling into the program design. And I think in terms of AOD, for us, there's a strong area for it, certainly in rehabilitation, in those sort of where they've almost got a captured audience in terms of what they can do, the one-on-one work, but also the group work, ensuring that when someone's transitioning into rehab, they've made sure they've got everything squared away so they're not coming out straight into the whole hope of debt and creditors chasing them. When they're in there, they can do lots of group work, they can do individual literacy work, and then obviously transitioning out, they know that service is out there for them. They can then revert back for that advocacy that Sarah was talking about to really, relapse is a very challenging thing, and if you've got financial issues, financial hardship, that relapse is going to be a lot closer to home. We know that.
Sure. I know that I've met with someone, a group in my own electorate, which is in Melbourne, which has a fantastic community legal service that has financial counselling embedded in the wraparound services that it affords to people, particularly those escaping domestic violence and things. So this would be a similar sort of model where basically any service that interfaces with vulnerable people such as the ones we're talking about, would be offered financial counselling supports. Yeah, I think that's a great idea. Thank you.
Community legal will do it reasonably well in Australia, yeah.
Can you give us some examples of just how you identify people and how you then refer, and as a demonstration of the kind of the issues that in terms of getting people help, and you know, what's a typical kind of situation that you would see, and do you know, what happens when an alcohol and other drug service refers to you? Do you have that continuity? And
so we're not actually in service delivery as the peak body, but I can certainly speak. Melanie Hopkinson, I keep forgetting to say my name, apologies. We can certainly speak to our membership. There is many doors to financial counselling, and whilst it's a consistent profession, it can look and feel very differently if you're in community as opposed to in the metro area. One of the doors is through the National Debt Helpline, but many people will approach through different avenues, so perhaps through emergency relief, perhaps through community legal services. It's usually those community service areas at the moment where the majority of financial counsellors are found, and that's really what we're advocating, to see financial counselling become more mainstream. In terms of what your typical client would look like, it probably just anybody and everybody, you know. In terms of how AOD is identified, as we sort of highlighted in some of the other work, it is not shown. Often it's put as a co-occurring health condition. It's not necessarily identified. And also, listening to the previous evidence, a lot of frontline workers will not necessarily, a lot of financial counsellors won't necessarily want to go into the AOD use unless they feel equipped to be able to know where to refer to. Many do, but not all of them. Did you want to add to that?
Yeah, so Sarah Holman here. So I have a background, so I did a few years financial counselling before I sort of moved into the policy space. So clients are not presenting with their AOD issues, so they're presenting with financial issues. So it's not always disclosed to a financial counsellor that any co-occurring mental health issues. So it's really about gaining the rapport with the client, and usually they may open up, or if you're looking through trying to troubleshoot something, it will pop up, there's a lot of $20 trips to IGA here, then identifying that they're smoking cigarettes or buying lots of alcohol. And it is through that relationship building that you get with a financial counsellor, then it may be disclosed to you by them. In terms of AOD referrals out, again, it's not a warm referral. It's, hypothetically, if I had a client with me that potentially needed a wraparound service or an AOD service, those pathways aren't always smooth, and they usually are a cold referral. Because we're not embedded in the services, which would be very different in services like RUA or Odyssey, who have embedded financial counselling and AOD programs. So I think that there is the issue. And again, the referrals in from the AOD services to financial counselling, it's the same, just role reversed. So they're cold referrals. We're not getting calls from the caseworker warm referring their client with them. It is call this number. And that's my experience of it, but I dare say that that's probably echoed throughout Australia nationally. Yeah.
Thank you.
Thank you for appearing for our committee today. It's great to have you here. Your submission references the fact that financial stress can be both a driver and a consequence of AOD harm, and I was just wondering if you could elaborate a little bit on that and what any other perspectives you want to provide to the committee on that.
I didn't bring the Venn diagram, I'm sorry.
We can send it through, in fairness. Melanie Hopkinson speaking. I think, as Sarah was alluding to there, it's very much a two-way street, and the fragmented systems are not allowing the co-occurring issues to be case managed appropriately. So if you are using a lot of alcohol or other drugs, often that impacts on your ability to make decisions, on your perhaps on your employment. If you have a real issues with substance use, it's definitely going to impact on your discretionary income, and it's going to make impacts on, even if you can afford it, you're still going to be impacts on family and children, and what money is not going through to the family unit. So there is definitely, very often, if someone's, certainly if they're problematic using, they're going to get to a point where that is going to be impacting significantly on their financial health. And often vice versa, with financial distress, people will use maladaptive coping mechanisms to help them sort of cope with that. And then the unfortunate thing is then if they're sort of using those coping strategies, chances are they're going more into denial, into shame, into not reaching out for help. And what we often see at the moment with financial counselling is it's very much picking people up when they've fallen off the cliff, and we are really passionate about trying to move the profession a little bit more upstream, if you like, to still absolutely vital where it is, don't get me wrong, but we need to see more financial counsellors where people are at. So, for example, in AOD, mental health, I heard the conversation before about the GPs. We'd love to see GPs social prescribing to financial counselling, but we can't push that social prescribing because at the moment there's not enough financial counsellors out there. So we don't want to set people up to fail with huge wait lists. And the other point at the moment with financial counsellors doing fabulous jobs, and I really don't want to take away from this in our organisations, many people will not see taking an appointment at Anglicare or Vinnie's or the Salvos. They'll feel that that is for someone else. You know, that's not for me, that's for someone who needs it more than me. So we really need to go on that journey where financial counselling is a lot more mainstream, it's a lot more understood, the awareness is there. We're seeing that wider and wider demographic. So the National Debt Helpline is reporting a lot more two-income families ringing up the National Debt Helpline, mortgagees ringing up the National Debt Helpline. So the whole demographic of people needing that support is getting wider and wider, but the profession is not expanding in the same way. And the reason be is it's seen very much as programmatic. So it sits within Department of Social Services and it sits within the Department of Community in the state level, and it doesn't go outside of that. So that's that cross-portfolio commissioning that we really need to see, that financial drivers sit across many different areas of government.
So the way we break that cycle is earlier intervention, but we need to build the workforce to be able to support that. Yeah, okay, thank you.
Thanks. And if I can carry on with that discussion, you're saying the workforce actually needs to be embedded, like in a one-stop shop where people are actually being seen in a more holistic way, and financial counselling should be part of that. Because and this is my opinion, and you can tell me if I'm wrong, but I think people are more stressed now than I've ever seen. And financial stress is a big part of that. And are you seeing, is that what you're hearing from your workforce?
Yeah, and there's a very large lack of emergency relief funding at the moment, especially with the crisis in the Middle East. That's just amplified everything for everybody. But definitely it's not getting better. It is getting worse since COVID.
Do you have any data about that you can show us?
We can take that on notice and reach out to our networks. We have limited data available to us at the moment, but Mel might like to add to that.
That is one of the issues around the fragmentation. Us being able to get the data to actually show the recent return on investment. That's why the Financial Council in Victoria did that return on investment research to try and highlight the value, so we can try and boost financial counselling, and then obviously once we've got it in place we can certainly show the outcomes. But a lot of our providers do sort of working under different funding streams, whether it be state or national, trying to get that overall data. And I heard the lady mention it earlier as well with injury prevention. It is quite challenging, and of course government want to see that data to be able to put the investment in, so we do get stuck in.
We're not disagreeing with anything you're saying, but if we're going to do some recommendations, it's always nice to have some data to back it up.
We can take that on notice and pull together what we've got. I know from our own state budget and the federal budget submissions that we made, there are some analyses in there.
Right.
Yes, definitely.
That'd be great if you don't mind. Any further questions? No. Well, once again, thank you for coming. It's actually been very valuable, and even though it's the end of the day, you managed to capture all our attention, so that by itself is a feat. And
yes, appreciate it.
If you have been asked to give us any information on notice, which you have, if you could do it within the next 2 weeks, that would be great. And once again, thanks for your very valuable time today.
Thank you. Thank you.
Good. Now, thank you, Hansard. Thank you, committee. Thank you, Secretariat. And I will now adjourn our meeting until 9 o'clock tomorrow morning.
Thanks, Joe.
Thank you.